So good afternoon, everyone in India, and maybe good morning, those in the West, and good evening, those who are east of us. And welcome you all on the second day of this meeting, CPLD 2020, which you know is a 20th meeting, joint meeting of PGI Chandigarh, Postgraduate Institute of Medical Education and Research Chandigarh, and AIMS New Delhi. We are holding it on a virtual format for the first time because of the ongoing COVID pandemic. The format of the meeting remains the same. We have one moderator, two or three speakers in each session, and we have four or five panelists in each session. The only change today would be that we would request all our speakers to be sticking to their time. We will ring a bell 2 minutes before their allotted time, and second bell when their time finishes, and thereafter the internal moderator may even interrupt verbally to stop you from your presentation. So I think we will request all the speakers to kindly stick to your time. For the moderators, we will request you to kindly be brief in the introduction of the panelists and the speakers, and only if they want to make any comment or ask question the panelist, only then you can allow them. If they are fine with everything, I think it's okay. And the discussion time also, we need to be remain within the limit, allotted time. And again, there would be a bell 1 minute prior to the allotted time for discussion, and then a second bell when the allotted time for discussion is over. So let's start with the first session without wasting any time. And over to you, Dr. Nipun, and you can invite the first, moderator for the session.
Thank you, sir. I welcome all of you. And now I would like to request Professor A.C. Anand, who is a professor and head on Kalinga Institute of Medical Sciences, Bhubaneswar, to please start the meeting on nutritional ethics.
Thank you and very good afternoon to all of you. It's a great pleasure to be part of this academic feat, and I'm grateful to Dr. Virendra Singh and Dr. Ajay Duseja for giving me this opportunity. The first session of the second day is on a very important topic, that is nutrition in chronic liver disease. We have two talks here, and the first talk will be delivered by Dr. Sunil Taneja, who is the professor of hepatology at Postgraduate Institute of Medical Education and Research at Chandigarh, and he's going to talk to us on nutritional screening and assessment in cirrhosis. I'll introduce other panelists and the speakers as we go along.
Good evening, everyone. Am I audible?
Yes, you are audible.
Yes, you are audible.
Slides are visible?
Yes, slides are also visible.
So my job here is to discuss about the nutritional screening and assessment in patients with cirrhosis. Well, we all know that this is the most neglected area. Most of us would not screen our patients in the OPD for malnutrition, just because we are very busy and we have a big line outside our OPDs, and we are always in a hurry to finish our work and complete the patients. So my job here is to just talk about nutritional screening, and I will also discuss about what is the specific screening which has to be done in patients with cirrhosis, and how do you stratify your patients of cirrhosis once they come to you. So let me just start with the goals of nutritional assessment. The primary goal is to identify nutritional risk that influences the morbidity and mortality. And by identifying these risks, you try to modify it with targeted nutritional therapy. And there are some experimental therapies also which are coming up, which might help in improving the nutrition of patients with cirrhosis. The second goal is to allow for the determination of macronutrient and micronutrient state so that you can supplement them and improve the nutritional status. And we all know that we are just working, all of us are working now on body composition and muscle function analysis, which we now label it as sarcopenia or assessment of frailty. And I'll discuss this part in the specific assessment of nutritional status. So as you all know, there is no gold standard for assessment of nutrition. And it is also impractical to attempt detailed nutritional assessment in all the patients in your outpatient department. So what has been suggested is to follow a staged approach. The first step should be a screening in which you begin with a history and a physical examination. And if it is suggestive of malnutrition, then you go on to the second step where a specific assessment is done. It's not moving. Okay, so what is this first steps? If you look at this EASL algorithm, Screen is not recommended in patients who have overt malnutrition or who have a low BMI and child C status. So you don't need to screen them for malnutrition. Straight away, you have to do specific assessment in them. All other patients who do not fit into this category, that is child C cirrhosis and low BMI, should be screened before you do a complete nutritional assessment. So how do you screen these patients? A number of tools have been used. The only problem with these tools is they are cumbersome and time consuming. Out of these 4 tools which are available, the Royal Free Hospital Nutritional Prioritizing tool is the most promising because it is simple and it correlates with the mortality and morbidity also. So what is this Royal Free Hospital Nutritional Prioritizing tool? Again, this is a stepwise approach. You should look at the BMI of the patient. Is there any unplanned weight loss? Is the patient acutely ill or having alcoholic hepatitis, or the patient is on tube feed or not? What is the fluid status of the patient? Is there evidence of any fluid overload? And what is the kind of dietary intake of the patient? So by looking at all this and scoring this, you can stratify your patients into 3 groups. One is the low risk group, the moderate risk, and the high risk group. This high risk group and the moderate risk group needs specific assessment for malnutrition. So one might argument that BMI is not an appropriate tool for assess nutritional status in patients with cirrhosis in view of ascites and edema. But now you have corrections which are available, and you can use either a weight-based correction or a percent-based correction, and this will give you a fair idea of the dry weight and can calculate the BMI. So now moving on to specific nutritional assessment. And before I really talk about sarcopenia and frailty, let me just take you through the definitions of sarcopenia and frailty and try to differentiate sarcopenia from frailty. So this is the first definition which was proposed in 2010 by the European group, and they defined sarcopenia as low muscle mass plus either low muscle strength or low physical performance. This definition was revised in 2018 by the same group, and now they defined sarcopenia by low muscle strength along with low muscle quantity or quality. Here they've included quality also, plus minus low physical performance. So if you have low muscle strength, quantity or quality, then they would label the patient as sarcopenic. So the central point here was low muscle strength and not the low muscle quantity. Why they have included qualities, I am going to discuss in my next slide. The third point is low physical performance, and if it is there, then they have labeled the patient as severely sarcopenic. This is myostitosis, which has been recently introduced, and it is the increased deposition of lipids in the muscle. So this can be between the muscle groups when it is called intermuscular. This can be between the myocytes when it is intramuscular, and within the myocytes it is intramuscular. Why it is important to include myostitosis in assessment is because it has a direct correlation with the muscle strength, and it is also associated with increased mortality. And there's been an association with diabetes and HCC also. So how do you state sarcopenia? Probable sarcopenia is when you have low muscle strength. Sarcopenia is when you have low muscle mass, quality, as well as strength. And when performance is also impaired, you label them as severely sarcopenic. So coming to frailty. So this is a multi-dimensional construct, and it is defined as a biological syndrome of decreased reserve and resistance to stressors resulting from cumulative decline across multiple physiological domains and cause vulnerability to adverse outcomes. Again, here sarcopenia and malnutrition are the central component. So what are the other components of frailty? There can be functional decline, physical deconditioning, cardiopulmonary dysfunction, and even impaired cognition. So this is a syndrome now, what we're talking about. So just to show this slide, are sarcopenia and frailty two sides of the same coin? I completely agree to this. The central component is the physical function impairment. When you look at the patient in totality and you look at all the systems, then you label it as frailty and it becomes a syndrome. When you're looking at the muscles only, then it is sarcopenia and it is a disease, I would say. So how do you specifically assess for sarcopenia? For sarcopenia, you can look at the muscle strength, by the hand grip strength. This is simple and inexpensive method. For muscle quantity, there are a number of ways you can assess, but if you have to look at the muscle quantity and quality, you need to do a CT or an MRI scan. For physical performance, you can look at the gait speed, the 6-minute walk test, chair, and a balance test. And when you include muscle strength with physical performance, then you can label the patient as frail. So if you are looking at muscle strength, muscle quantity, and muscle quality, you are assessing sarcopenia. And if you're looking at physical performance along with all this, then you label the patients as frail. How do you look for muscle strength? You can use a hand dynamometer. As I said, it is a simple, inexpensive, and effective method. And it also predicts the incidence of major complications and mortality. What are the cutoffs which can be used for hand grip strength? These are the BMI based cutoffs. You also have a single cutoff which has been recently defined. If you have a grip strength less than 27 in males and less than 16 in females, then you label them as having low muscle strength. However, the caveat is that these cutoffs have been taken from the European population, and we need to have our normative data for gender and population. So just to show you the impact of low hand grip strength on patients with cirrhosis, this is a study of 100 patients, and they showed that if the muscle strength is decreased, there is high mortality. And they also showed that the muscle strength is low in child C status as compared to child B and child A cirrhosis. A small study available from India in which they assessed the hand grip strength in patients of alcoholic liver disease. And they also showed that hand grip strength is low in patients of cirrhosis as compared to the controls. It is less in patients with child C status as compared to child B and child A cirrhosis. Moving on to muscle mass and quality, CT image analysis, as said earlier, is the best modality. And this is a universally recognized specific method to quantify muscle loss, which is altered by metabolic and molecular perturbations of cirrhosis and is relatively independent of activity and water retention. So how do you calculate this SMI? You look at the total cross-sectional area of the muscles, abdominal muscles at L3 vertebrae, and normalize to height to calculate it in centimeters per meter square. As I said earlier, for hand grip strength also, all these measures require normal values which are based on age, gender, and ethnicity. So you need to derive your own population-based methods. The other advantage of CT scan is you can assess the myocytosis also, which can be calculated based on the Hounsfield units. Fat is 100, water is 0, and muscle is taken as 50. So if you see this figure here, the red one is the muscle, the yellow is the fat, and white one is the water, which you can differentiate based on the Hounsfield units. So the cutoffs which are used for defining sarcopenia, it is primarily used as 50 and 39, and this was based on a large multicentric study from North America in which 396 patients were included, and they showed that there is a significant difference in survival between the sarcopenic and the non-sarcopenic patients. So various cutoffs have been used, and this has been based on ethnicity. People have also derived BMI-based cutoffs. The earlier cutoffs were 52 and 38, and people have also used 53 and 43. The central point of all this is that overall the prevalence of sarcopenia is pretty high, and the predictors of sarcopenia in all these studies were male sex, alcoholic liver disease, and low BMI. There is some normative data on sarcopenia from Indian population, and this is by Dr. Sidhu's group from Ludhiana. What they did was they assessed 3,000 non-cirrhotic patients who underwent abdominal CT scan, and they calculated the mean CT SMI, which was 44 for males and 41 for females. They also looked at the hand grip strength, which was 35 in males and 25 in females, and they also saw the gait speed and chair stand test. Another study from Dr. Sareen's group, and here they saw that the SMI in healthy controls was around 51 as compared to alcoholic cirrhosis where it was 47. And this study also showed that SMI was low in decompensated cirrhosis as compared to compensated cirrhosis and healthy controls. So just to summarize the modalities which are used for assessment of sarcopenia, you can use DEXA scan and bioelectrical impedance. You can use an ultrasound also, and anthropometry can also be used. However, the gold standard is CT and MRI. So I'll just quickly go on to assessment of frailty. These are the various frailty scores which have been used. Freed's frailty score and CFS are subjective, but now people prefer using LFI and short physical performance battery. And if you do not have time, simple tests are 6-minute walk test and gait speed. How do you calculate this LFI? You need to look at the grip strength, the chair stands, and the balance. And if it is more than 4.5, you label the patients as frail. This has been derived from this study by Jennifer et al. From US, where they saw that the statistics for MELD was 0.8, for frailty it was 0.6, and when you combine the both, it was 0.82. In the same group also showed that frailty affects and improves after transplant. And in this study, they took 214 patients where they saw that there was worsening of frailty at 3 months. It became similar at 6 months, and it improved at 12 months after transplant. The second score which is being used now is short physical performance battery. You look at the balance test, the gait speed, and the chair stand test. And if it is less than 10, you label these patients as frail. And this was again the study by Jennifer et al., which they showed that this is a dynamic process. The frailty continues to worsen over a period of time. And as the patients keep waiting on the waiting list, they tend to die or become more frail, and the outcome of transplant is not good if they are frail. Gait speed is a simple test which you can do in an outpatient setting. I'm not going to the details, and 6-minute test we all know can be done in your outpatient. So just to show you our data, 116 patients were assessed for frailty, and we looked at the different scores. The prevalence of frailty was around 45% in our studies. And not only did frailty correlate with the number of patients who were hospitalized, but it also correlated with the deaths. Just to summarize now, the algorithm which I showed in my first slide, if you have cirrhosis, if they're child C, or if they are having low BMI, they are high risk, you need to do specific assessment. Here they've added sarcopenia. I would also add frailty here. In all other groups, you need to do a nutritional screening by using the Royal-Free Global Assessment Score. And if they are moderate or high risk, then you have to do a specific assessment. If they are low risk, you can just follow these patients. Just to conclude now, assessment of nutritional status should be done in all patients. Sarcopenia and frailty are inherent components of this. Sarcopenia can be diagnosed with CT and MRI, and hand grip strength can be used as a simple method to detect the strength. Frailty can be assessed by LFI and short physical performance battery, which are quick, safe, and reliable tests. Thank you very much for your patient listening.
Thank you, Dr. Taneja. We will have the questions combined after the two talks, and my pleasure to invite Professor Anup Saraya, who is Chief of Gastroenterology and Human Nutrition at All India Institute of Medical Sciences, and he's going to talk to us on the management or treatment of nutritional treatment in the decompensated cirrhosis. Dr. Saraya, please.
Good afternoon, everybody. So I'll be discussing nutritional support in decompensated cirrhosis.
Sorry to interrupt. Can you make your slides on slideshow?
Yeah, you did it. You did it.
It's okay.
It's visible now?
Yeah.
Yes, sir.
Yes. So as you know, the malnutrition is defined as per the present guideline as undernutrition. But for cirrhotic patients, these may be overweight also, or may have obesity as well, especially those who are having NASH as the cause of cirrhosis. So muscle mass depletion may also occur in these patients, but due to coexisting obesity, this may be overlooked. So obesity and sarcopenic obesity may worsen the prognosis of patients with cirrhosis. As we know, the malnutrition is present in 60 to 90% patients of decompensated cirrhosis. and the fuel dynamic or utilization or energy metabolism in liver is deranged. In patients with cirrhosis, there is a significantly decreased carbohydrate oxidation and increased fat oxidation. This pattern of fuel use in patients with cirrhosis resembles that in starvation. And what happens? There is accelerated starvation. So the changes which we observe in a normal person after 3 days of fast develop in a cirrhotic after an overnight fast. So we have to give adequate calories, prevent fasting, and especially skipping of meals. So when there is accelerated starvation, there is gluconeogenesis and generation of amino acids and aromatic and branch chain amino acid in the muscle. Muscle can utilize branch chain amino acid due to localization of branch chain keto dehydrogenases. There is rapid consumption of branch chain amino acids in the muscle, and circulating level of branch chain amino acid goes down. That leads to activation of adaptive response and autophagy, leading to proteolysis. Then activation of amino acid deficiency sensor lead to stimulation of or phosphorylation of eukaryotic initiation factor, which inhibits protein synthesis. So there is decreased synthesis and increased proteolysis, leading to sarcopenia. So coming to the nutrition requirement, generally we require 30 to 35 kilocalorie per kg dry weight body weight, and 50 to 60% calories as carbohydrate, 20 to 30% fat, and rest as protein, that is 1 to 1.5 gram protein per kg dry weight. This estimation of dry weight has already been discussed. So for maintenance, we need 30 kilocalorie, and for improvement in the body weight, 35 kilocalorie per kg per day. The energy expenditure, resting energy expenditure multiplied by 1.3 gives us the total energy requirement, and correction for ascites has already been discussed by the previous speaker. So what are the new principles of management? We avoid, especially in those who are obese or overweight, we avoid hypomobility in cirrhotic patients, and then implement a nutrition and lifestyle program to achieve a progressive weight loss, that is 5 to 10% in obese cirrhotic patients. If BMI is more than 30 kg per meter square, correct it for water, and adapt it moderately hypocaloric, that is less than 5 to 800 calories of the normal calories which person require, including an adequate amount of protein to achieve weight loss without compromising protein stores in the obese persons. What are the common misconceptions in dietary advice in cirrhosis? That the high protein intake may worsen encephalopathy of cirrhotic patients, or cirrhotic should not consume fat, and herbal products are safe and there is no harm. These are misconceptions. Another thing which we have noticed in 342 patients, that diet intake based on dietary restriction, when we were advising only salt restriction, but these patients were not taking even oil and other things, spices as well. So this was self-imposed. So in spite of unpalatable food, nutrient intake of these patients with self-imposed restriction was found to be similar as patients with prescribed salt restriction. And during nutritional counseling, self-imposed restriction should be discouraged. And what we have observed, that as the severity of disease increases, the nutrition means calorie intake also decreases. We know that insufficient protein intake will lead to increased mortality. So patient consuming less than 8 to 1.2 gram protein per kg per day had a comparable mortality, and highest mortality was seen in patients consuming less than 0.8 gram per day. So old school of thought used to say that during symptoms, all dietary protein should be stopped, and only with clinical recovery 10 gram increment should be introduced. This is, I am quoting from Sheila Sherlock test book, as tolerated by the patient to a limit of 0.8 to 1 gram per kg per kg body weight. This concept of protein restriction was followed from 50 to almost 2004. And why we modified our opinion? Because there was high prevalence of protein energy malnutrition in cirrhotics, and severe malnutrition as well as presence of depletion in lean body mass was reported, independent prognostic factor in survival of patients with liver cirrhosis. The major metabolic alterations are substrate utilization is altered, rapid transition to gluconeogenesis even after a short starvation. Diet alone was unable to achieve a positive nitrogen balance, and protein refeeding is able to induce a significant increase in protein synthesis. So what are the recommendation in HG? At present, the use of serum ammonia level as an indicator to initiate protein restriction should be discouraged because of a lack of correlation between ammonia and encephalopathy and high protein needs of the cirrhotic patient previously described. So these are the recent recommendations. We don't advise restriction of protein. As far as fat in the diet is concerned, around 30% of calorie intake should be supplied as fat, and lipid restriction has no scientific basis. Fat make the food more palatable and help to combat anorexia in these patients, and without fat, the patient may be deprived of fat-soluble vitamins. So there is no need to restrict fat. Now coming to the concept of late evening snack. Post-absorptive state is longest between dinner and breakfast. So this is the best opportunity to reverse anabolic resistance. A late evening meal limit the overnight fasting period and prevent progression of early onset of nocturnal gluconeogenesis. So what are the recommendations? That in patients, a nocturnal feed between 9 p.m. to 7 a.m. with 710 kilocalorie, of which 26 gram protein, 475 ml of drink, and having 53% of carbohydrate, 15% protein, and 32% fat may be given. Then the review of 15 studies has shown that intervention to reverse anabolic resistance in sarcopenia with improved quality of life in patients with cirrhosis and long-term benefit and improved survival need critical evaluation. But all these studies were highly heterogeneous, and we cannot, in fact, we should not draw any meaningful conclusion from these studies because supplement was regular food, branch chain amino acid, carbohydrate, ensure, rice ball, casein, and calorie intake was from 149 to 710 calories. Time period was also variable and duration was 2 weeks to 12 months. So there was marked heterogeneity. So when nutrition therapy be initiated and which route? Oral diet should be preferred over antral or parenteral in critically ill cirrhotics. If oral intake is not possible, early antral, that is within 48 hours, critically ill patients should be performed or initiated rather than delaying antral nutrition. In case of contraindication to oral or antral, parenteral nutrition should be supplemented after 3 to 7 days. Early and progressive parenteral nutrition can be provided instead of no nutrition in cases where antral nutrition is contraindicated. And to avoid overfeeding, early full antral nutrition and parenteral nutrition should not be used in critically ill patients, that is, those with decompensated cirrhosis and in ICU. Coming to the sarcopenia, because that is also an important component, when nutrition, which this I have already said, why it is important? Because this is associated with higher rate of complications, susceptibility to infection, hepatic encephalopathy, ascites, and lower survival. This is how it is regulated, means the muscle metabolism is regulated. There is protein synthesis. Myostatin inhibit this protein synthesis, and ammonia upregulate myostatin. There are two pathways, ubiquitin proteasome pathway and autophagy pathway, which lead to protein breakdown, and there is muscle loss. These are the various ways of how we can intervene, and anabolic resistance and dysregulated proteostasis can respond to supplementation. In fact, we can lower the ammonia level, we can give myostatin antagonist, we can give branch chain amino acid as an anapyrotic agents, we can supplement nutrition, so to increase muscle mass. Prevalence of cirrhosis by DEXA, this is our own data, we can extract. So these are the various studies in which what they have shown that change in skeletal muscle mass have been strongly correlated with adverse clinical outcome, and change in physical fitness have been strongly correlated with adverse clinical outcome. So muscle mass and fitness both are important. Now coming to the role of branch chain, promote protein synthesis in muscle by stimulating mTOR signaling pathway. They will prevent the inhibition of protein synthesis by inhibiting the amino acid deficiency PCN2 and reversing ELF2A phosphorylation. In skeletal muscle, branch chain amino acid stimulates synthesis of glutamine from glutamate, and that also is an active and alternate pathway for ammonia detoxification. Who are protein tolerant, vegetable protein or branch chain amino acid should be used by oral route, and long-term oral branch chain supplementation should be prescribed in patients with advanced cirrhosis in order to improve event-free survival or quality of life. In sarcopenia, what we have observed that branch chain supplementation alone increases muscle strength and not the muscle mass. This, in fact, these are various studies in which branch chain amino acids are, the role has been assessed, and there are conflicting results. This is a randomized. This is a meta-analysis of 16 randomized controlled trial in chronic liver disease with hepatic encephalopathy, and here they have shown that branch chain amino acid has a beneficial effect on the HE, no effect on mortality, quality of life, or nutritional parameters. So, what are the guidelines that in EASL they say that standard nutritional regime can be utilized in critically ill cirrhotic patients, since no advantage has been shown for a specialized regime in terms of morbidity or mortality, and preoperative nutrition utilize standard nutrition regime. A special regime like branch chain amino acid or immune enhancing has not been shown to improve morbidity or mortality in those patients. These are the ammonia lowering agents. We can skip this slide. Now coming to role of exercise in the nutritional management. Also, exercise in cirrhotic improves the metabolic syndrome, sarcopenia, cardiopulmonary endurance, quality of life, and pressure gradient. So physical activity level in cirrhosis are low, with 76% of waking hours spent in the sedentary state. And three-step process involved: screening to minimize exercise-related adverse events, baseline physical capacity assessment, and exercise program with monitoring. Despite the lack of evidence in reversing severe sarcopenia and frailty with exercise, cardiovascular rehabilitation exercise and patient benefit from these exercise training. So when we conducted a survey, 87% of hepatologists, they recognize the importance of exercise, and these are the various exercises which can lead to, means aerobic will lead to improved physical fitness, resistance training will lead to reversal of sarcopenia, and balance and stretch will lead to reversal of frailty. These are the various studies which has been done, and the combining exercise with nutritional intervention increase muscle strength, insulin sensitivity, improvement in TNF alpha, beta-gluconectin, and physical fitness. Now coming to micronutrients. This is our own data in which we have shown that zinc, vitamin E, and vitamin A levels were significantly lower in patients of cirrhosis, 350 cirrhotics, and micronutrient deficiency progressively increases as CTP class advances. Then vitamin D was also low. This is again in 346 patients. We have noticed that they were vitamin D deficient, and we have given supplementation and assessed them after a period of 1 year. This was a randomized trial, but there was no significant change in both arms in level of calcium, TSH, PTH, insulin-like growth factor 1 or BALP, and improvement, or there was no improvement in quality of life. These are the guidelines which clearly says that if this is normal, T-score is less than -1.5, we can give calcium and vitamin D. If it is in the osteopenia range, then we can give both along with bisphosphonate, and we can repeat the DEXA after 1 to 2 years. And in osteoporosis, the score is less than -2.5. We can repeat it after 1 year, and newer agents can be tried. As far as salt is concerned, hyponatremia is common in patient cirrhosis and more likely when sodium intake is low with water unchanged or increased. Careful monitoring of sodium and water intake is required. Cirrhosis with ascites, we give sodium restriction and take care to improve dietary palatability. And recommended daily intake is 2 grams per day of sodium corresponding to 5 grams salt added to the diet. Moderate salt restriction may be recommended. So these are the guidelines which I have already told you. Now the immunonutrition, coming to immunonutrition, these are the 3: glutamine, arginine, and omega-3 fatty acids. These have been tried. The major fuel for glutamine is a major fuel for enterocyte, and arginine it's a potential source of nitric oxide in macrophages, and omega-3 fatty acids, they modulate the state of inflammation. So possible mechanism of immunonutrition in cirrhosis, there is alteration in gut permeability, reduced generation of eicosanoids, and enhanced antioxidant properties, but none of these mechanisms have been formally tested in chronic liver disease in animal or human studies. These are the various studies, and in which, in fact, only one large study, a large randomized controlled trial of 101 patients, but there was no significant difference. So as far as guidelines are concerned, there are no recommendations for the use of immunonutrition in patients waiting for liver transplant or otherwise also in chronic liver disease. Now supplementation, now I'll take 3 conditions like alcoholic hepatitis. This is again meta-analysis of 7 randomized controlled trial, and there they showed that HE showed a significant improvement or resolution if nutrition was given In alcoholic hepatitis and severe acute hepatitis, nutritional support should be provided to accelerate resolution of hepatic encephalopathy and improve survival in patients with caloric intake. And complete abstinence of alcohol is a must. In presence of deficiency, supplement should be provided. Now, we have conducted a survey in patients with GI bleed, and there were 272 respondents globally. So first question was, do you follow the recommendation of systemic fasting for 48 hours after an episode of acute bleed? 63% told that yes, they recommend that. 63% said no, they don't recommend. And then the objective nutritional assessment as a part of bundle of care, 64% said no. Then again, we posed another question. Will early initiation, that is within 12 hours of normal feeding, have an impact on the management of varicose bleed? 50% responded by saying that may be beneficial. And those who were saying no, and why do you think that early initiation of feeding can be harmful? They have 37%, and they have no deleterious effect of early illness, and rest said that increased portal pressure or affect mechanical, the nutrition may have a mechanical effect by removing the band. So these were the answers we got. Then the meta-analysis, which was published, and including 5 trials and 313 patients of early enteral nutrition versus delayed enteral nutrition in gastrointestinal bleeding, that clearly showed that mortality remained unaffected, no significant difference in rebleed, but hospitalization time is reduced. So what we recommend that patients who are at low risk for rebleeding can be fed early and discharged early. So what are the guidelines for that? Withhold enteral nutrition for 48 to 72 hours after acute bleed due to risk of increased portal pressure and rebleed. NG tubes are not contraindicated in patients with non-bleeding esophageal varices. Avoid PEG insertion. This is EASL 2019. And then early enteral nutrition within 24 hours of bleed may reduce hospital stay without higher risk of rebleed. After treatment of bleeding, patient at low risk for rebleed can be fed early, and parenteral nutrition may be considered in those with prolonged period of poor oral intake, refractory to recurrent bleed or associated paralytic ileus. Protein restriction is usually not advisable, but may be considered in those with refractory bleed and persisting hepatic encephalopathy. Now coming to hepatic encephalopathy, energy requirements are same as those of cirrhotics. We avoid protein restriction in patients with hepatic encephalopathy, and protein intake should not be restricted, but preferably enriched by vegetable proteins or dairy proteins. These are the guidelines by EASL and INASL. In severe hyperacute disease with HE and highly elevated arterial ammonia, the risk of cerebral edema, nutritional protein
Sir,
can
if
be
you could just
deferred.
summarize, we are crossing the time.
What, sir? Time is over?
Yes, time is over.
Okay.
Kindly
So this is the last slide. So what is the prescription? Abstinence from alcohol, diet 1.2 to 1.5 gram of protein per kg, total 35 to 40 kilocalories, and intake per day. Suggest late evening snack and early breakfast. Supplement branch and amino acid. Use tube feeding or parenteral nutrition in critically ill patients. Zinc, vitamin D, and other micro deficiencies to be corrected. And exercise regime should be there in the management. Short practical dietary advice for bedside or outpatient clinic. Healthy eating. Alcohol should be avoided. Adequate amount of calorie and protein. Split food into 3 main meals and 3 snacks. Eat as many fruits and vegetables as one can. Less salt. And patients with liver disease may have hepatic encephalopathy, which may make them tolerate animal protein less. And so vegetable protein intake should be encouraged. And patients with liver disease have other diseases as well, for example, diabetes or other overweight or obese, so that dietary adjustment should be made for these conditions also. Thank you.
Thank you, Dr. Saraya. You can stop sharing your screen so that we can have all the panelists also available on screen. We have 4 very elegant and very expert panels available to us. I have 6 questions already with me, and I will start by asking first question to Dr. Setu Babu, who is the Chief of Gastroenterology at Krishna Institute of Medical Sciences in Hyderabad. Dr. Setu Babu, what do you think? Dr. Taneja has listed about 25 tests to be done for nutritional assessment. How much is practical to do? And in a private hospital, for each test, the patient is also going to pay. So is it really required to do so many tests?
I think there is a very important answer in your own question. Let me thank Virender and Ajay before that. I think what we did was there is a thesis which was done by one of our residents. We analyzed 141 patients. And what we do regularly for all these people is just do a hand grip machine when they come to the OPD. And that would reasonably correlate with the child status and outcome and all. So I guess this is a very simple machine which you can, tell even one of your nurses to do the hand grip as one of the important things. There are taking the advantage, if you can, and one more minute is the anorexia is very important in these people, and that also correlates with the improvement as and when he improves. The other comments I'll make it later. So I guess hand grip is the best one.
So second question I have for Dr. Manisha Dwivedi. She is the head of Department of Gastroenterology at MLN Medical College, Allahabad. And I want to ask you, the BCAA, the branch chain amino acids which have been mentioned, they are very expensive to give for people who can't really afford it very much. Are there any foods available where BCAA are rich? You can unmute yourself and answer the question.
Basically, coconut oil is rich in branch chain amino acids and can be used as a supplement.
That is the basic thing. Dr. Saraya, would you like to add anything on this?
Dr. Setubabu want to say something. He has raised his hand.
Yeah, we actually ask patient to take a lot of coconut scrapings to be added in the diet, and that would help them a lot.
Okay. The third question is the recommendations that have been made. The third question is for Dr. V.K. Dikshit. He is the
Yeah.
Chief of Gastroenterology at Banaras Hindu University, Varanasi. And the question for him is intermittent fasting in patients with NASH or compensated cirrhosis. People who are obese. These days, there is a fad that intermittent fasting, one can lose weight quite a bit. So, is it recommended for patients with NASH?
Yes, because NAS, as you said, obesity is one of the important factor, and at least the person should reduce actually 10% of the weight actually, and this is the diet is the important component which we always advise, and the exercise. These are the two important components. So like intermittent fasting, and because ultimately the total caloric requirement should be less. They should eat less and their caloric requirement should be less. So I think intermittent fasting will be definitely beneficial in the patient NAS with the obesity.
Okay. Dr. Saraya, would you like to add anything?
I would say rather to decrease calorie intake by 500 to 600 calories per day from their requirement. And then we don't think, at least I don't think that this prolonged fasting will help. Because if a patient is fasting for long, then muscle will be utilized for, for energy. So they will end up losing muscle mass. We have to, in fact, discourage this. They should take at least 6 meals. Total calorie intake should be less, and protein intake should be more. So emphasis should be that they should take more of protein, less of calories, and divide it into 6. In fact, there is no need of going for intermittent fasting, even if you have to lose weight, especially in a chronic liver disease patient.
Dr. Setu Babu, would you like to say anything?
Yeah, a couple of comments with all you people around. Those people who are alcoholic liver disease, when we gave them enzyme supplementation very randomly, I wouldn't say that this is correct, but they improved nutritionally very well because we guess some of them have subclinical pancreatic enzyme deficiency, which may not be overt. The second thing which I want Professor Anup to also comment that when we started giving albumin on a weekly regime over the last 2 years, this made some difference. Does he agree that there is some impact of giving them weekly albumin?
Albumin in a cirrhotic may help in those who are having ascites. So albumin as such will not help as far as building up if you're trying to build up nutritionally a person with chronic liver disease, in them probably albumin will not help to that extent.
And I won't call really giving IV albumin as a nutritional supplement.
No, it is not. It is not.
Because when you do a global assessment, they started improving. Maybe it's all overall.
My next question is for Dr. Atul Sood, who is Chief of Gastroenterology with Armed Forces Medical Services. And the question for him is there really any evidence that decompensated cirrhosis patients will improve by improving their nutrition?
So there are some studies which have come in the last 2-3 years which have shown that the difference in mortality and morbidity between child A, B, and C is different. And that is in addition to the MELD score or the child score, the nutrition has itself been different. Wherein the mortality is much higher in those patients who are sarcopenic with the same child score and a same MELD score. And if you have shown improvement in the nutrition of such patients, the mortality and the morbidity has reduced. The hospital stay, the infection rates, all have been reduced in such patients.
So even if we should give them tube feeding.
Yeah, very true, sir. In fact, that is what I was going to come to, that even in alcoholic cirrhotics who come with acute alcoholic hepatitis or decompensated cirrhotics, we tell them to take oral feeds, but they are not having appetite, they're not able to eat. So although we are giving a prescription of 2,500 calories, but he is not able to take. The nursing staff is not able to ensure. But if you give a rice tube feed and you give 200 ml 2 for 2,000 ml, you can achieve a calorie content of almost 2,500 calories to 3,000 calories. And herein we can add on 6 eggs and 100 grams of cheese, cottage cheese, which increases the protein content by almost 30 to 40 grams and adds on about 500 calories. So a normal diet added on with this over a rice tube feed.
Okay, Dr.
This is what practically we tend to do.
Anything you would like to mention, Dr. Saraya?
See, first we have to make an assessment of the nutrition of that patient. If patient is decompensated, severely malnourished, we should be careful in giving nutrition at that rate. Because if patient is sarcopenic, emaciated, not taking adequate calories for say for more than 2 weeks, and we start with an aggressive therapy, we may end up precipitating refeeding syndrome. So we should be a little careful in dealing with critically ill cirrhotics, those who are malnourished and sarcopenic. We can build up nutrition gradually. We can start with small dose. Slight undernutrition for 3 days or 4 days will not make that much of difference. But we should avoid precipitating refeeding syndrome. So we should be guided by their phosphate level, magnesium level, sugar level, everything should be taken into account before embarking on this path of giving 2,400 calories. You see, we can start with lower calorie intake that is permissive under nutrition in critically ill cirrhotics. And we should not go for very aggressive therapy in the beginning. We can build up over a period of time. In initial 3 to 4 days, we should give very small quantity, and then over a period of time, over a week, we can gradually build up.
Thank you, Dr. Saraya. We have very little time left and 2 more questions have come. One question
Can
is...
I make a comment? Dr.
Yes.
Anand, can I make a comment?
Yes, what
because
is
we are running short of time, so we'll have to finish it fast.
Okay, 2 quick questions. One for Dr. Manisha Dwivedi. Is keto diet recommended for patients with NASH and obesity?
I don't think that is useful for these patients. It might worsen the nitrogen balance further.
Dr. Saraya, any comment? Dr. Sareen is also there. We can ask him also. What is his opinion? You can unmute yourself, sir.
Well, I enjoyed the nutrition session, very educative. Three small comments. And finally, Manisha said what should have been sent, the nitrogen turnover study. And that is a very important part. All cirrhotics are in negative nitrogen balance and should be converted into normal or positive nitrogen balance. So the assessment must be made. As far as ketogenic diet, I'm not sure, but yes, lipids are very useful. And as liver takes 80% of its energy from lipids during decompensation. And thirdly, for branch and amino acids, my choice would be walnuts. This is a paper by Jaime Bosch in Hepatology 2012. 43 grams of walnut prescribed every day for patients with decompensated cirrhosis. Thank you.
Thank you, sir. The last question I have very quickly, what is the software used for assessing myosteatosis? And I like Dr. Sunil Taneja to answer this, and where it is available, because people in the periphery probably do not have this software available to them. So Dr. Sunil,
Yes, sir. Sir, it's not easy to measure myostosis actually, and this is being done by MRI or triple phase CT, for which you need a special software, and that is a costly software, sir. It's not available routinely, sir.
where is it available?
Sir, it's available in tertiary care institutes only right now.
So with this, I think I'll close this first session. I'd like to thank both the speakers who gave very informative talks, and to all my panelists who have added to the knowledge which they were trying to impart, and all the questions have been very elegantly answered. Thank you very much, and we close the session.
Okay, so for the next session on the complications of cirrhosis, I would like to invite Professor Saraswat, who is the head Department of Gastroenterology at SGPJ Lucknow, to please moderate the session and invite the speakers and panelists. Saraswat, sir.
Good afternoon, everyone. It's a great pleasure to be again part of CPLD, which is with looking at all the comments, and the participation is doing just as well, in fact, better online than it used to do when we had face-to-face meetings. And it's also wonderful to see all the panelists already in, Professor Serene, Professor Paolo Angeli, my Virinder is there in the hall, and Manav is right at dead center of my screen at the moment. And all the panelists have also logged in. So I think without further ado, we move on to the next session, a very important session on the complications of cirrhosis. And the first talk in this series of 4 lectures will be delivered by none other than Professor Shiv Sareen. I will not be presumptuous enough to try and introduce him. I think Professor Sareen is a legend not only in India, he's the doyen of hepatology for all of us who are practicing hepatology in India. And sir, we look forward to listen to you on your lecture on acute and chronic liver failure. What is new? Professor Sareen, sir.
Thank you. Are my slides visible?
Yes, they are indeed. You could go full screen, sir.
Thank you,
yes, they are full screen.
Dr. Viren Singh and Ajay, and for inviting, and Dr. Saraya for this interesting CPLD I heard. Thanks, Vivek, for your kind words. I bring greetings from ILBS, and our residents for 3rd year in a row ranked 2nd to AIMS Delhi in scholastic output. Now, what is new? Every day ACLF is new. This is the 2019 definition that we had, just for people's memory, that acute liver failure or a decompensated cirrhosis, they are not part of the definition that we consider. However, what we consider is patient who has underlying chronic liver disease or has cirrhosis of liver, which can decompensate after an acute insult in several forms. It can be a GI bleed, HE, ascites, HRS, sepsis, or a combination, or just one variant of this decompensation where there is jaundice followed by ascites. And this is the definition with an underlying chronic liver disease or compensated cirrhosis includes homogeneous group of patients as ACLF for us. If you take other variants in the definition by Cliff, there could be 9 to 29 variants, and therefore the endpoints may be difficult to decide. And same can be true for the next cell definition. So this is our basis. I just want to brief you the tale of two definitions that we wrote in hepatology. The two definitions overlap, and I'm happy Paulo is here with us. So the easel starts with organ failure, liver plus others, sepsis, and liver failure could be much later. Other organs can come before. On the other hand, you will have in the puzzle, first will come the liver failure and other organs will come later. And I'll try to show you much more data now on this. So the difference between the apostle and easel definitions is just a golden window of about 7 to 10 days before extrahepatic organs start failing. Unfortunately, in a recent review in NEJM, I was very pained to see when apostle was misquoted by Vicente Arroyo and the group. And they said definition of the APSL is based on the opinions of experts, applies only to patients with non-cirrhotic. This was never the case. We have now more than 7,300 patients and several prospective studies. And I'll show you 3 accepted, published in hepatology itself. So therefore, we need scientific honesty. Let's look at the new data, assessment of severity and use of lactate. Apostle published this, very important, that liver is the driver. Jaundice, coagulopathy, encephalopathy, and lactate. These are the primary drivers before the kidney goes down. This is the ARC score, which was also published in JHEP. It shows you that patients who have a high bilirubin, high INR, high lactate, and a creatinine, even if it is less than 1, will give you a score which is 11. If this is a score, then a patient may be quite sick. Such patients may die. A score of 11 this is the first liver failure score in chronic liver disease. You have in ALF, but not in ACLF. And this score of 11 means this guy will die. Now, this score in 4 days' time becomes 13 because his creatinine now becomes from less than 1 to more than 1.5. This patient has a high chance of mortality. And let's look at it. So if there is a dynamic change in score, what is the outcome on 28-day mortality? So if a person has a score at baseline of less than 10, then 1 unit increase from 8 to 9 will increase mortality by 4%. But somebody has a score above 10 at baseline. So 1 unit rise by day 7 will increase mortality. Now, if the score is about 10, then you will see an increase in 7 days will be about 20% more mortality. So within 1 week, you can say this guy has 20% more chance of mortality just within 7 days. This score was compared with Cliff, SOFA, MELD, and Apache, and it shows that this score, the ARC score, has the best predictive value. Now, this was published. Now, and this has an online calculator, which all of us, at least in Asia, use. This beautiful study from China, it has now shown serum lactate levels predict short-term and long-term mortality of HBV ACLF. And it shows you every single score that you can think of, whether it is SOFA, CTP, it is MELD sodium, SOFA, Cliff SOFA, or organ failure score. Anywhere you add lactate and it improves the predictability of the score. Let's now look into second part, high risk patients who can develop ACLF. And this beautiful work from ARC led by Professor Duseja, where we have 2,030 patients, of which alcohol-related ACLF were taken, 1,216, dominantly male, and they had, as you can see, high MELD score. Now, the patients were of 2 categories, those ACLF alcohol with metabolic risk factors, 1/3 of them, and without risk factors. So those who were obese had higher MELD. Those who had dyslipidemia had higher ARC score. Those who were overweight or obese had higher adjusted hazard ratio of 30-day mortality, which was independent of age, CTP, MELD, and ARC. Clearly, this shows that comorbidities add to ACLF mortality. Let's look at some of the treatment and new options of this. First aim is prevention of organ dysfunction. I'll go step by step for 3 organs. ACLF is different from the decompensated cirrhosis. Here it is liver cell death, because of which you release several things, and they lead to systemic inflammation, endotoxemia, increase in nitric oxide, cytokines, and very high bilirubin. High bilirubin itself, high bile acids themselves are hugely vasodilatory and cardioinhibitory. They increase the intrahepatic resistance and many other things. I don't have time. Just to tell you, there is a systemic inflammation, hyperbilirubinemia, hypercytokinemia, rapid increase in portal pressure, decrease in mean arterial SVR, higher cardiac output, and HVPG. So ACLF is a syndrome of acute portal hypertension. This acute portal hypertension causes rapid rise in portal pressure. In cirrhotic, maybe the pressure was 12 or 13, it may go up to 20. And within a period of a week, this patient develops ascites, HRS, GI bleed, and hepatic encephalopathy. And this study, which was done by Sumit, 280 patients, finally, we had HVPG pre and post. One group got placebo, other group got carvedilol. Beautiful study. It shows that patients who got placebo but improved also showed reduction in portal pressure. Carvedilol also showed reduction in portal pressure, both of them. Those who had an HVPG reduction, they had a better survival. I want to show you this single line. In ALF also portal pressures can go up to 15. However, once the ALF recovers, the pressures go down by 8 to 10 millimeter, from 15 to 7. However, in ACLF, the pressure reduction is only 3 millimeter. Let's look at in those HVPG reduced, whether spontaneously or otherwise with drugs, varices did not progress. We also see carvedilol improved outcome, survival benefit. Those who received carvedilol compared to placebo had a better outcome survival. The second paper in hepatology, published last year by Vinod. This is how do you prevent renal injury and PICD in ACLF with ascites. Please remember, ascites in ACLF is anteroposterior, not side to side. It's an acute abdomen. Tense. There are no guidelines for plasma expansion with albumin in ACLF undergoing. And our hypothesis was hemodynamic changes of PICD will appear at a lower volume of acetic fluid paracentesis, especially if it is without albumin. And these patients will develop PICD early. 380 patients, finally 40 received albumin plus TAP. The other group got no albumin plus TAP. And this we defined as modest volume paracentesis. Less than 5, but more than 3. Roughly 4 liters of TAP was done. What you see here, red is albumin. Those who received albumin, they had less hyponatremia, HE, or kidney injury. But otherwise, these complications were common in ACLF despite MVP. If you give albumin, you are better off, but it's still 30% of the people got PICD. Very important data is this. At baseline, you find that their plasma renin activity, normal is less than 4. At baseline, plasma renin activity is 23 to 24. And if it is so, this patient will develop PICD within 3 days. Not 6 days, 3 days you get PICD. To summarize, I don't have much time to say. I will only say high baseline plasma renin activity is a single indicator. Therefore, do only modest volume paracentesis, 3 to 4 liters, and albumin helps, but we have miles to go. Now, how do you prevent kidney injury in ACLF? Now, this is to show you the time in weeks. Sorry, the slide got slightly messed up. After ACLF, you will see in a period of time, the kidney, the brain, and other organs can go down. The spectrum of AKI in ACLF is first as functional, which is volume responsive, and then slowly it becomes non-responsive. And none other than Professor Paolo Angeli and us had made these definitions, and we can discuss that. Important is structural AKI and ATM does develop in ACLF. This was a hepatology paper last year by Rocky. I'm not showing you that. Now, this is to show you that does terlipressin work. This paper was Ankur by Ankur shows response to terlipressin is only seen in 1/3 in ACLF. This is the second paper by Vinod in hepatology last year, where he compared terlipressin versus noradrenaline. And he could show that terlipressin is superior in ACLF with HRS AKI. However, adverse effects were much more. So now terlipressin is superior, but terlipressin only gives you response in 1/3. So we are stuck up with 2/3 of our patients. So let's make this algorithm was published 2 years ago, needs to be revised again. So you have a new AKI, you will give volume, you will give albumin. If it responds, continue, but don't do overload. Functional HRS, if it is not corrected, then give vasoconstrictors. Your chance of success is 1/3. If there is no response, find out early enough, and you may use renal replacement therapies in them. Now we have to look for immune paresis in ACLF. There is limited data. There's one very good paper from PGI by Dr. Makkar and others where he has shown the NLR ratios. I don't have time to show, but just to and you can give GCSF in these patients and you can improve the outcome by neutrophil dysfunction to be converted into good neutrophil function. Now, this is a very interesting paper, which is hopefully under publication now, is to show you therapeutic plasma exchange in acute and chronic liver failure, how it changes the immunity. And because of the bell, I won't be able to deal with this. Liver transplant is one of the very good options. So what is new? We did a survey in our Asian and global region. 85 centers responded. It was dominantly Asia, so a partial definition was used. What I want to show is people did not operate if they had 2 organ failures. This is the last slide to show you management for ACLF, what is new. If a patient has a high MELD of more than 30 or a RQ score of more than 10 and there is no sepsis, patient can go straight for transplant. However, if the patient is improving, at day 4, an RQ score improves, patient can have medical therapy. If it is worsening, then he needs to go for emergency transplant. If the patient at baseline had 2 or more organ failures, plasmapheresis can be done. And if he improves, emergency transplant. If he is not improving, supportive care is the best. I will just like to invite you to 24th of October, where the 8th annual conference of ARC will be done. I do hope you will have 7 new protocols coming up. And with that, thank you all for listening to me. Thank you.
Well, thank you very much, Professor Sareen. As usual, very novel and very intriguing insights into the syndrome of ACLF that we have seen evolve in front of us in the last couple of decades. I think we will reserve questions for the end of the session. And if you could please stop sharing your screen, then call upon the next speaker in this session. Is none other than the chairperson of this CPLD, Professor Virendra Singh, the present head of the Department of Gastroenterology at PGI Chandigarh, and who's done extensive work on the topic, will speak to us about refractory ascites management strategies. Virendra?
Thank you, Dr. Vivek. I'm not head of gastroenterology, I'm head of hepatology.
So
Just
sorry, apologies.
no problem. So in the next 15 minutes, I'll be speaking on the management of refractory ascites. Next, please. Okay. So in patients with the cirrhosis, there is a portal hypertension and there is a splanchnic or the systemic vasodilatation, which leads to the activation of the vasoconstrictor and the anti-natriuretic factors, and ultimately leading to sodium and water retention, causes ascites, and it also causes the renal vasoconstriction and then leading to HRS. And we can intervene at different levels, maybe sodium restriction or the diuretics or LVP or use of tapes or the transplant. A newer therapies, the use of vasoconstrictors, either terlipressin, octreotide, NORAD, or midodrine can be used for the patients with the ascites and HRS. This is the overview of the treatment of ascites as per the ASLD guidelines. The treatment of ascites depends on the cause. Low sec ascites, there is no response to salt restriction and the diuretics except in the nephrotic syndrome. High sec ascites, if there is a history of alcohol intake, you have to stop it. And other treatable causes you have to treat. Then portal hypertension, the basic is the salt restriction and the use of diuretics. Identify the precipitating factors. The most common is the dietary indiscretion and the diuretic non-compliance. There may be a GI bleed, HCC with or without portal vein thrombosis, and this patient may be taking NSAIDs. Sodium restriction is the mainstay of treatment. Sodium intake of 2 grams or 5.2 grams of salt per day is allowed. And the low salt diet only can improve ascites in about 10% patients. The diuretic therapy is very useful and it is required in about 90% patients. And the drug of choice is the spironolactone. However, for the faster control, we can use the combination of the loop diuretic and the spironolactone. And the adverse effects in these patients are seen in about 20 to 40% patients. And if the patient develops any gynecomastia or any other problem, in that case, we can use the amiloride. However, it is little costly. If there is an ineffective diuresis, increase the dose to in the multiples of 100 plus 40. You can make it 200 plus 80, 300 plus 120, 400 plus 160 milligram per day. The urinary sodium excretion, the value is very important in these patients. If it is more than 78, it means there is a adequate sodium excretion. And then spot urinary sodium and potassium ratio, if it is more than 1, that indicates a 24-hour urinary sodium excretion of more than 78 millimole. A negative sodium balance with a weight loss of 0.5 kg per day, more in patients with the peripheral edema, and increased diuretics after 3 days if there is no response. This is the definition of the refractory ascites, which can be a diuretic resistant ascites, which is uncontrolled with the salt restriction diet of less than 90 millimoles per day and 400 mg of aldactone plus 160 mg of furosemide. Or it may be a diuretic intractable ascites when you notice the complications which prevent the use of the adequate doses of diuretics. And these are the definitions. The treatment duration in these patients. Patients must be on intensive diuretic therapy for at least 1 week and on salt restricted diet of less than 90 millimoles per day. Lack of response, when do you call it? Mean weight loss of less than 0.8 kg over 4 days and urinary sodium output less than the sodium intake. Early ascites recurrence, if there is a reappearance of grade 2 or 3 ascites within 4 weeks of initial mobilization. Diuretic induced complications, this may be the diuretic induced hepatic encephalopathy, the development of encephalopathy in the absence of any other precipitating factor, diuretic induced renal failure, if there is an increase in the serum creatinine of more than 100% to a value of more than 2 milligram per dl in patients with the ascites responding to treatment. Then diuretic induced hyponatremia is defined as a decrease of serum sodium by more than 10 millimoles per liter to a serum sodium of less than 125 millimoles per liter. And diuretic induced hypo or the hyperkalemia is defined as a change in the serum potassium of to less than 3 millimoles per liter or more than 6 millimole per liter despite appropriate measures. Once it occurs in about 5 to 10% patients, and once it occurs, the mortality is quite high. The various options in the management of refractory ascites are stop beta blockers, use oral midodrine, then serial therapeutic paracentesis, tapes, liver transplantation, and nobody uses the peritoneal venous shunts, and then you can do the clinical trials using newer therapies. LVP is very effective, and it has been compared in patients the paracentesis versus the diuretics, and in this series, this reduce the hospital stay, and the paracentesis induced circulatory dysfunction is a major problem after the LVP, and this is shown in if you use the plasma volume expansion, then it is seen in about 75% patients. If you use Dextran 40, then it is seen in about 40 to 50%. Even with the albumin use, it is seen in about 15% patients. PICD, it is because the arteriolar vasodilatation, there is effective arterial blood volume. And if you give albumin in the dose of 6 to 8 grams per liter of the fluid removed, then it can be avoided. However, initially there was a problem of transmission of diseases, and this is costly. So we use the vasopressors, combat the vasodilatation, and then prevent the PICD. This was the landmark study done by Maru. In that, he compared the albumin and the terlipressin, and the terlipressin was effective, and it prevented development of PICD. We also did a similar study in which in 40 patients, 20 in each arm, compared terlipressin with the albumin, and this also was equally effective as this albumin. Again, we used the NORAD and then compared the two groups, the albumin and the NORAD group, and the NORAD also was quite effective. But the problem with the NORAD is we have to give an infusion. So we resorted to the midodrine, and it was very difficult to get midodrine that time, but we could manage. And then we conducted a study. This was the original study by Angeli, and he also used the midodrine and then showed the acute effects of the oral administration of the midodrine in an adrenergic agonist on the renal hemodynamics and renal function in cirrhotic patients with the ascites. And this is again study by Paolo. And then we did for the prevention of PICD, and we could prevent development of PICD in these patients by using midodrine. This is another study, the prevention of the PICD and midodrine versus the albumin in a randomized pilot study. 24 patients were randomized to receive either midodrine, and midodrine in this study was not as effective as albumin in the prevention of PICD. This is the meta-analysis by Bernardi, and then he compared the various studies in which they used the vasopressors and the albumin, and he showed that the albumin reduced the incidence of PICD and morbidity and mortality among patients with the tense ascites. However, the vasopressors could not. These are the newer therapies based on the circulatory dysfunction, especially the splanchnic vasodilatation and renal vasoconstriction. The midodrine has been shown to be effective. In another study, midodrine plus octreotide and albumin was used for 1 month in 10 patients with the refractory ascites, and there was a significant reduction in the plasma renin with a better control of ascites, and there was a reversible deterioration in the MELD score. We use midodrine for the control of the refractory or the recurrent ascites, and in the doses of 7.5 mg 8 hourly, and the primary endpoint was the control of ascites. Secondary endpoints were the frequency of worsening encephalopathy, liver and renal function, and frequency of other complications of cirrhosis, or the 3 months of midodrine therapy. And we found that there was a mean arterial pressure increase, cardiac output decreased, SVR increased, urine output and the urinary sodium increased, PRA decreased, and there was no renal or the hepatic dysfunction. And there was a better control of ascites, and there was a better survival at 1 year. However, this is another study in which they use the midodrine for the control of ascites in refractory or the recurrent ascites, 78 patients. In that also, they showed a better effect of midodrine. However, this is a multicentric US study in patients with refractory ascites, and in this, they could not prevent the PICD when they use the midodrine as compared to albumin. We also use the midodrine and the clonidine combination, and the midodrine was effective. However, the clonidine addition was not effective in the control of recurrent or refractory ascites. Then in these studies, see they use the V2 receptor antagonists, and then they conducted various studies. However, they were in phase 3 randomized placebo-controlled study. There was no significant beneficial effect of cetabaptin in the control of ascites. There was increased morbidity and mortality. However, the cause was unclear. So routinely, the V2 receptor antagonists are not recommended for the control of ascites. However, we conducted a study with a combination of midodrine and the tolvaptan in 50 patients, and then in the different groups, midodrine was used in the doses of 7.5 mg 8 hourly, and tolvaptan in the dose of 15 mg 12 hourly. And midodrine, as well as the combination of midodrine and the tolvaptan plus the standard medical therapy, was given in one group, and it was superior to SMT alone, as well as tolvaptan in the control of ascites. The combination therapy was superior to midodrine in the control of ascites at 1 month. So it was a faster control of the ascites. The mortality and the frequency of complications were similar in all the groups except the SMT, in which renal failure was observed in significantly higher number of patients. The long-term administration of the human albumin also improved the survival in patients with cirrhosis and refractory ascites. This is done by Pascali, published in Liver International in 2019. This is a well-known, the ANSWER trial. They looked at the efficacy of the long-term human albumin administration in patients with the decompensated cirrhosis. And it was a multicentric randomized parallel open label trial in 33 Italian hospitals. 431 patients were randomly included. The human albumin group, 40 gram twice weekly for 2 weeks, and then 40 gram weekly for up to 18 months. 38 out of 218 patients died in the SMT plus human albumin group, and 46 of 213 in the SMT group. Overall, 18 months survival was significantly higher in the SMT plus human albumin group than in the SMT group, 77% versus 66%, and it was significant. Hyponatremia episodes decreased. Ascites, cumulative incidence of the first paracentesis and the refractory ascites decreased. This is another study in which they used the midodrine and the albumin, Sola et al. And then 196 patients with the decompensated cirrhosis and the ascites waiting the liver transplant. It was a double-blind placebo-controlled trial, midodrine and the albumin group. And then there was no significant difference in the development of complications or 1-year mortality. So it was, the midodrine was not helpful. Now coming to the tips, the portacabal shunts, these are for the better control of ascites. The disadvantages are the high rate of stenosis. However, recently with the newer stents, this is not so. However, this is little costly. Encephalopathy is slightly higher, lack of availability in some centers, and technical expertise. These are various studies in which they compare the tips versus the large volume paracentesis. And then this is a meta-analysis of 5 studies. Recurrence of ascites after 3 and 12 months lower with the tips. Frequency of hepatic encephalopathy was higher with the tips. Survival, there was no difference in 3, trend towards the reduced mortality in patients treated with tips in 1. Increased transplant-free survival in the tips group in 1. Tips versus the LVP, this is a recent study published in 2017. 62 patients with recurrent ascites, multicentric study from France covered tapes in 29 or LVP and albumin in 33. Survival without liver transplant at 1 year, 93% versus 52%, and encephalopathy was seen in equal number of patients. This is another way of controlling ascites, the alpha pump, the automated low flow ascites pump, and in which they drain the ascites with the help of a pump from the peritoneal cavity to the bladder. And I will not go into the details. These are various studies. However, the efficacy is not yet proven, and there are a lot of complications. So if this is the approach to the management of refractory ascites, cirrhosis with ascites not responding to usual measures, then if you do the diagnostic tab, rule out SBP, or look at the ADA, there may be some patients who may be having tuberculosis in addition, and then do the 24 hours urinary sodium or the spot sodium and potassium ratio. Then you look at the dietary sodium intake and the stop alcohol, NSAIDs or treat etiology, look for HCC, stop beta blockers. And then if this is not controlled, then do the LVP with the albumin. And then if this patient is having low MAP, you can use midodrine, or you can send this patient for the tapes, and you can take use of the long-term albumin. And if nothing works, these patients should be referred for the liver transplantation. Thank you.
Well, thank you, Dr. Virendra Singh, for that extensive overview. Almost every aspect of refractory ascites and an extensive literature review that was presented. I think we'll come to questions at the end of the session with the discussions. So I think we move on now to the next and very important talk in this series from Professor Paolo Angeli, who's from the University of Padua, a very familiar name and a very familiar face to Indian audiences. There has been a lot of ferment in the terminology and nomenclature of acute kidney injury. We are all used to be familiar during our learning DM days with HRS type 1 and HRS type 2, and that was it. But a lot of changes have happened, and most of them have been spearheaded by the International Club for Ascites, led by Professor Angeli. So we look forward to your lecture, sir, on acute kidney injury in cirrhosis, consensus on nomenclature and management. Professor Angeli, sir.
Thank you very much for this kind introduction. But let me thank Virendra and Ajay for this kind invitation. I miss a lot the opportunity to come again to India and to meet all you in person. I hope we can do it as soon as possible. But after my disclosure, I want to start my talk saying that we have had our own specific definition of acute renal failure in patients with cirrhosis. That was an increase in serum creatinine equal or higher than 50% up to a final value equal or higher than 1.5 milligram DL. And this conventional criteria worked very well in prospective clinical studies and also in randomized clinical study. But you know, in 2012, a task force of the International Club of Ascites in a meeting in Venice, where also SHIB was present.
Can you please share your slides? Share the screen.
Professor Angeli, yes, I thought we were prelude. Your
Sorry.
Share screen, please. Yeah.
So this was our previous definition of acute renal failure that I mentioned. And this was the task force in Venice when we decided to change the name and the diagnostic criteria of acute renal failure. I stated that also SHIB was there, but he moved the day before we took this picture. Well, In that meeting, we decided to move to the KDIGO criteria for the definition of what we call today acute kidney injury, AKI. And you know, the diagnosis of AKI is based on two parameters, either the increase in serum creatinine or the reduction of urinary output. Focusing on the first, nowadays we make the diagnosis of AKI either in presence of an absolute increase in serum creatinine equal or higher than 0.3 milligram DL in less than 48 hours, or a percent increase in serum creatinine equal or higher than 50% in less than 7 days. Of course, there is a staging system that is based on the amount of increase of serum creatinine from baseline. So stage 1, less than 2-fold, stage 2 in between 2 and 3 folds, and stage 3 higher than 3 folds. And you know, the staging system is crucial for the prognostic implication of the KDIGO criteria in cirrhotic patients. So if you consider the initial AKI stage, that is the AKI stage at the first fulfillment of the KDIGO criteria, you can say that patients with AKI stage 3 and 2 had the same in-hospital mortality, quite higher than in patients without AKI, quite higher than in patients with AKI stage 1. And finally, patient with AKI stage 1 has a higher mortality rate than patient without AKI. So when we accepted the idea to share the KDIGO criteria, we propose a new algorithm for the management of AKI in patients with cirrhosis based on the initial AKI stage. So if you have an AKI stage 1, you are on the left side of the algorithm. If the patient has an AKI stage higher than 1, the patient stays on the right side of the algorithm. The first patient should be treated as soon as possible with very simple measure, among which also the withdrawal of diuretics and beta blockers. In case of response, everything is fine, but this patient should be closely followed, because even in presence of a transient AKI, there is a significant reduction of survival in the midterm. Why? Because this patient develops more frequently other episodes of AKI during the follow-up. In case of no response or without progression of the AKI stage, any further decision in the management should be decided case by case. In case of no response with progression of AKI stage, the patient move on the right side and should receive the treatment that the patient who were already there had received from early beginning, that is plasma volume expansion with high doses of albumin. In case of response, everything is fine, but again, close monitoring. In case of no response, the patient should be checked for all the other diagnostic criteria of hepatorenal syndrome. If the patient fulfills the criteria, he should receive immediately vasoconstrictor plus albumin in spite of the final value serum creatinine. In case the patient does not fulfill the criteria, it could be treated with other measure when indicated. Well, let me move briefly to the second parameter, that is the reduction of urinary output. Of course, you need a bladder catheter and a flow meter, but the criteria is a reduction of urinary output below 0.5 ml per kilo body weight for more than 6 hours. Also, in this case, there is a staging system that is based on the severity of oliguria or the presence of anuria. So if you have on a regular ward a patient with a bladder catheter and the flow meter, please apply both the criteria, because this will increase your probability to make the diagnosis of AKI, and we also improve the quality of the prognostic assessment in patients with AKI. But up to now, we have only done the first step in the diagnostic process of AKI. The second step is to differentiate among the 4 phenotypes of AKI, so ATN AKI, pre-renal AKI, HRS AKI, and post-renal AKI. So let me say that most cases of pre-renal failure are solved by plasma volume expansion. Post-renal AKI is rare, so the real problem is to differentiate in between ATN AKI and HRS AKI. And what we have our diagnostic criteria for hepatorenal syndrome, from which we deleted only the final value serum creatinine. So nowadays, we make the diagnosis of HRS AKI in a patient with cirrhosis and AKI when it does not respond to plasma volume expansion, so withdrawal of diuretics and use of albumin. He has no shock. He's not receiving a nephrotoxic drug. He has no significant proteinuria, no hematuria, and a normal renal ultrasonography. So the question is, are these criteria adequate to rule out the presence of parenchymal damage and particular tubular damage in cirrhotic patients with AKI? The answer is no, because if you look to a platform of new biomarker of parenchymal damage and particularly tubular damage, you can see that abnormal values are present not only in patients with ATN AKI, but also in those with HRS AKI when compared with those with pre-renal AKI or no AKI. The higher number of new biomarkers with abnormal values you have, the lower probability you have to confirm your initial diagnosis of HRS AKI, and the higher probability to arrive to a final diagnosis of ATN AKI. You know, this finding raises several questions. The first one is, are these biomarkers useful in clinical practice? May they facilitate the differential diagnosis in between HRS AKI and ATN AKI in our patients? The answer is yes. Particularly urinary IL-18 and urinary NGAL seem to be very promising. This is true particularly for urinary NGAL because you can see that there is no much overlap between the value in patients with HRS AKI and ATN AKI. The second question, why there is parenchymal damage even in patients with HRS AKI? The answer is quite simple, because nowadays nobody thinks that hepatorenal syndrome is only related to renal hypoperfusion. There are several other pathophysiological drivers, such as, for example, microvascular dysfunction, direct tubular damage, and overall inflammation. So the other question is, which is the impact of a parenchymal damage on the efficacy of the pharmacological treatment of HRS AKI? And I want to state that the best option we have is to use terlipressin by continuous intravenous infusion plus albumin. Well, the first consequence is that there is only a partial recovery of glomerular filtration rate, even when we state that the patient has a complete response on the basis of the normalization of the serum creatinine. The second consequence is related to the efficacy of terlipressin. This is the grade of systemic inflammation according to the grade of ACLF in cirrhotic patient. You can see that higher degree of inflammation, higher grade of ACLF. Well, you can see that if we evaluate the efficacy of terlipressin plus albumin in the treatment of hepatorenal syndrome in the context of ACLF, the higher grade of ACLF, the lower probability of response for the same value of baseline serum creatinine. There is another consequence. In your country, in 2 small clinical trials, you prove that NORA is an effective alternative of terlipressin in the treatment of type 1 HRS in terms of response to treatment, reversal of renal failure, and overall in terms of 1 month survival. But when you are treating type 1 HRS in the context of ACLF patients, terlipressin is much higher, much effective than NORA in terms of recovery of renal function and in terms of 1 month survival. Why? The answer is obvious. Terlipressin is much better than NORA in the treatment of hepatorenal syndrome because, for example, terlipressin has some degree of anti-inflammatory action that NORA does not have at all. So we definitely remove the old classification of hepatorenal syndrome into type 1 HRS and type 2 HRS. Type 1 HRS is nowadays HRS-AKI. What about type 2 HRS? You know, in the KDIGO criteria, there is not only AKI, there is also acute kidney disease that we can define as a GFR below 60 ml per minute for more than 3 months with or without structural kidney damage. And there is CKD that we can define a GFR below 60 ml per minute for more than 3 months with or without kidney damage. So we have proposed to call type 2 HRS as HRS-NACI. NACI means non-AKI. That means that HRS occurs without the criteria for AKI, and NACI can occur as HRS-AKD if there is a GFR below 60 ml per minute for less than 3 months, or as HRS-CKD if the reduction of GFR below 60 ml per minute lasts for more than 3 months. So let me say that I should remind that we are using estimated GFR, and so any formula we are using will underestimate the real value of GFR in our patient. What about treatment of the old type 2 HRS and now HRS-NACI? You know, terlipressin is very effective, like in patients with the HRS-AKI. The problem are the high rate of recurrence. In addition, there is some controversial data on the final outcome, for example, an improvement of transplant-free survival, but not an improvement in post-transplant-free survival. So let me summarize what I said. AKI is frequent in cirrhotic patients. The KDIGO criteria should be used for the diagnosis. A new algorithm should be applied for the management. Definitive removal of any cutoff value serum creatinine beyond which we should start the treatment. In the differential diagnosis in between HRS-AKI and ATN-AKI, some new biomarkers may be useful. And terlipressin plus albumin is the best treatment for this severe complication. Thank you very much for your attention.
Thank you very much, Professor. Taking us over complicated, very changing terminology so elegantly in the last 15 minutes. So now we move to the last talk in this series of 4 lectures, and I will invite Professor Dr. Manav Vadhavan to talk to us about refractory variceal bleed. What is the consensus management? Manav is a senior consultant at the B.L. Kapoor Memorial Hospital, a well-known figure in gastroenterology circles in India, and I've always enjoyed his crisp and to-the-point presentations. So Manav, the floor is yours now.
Thank you, sir. I must congratulate the PGI team for this brilliant meeting, and also thank you for inviting me to talk upon this such an important topic. Now, we have 2 extensive consensus documents available on refractory variceal bleeding. We have EPASL guidelines, and we also have Baveno 6 as of now. Our own ISG also formed a task force on varicose bleeding, and that also paper should be out very soon. That's under peer review now. What I've done in this presentation is I've taken all three together, try to sort out their differences from each other, and to give you actionable evidence of what to do when you see a refractory varicose bleeding. So let's hope I can come up to the task. First question is, what is the refractory varicose bleed? So upper GI bleed, which is either persisting or recurs after even despite a therapeutic endoscopy, that is a refractory varicose bleed. There is no standard term in any guidelines, in any consensus as refractory varicose bleed. So we have to define a refractory varicose bleed as per two criteria. One is the timeline. That means after in how much time from the index varicose bleed, the next bleed happens. So let's say a patient comes to you in emergency with a varicose bleeding, you do endoscopy and you're not able to control the bleeding. That comes under failure to control bleeding. If the bleeding happens within 48 hours, even that is failure to control bleeding. Early rebleeding is defined as bleeding from 2 to 5 days of initial endotherapy. That means the patient was okay for the first 48 hours after the initial endotherapy and subsequently bled again. And late rebleeding is after 5 days to any time. Why we need to classify that is because the connotations are different. Failure to control bleeding basically signifies an endoscopy failure. You might benefit just by doing a repeat endoscopy and repeating the endotherapy procedure. Early rebleeding is failure of primary therapy. That means the patient has high risk of rebleeding. He's probably rebled despite adequate endoscopy. Late rebleeding may be either due to failure of secondary prophylaxis. That means the patient has not been able to report for a 3-weekly or a 4-weekly bending episodes, or he has a high risk of bleeding anyway, like early rebleeding. And in that case, you require a different intervention. That is one thing which we need to remember. The second thing, when we are defining refractory varicose bleed, is that the varicose bleed may be esophageal or gastric, and there are conceptual differences between these two bleeds. We understand that esophageal varices, all varices arise in high portal pressure state. So esophageal varices, you have high portal pressure, but the intravarical pressure is also very high. In contrast, gastric varices, they develop in a high portal flow state, but the intravarical pressure is very low. So they are large varices, low intravarical pressure, and they bleed because of high flow state. So we need to differentiate. We'll touch upon this subsequently as we are defining the management for each one of them separately. One thing is for sure, in all refractory bleeds, whether they are esophageal or gastric, whether they are failure to control bleeding, early bleed, rebleeding, or late rebleeding, the initial management is to achieve immediate hemostasis. When you're talking about the timeline, there is a slight difference in management in failure to control bleeding versus early versus late rebleeding. I'll discuss that. But the definitive therapy almost across all groups is same, and we'll discuss that also. Let's talk about failure to control bleeding, as in when we are talking about esophageal varices. The initial management, as I told you, is in immediate hemostasis. Obviously, you continue all vasoconstrictive medications, somatostatin, terlipressin, whichever you choose as per your preference. If you are not able to control bleeding during endoscopy, sometimes there may be so much blood in the endoscopy, you may not be able to see anything and not do anything. Then you have an option of putting a SB tube or a Dennis Ella stent, which is a new stent which is available, not a new stent now, almost 5 years it has been available in India. The idea is to stop the bleeding for some time and make the field clear for subsequent endoscopy. Now, these strategies, the SB tube and Dennis Ella stent, is also very useful if you're working in a peripheral center. You don't have access to advanced endoscopy. You can do basic endoscopy and you're not able to control bleeding. So you can put a SB tube or a Dennis Ella stent and you can shift the patient to a higher center for subsequent therapy. Hemostatic powders are also available, but I'm personally not too sure whether they at all work in acute varicose bleeding. And I don't recommend usage, although there are studies which have used them. If you talk about SB tube versus Dennis Ella stent, there are some basic differences. SB tube, we all know we've used in an emergency. Both control bleeding in over 90% cases acutely. SB tube can be inflated, the gastric balloon can be inflated for a maximum of 24 to 48 hours. The esophageal varicose balloon obviously can be inflated for a much smaller period. Dennis Ella stent can be placed in situ for up to 7 days. You have bad complications with SB tube like esophageal ulceration, and rupture also has been reported if the pressure is applied too much or if it is kept for a longer period. In comparison, Dennis Ella stent is much safer. The biggest advantage the SB tube, age-old SB tube has is it is cheaper, much more cheaper as compared to Denizella stent, which costs something like 50,000-60,000 rupees for the cost of stent itself. But both these strategies are very useful when you are not able to see anything in the endoscopy. You just put in a Denizella stent or you put a SB tube and you wait for some time for a repeat endoscopy or shift the patient to a higher center if required. When we talk about rebleeding, whether it is early or late, the first therapy is repeat endoscopy with endotherapy. EVL is the standard of care. If your rebleeding is a late rebleeding because of failure of the patient to report for surveillance endoscopies, that means patient is not coming to you within 3 to 4 weeks, then a simple EVL and good surveillance will suffice. You may not need to go to a definitive therapy. But in all other cases, in all early rebleeds and in all late rebleeds where the compliance has been good, you need definitive therapy, and we'll discuss definitive therapy in subsequently in detail. In case of gastric variceal bleeding, if there is a failure to control bleeding, then EUS guided coiling and glue may be a good option. So imagine a stomach which is full of blood, you cannot identify the gastric varix. But in contrast, if you have an expert who is used to handling endoscopic ultrasound, he can use that to his advantage. The blood actually will work as a medium where the visibility of the gastric varix may actually improve. So you may be able to inject or glue with the gastric varix despite having blood in the stomach if you're using endoscopic ultrasound. The problem is that it only controls bleeding on table and may not be definitive, and obviously require expertise for that, which may not be available everywhere, but for the record, that is an option which people have. Let's talk about definitive therapy now. Before we go on to definitive therapy, let's again understand the basic conceptual difference between esophageal varices and gastric variceal bleeds. I told you esophageal varices, high portal pressure leads to refractory bleeding. So simply lowering the portal pressure may further control bleeding. The scenario is different in gastric varices. You have a high portal pressure but low intravaricial pressure. So it is basically the flow in the gastric varix which is leading to the bleeding. So obliteration of gastric varix is very important. I'll just highlight the concept in this diagram. Let's look at, this is the portal vein. Left portal vein, right portal vein, this is the main portal vein. The esophageal varices basically are arising from the left gastric vein. Left gastric vein is a big vein which is in direct continuation with the main portal vein, and all the portal pressure is transmitted across. So if you are able to lower the portal pressure, as in by tips, which I'll discuss subsequently, you will collapse the esophageal varices. You don't need to eradicate them if you are leading to a definitive therapy. So in case of refractory bleeding, where you need definitive therapy for esophageal varices, a simple tips is good enough. What you do is, we all understand what tips is. You go through the right hepatic vein, you make a puncture through the liver parenchyma, enter the so you enter the right portal vein and place a metallic stent which diverts the flow from the portal vein into the systemic circulation, thereby lowering the portal pressure. You lower the portal pressure, the esophageal varices will stop bleeding even if you have not bedded them. This is what you require to do if you have refractory esophageal variceal bleeding, as per the previous discussion which we talked about. The scenario is very different with gastric varices. Here, left gastric vein is not responsible for your gastric varices. Mostly they arise from posterior gastric vein and short gastric veins. These are shorter veins. The transmission of portal pressure through posterior gastric and short gastric vein is not much. Then you have large gastric varices. The gastric varices, they have high capacitance. They have large flow. So even if, and in addition, there may be a large extra gastric component of the gastric varices. So what you see on endoscopy inside the stomach may not be the only extent of gastric varices. You may have large extra gastric varices also. So even if you glue the gastric varix, the flow continues and the rebleeding happens. So that is why when you're dealing with gastric varices, which are refractory, which are bleeding again, imaging is absolutely essential. You need to see what is the extent, where the varices are coming from, and also you need to define the outflow of gastric varices. Obviously, if you talk about only inflow, you cannot reach inside one of these varices. It is difficult to reach. We can do that. I'll talk about that also. But the easier way would be to look at the outflow. So in 85% of all gastric varices, you have an outflow, which is a linear shunt. All the blood goes from the portal vein into gastric varices. From the gastric varices, it goes into the shunt, which drains into left renal vein. So simply what you do is you enter the left renal vein, enter the linear shunt, occlude the shunt, and put a sclerosant. that will obliterate the gastric varices, both the intragastric gastric varices and the extragastric component of the gastric varices. So obliteration of gastric varices is very important even if you don't lower the pressure. So that is the basic difference. Esophageal varices, if you're doing a TIPS, you don't need to obliterate the varix. In a gastric varix, you need to obliterate a varix because only lowering portal pressure will not help you. So BRTO is something which you can do. Let's imagine another scenario. Let's say that there is no linear shunt. Almost 20-25% of patients will not have a linear shunt. In that case, what you do is you enter through the portal vein, do a TIPS, but as I told you, TIPS alone is not useful. You enter one of the inflows of the gastric varix and put sclerosant through that. So that's a more complicated procedure, but required in some patients who don't have a linear shunt here. So talking about TIPS in refractory bleeding, it is definitive therapy for esophageal variceal rebleeding, which is not amenable to endoscopic therapy. Dr. Virender Singh talked about the risk of hepatic encephalopathy, but I'll show you some data that when you're doing that for variceal bleeding over a period of 1 year, the risk of encephalopathy is less actually when you're doing TIPS as compared to EVL beta blocker, especially in cases of refractory variceal bleeding. There is of course a risk of hepatic impairment. What you're doing is you're diverting the blood flow away from the liver into systemic circulation. So due to low blood going into the liver, you may have more hepatic impairment. So there is a relative contraindication in advanced cirrhosis patients. In fact, CTP child C who have a score above 13, no TIPS should be done. Even 11, 12, 13, you have to be very careful. These patients may decompensate after a TIPS procedure. But again, you have to weigh whether stopping bleeding is more important or decompensation. BRTO, I've talked to you. BRTO in refractory variceal bleeding, it is definitive therapy for gastric variceal bleeding. Here, advanced cirrhosis is not a contraindication because in contrast to TIPS, you are blocking the shunt. So in effect, you are improving the blood flow. The portal flow to the liver is increasing. So it may lead to increase in ascites. It may lead to increase in esophageal varices or variceal bleeding, but it does not lead to liver decompensation. That way it is better than TIPS when you're dealing gastric varices. Problem is, if you have no linear shunt, then you of course consider the other procedure better, which I talked to you about, TIPS plus selective obliteration of inflow of the gastric varices. Before I end the presentation, I thought I must introduce the audience to the concept of early TIPS. Now, what if you can predict which patient is going to have a refractory variceal bleed, and you can do something about it? That is where the concept of early TIPS come in. So the trial which talk about early TIPS, the definition is TIPS procedure is performed within 24 to 72 hours of initial endoscopy in a bleeder. You do an endoscopy, you control the bleed, and immediately do a TIPS. This is for all comers. What I have added here is this can be actually done in patients who have a high risk of rebleeding. How do you define that? There are some criteria. The best CPG. So this is a meta-analysis which I thought I should discuss. There are two randomized control trials which are available in 2019 and 2020 also. But this meta-analysis I choose to publish because I thought the focus of the presentation should not be individual data, but overall picture. So total 7 papers, total 8 papers, look at the risk of variceal bleed at 1 year. All papers favor early TIPS as compared to beta blockers and EVL. Look at the mortality. There's a survival benefit if you're using early TIPS. Now, this is for all comers. Just imagine if you can identify patients who are likely to have refractory variceal bleed. And who are these patients? If you have TIPS at your place, you will also have HPPG. So these patients are basically those who have a HPPG more than 20. So what we do in our center is somebody who comes with a refractory bleed, if the HPPG is more than 20, we will straight away do TIPS in these patients. To summarize, in failure to control bleeding, that means bleed persisting or within 48 hours of initial endotherapy, use SB tube or Deniseller stent for esophageal varices. Consider EUS guided coiling or glue for gastric varices. In early rebleeding, please repeat endoscopy and EVL in esophageal varices or glue in gastric varices. And consider definitive procedures such as TIPS and BRTO, which you have discussed. In late rebleeding, in many cases, if the patient is not compliant, a repeat endoscopy EVL or a repeat glue may suffice. But if the patient has been compliant and despite that he bleeds, you may require definitive procedure like TIPS and BRTO. Regarding early TIPS should be considered where available in variceal bleed in high-risk patients which are defined by a HPPG value more than 20. A child B cirrhotic with active bleeding, which you see during endoscopy, usually has a high portal pressure. They also are candidates. And this is third, a relative indication, child score C10 to 13. I'm not too sure whether you should be doing for all these patients or not, but that is what the recommendations say. Thank you for your patient listening.
Thank you, Manav, for a very elegant presentation. My question to the organizers is: we have the 15 minutes for a panel discussion, or are there any time constraints? Because we're kind of overrun our time a bit.
So you can take 10 to 12 minutes.
Thank you, Ajay. So what I'll do is, I think I'll start with the most recent, the latest talk that has been delivered, and we'll try and put one or two questions. We haven't had too much input on the chat box. So starting with refractory variceal bleed, I think I'll put this question to the most eminent panelist we have, Professor Kartar Singh, sir. If you are there, if you could unmute and respond. Everybody knows Dr. Kartar Singh has been a past head of the Department of Gastroenterology at PGI Chandigarh and the past director of SGPGI Lucknow. Sir, this definition of refractory variceal bleeding, is this term that we need? Because you already have so many terms. We have persistent bleeding, early rebleed, late rebleed. It is difficult to manage. Group 1 agrees, but unless you are very specific about the definition of refractory bleeding, is it not creating more confusion than clarity in the field of variceal bleeding? Provocative question, but what are your views, sir?
Well, when the bleed is exponential and there is hardly anything to be seen, then I think Manav will still agree that a staple gun re-anastomosis of the lower esophagus, which used to be done in such like situations, is still somewhere having a place in addition to the stent and the SB tube. What do you say, Manav?
Sir, I would do a tips in these patients. That's easier to do, easier to organize.
Very easy.
Right. No, so I think that was my second question that I thought I'd put to Dr. Shrikant Mukhewar. Shrikant Mukhewar is a very eminent gastroenterologist from the chairperson of the Maidas Multi-Speciality Center in Nagpur and an old friend. So what is the place of surgery these days? We are not talking only of cirrhotic portal hypertension. We are talking of variceal bleeding, which also includes non-cirrhotic portal hypertensive bleeding. And having listened to Manav, it appears that BATO, BRTO, TIPS, these procedures will tackle almost any situation. But say particularly for refractory gastric variceal bleeding, say with sinistral portal hypertension, mainly splenic vein thrombosis and large gastric varices and persistent bleeding, are there any situations like Professor Kartar Singh just said that you see a role for a surgical intervention?
Thank you, Vivek, for a nice question. Let me first congratulate both Ajay and Viren for this wonderful conference. As rightly said, the role of surgery is getting minimized. And I don't see in last 15 years of my practice that I have sent a single patient with refractory GI bleed for a surgical intervention. Maybe earlier to that 15 years, there were instances where I could have sent a couple of patients for emergency esophageal transections and emergency shunts like mesocaval shunt. But presently, I would say that the role of surgery is only in patients with splenic vein thrombosis, with left-sided portal hypertension isolated with gastric varices, where possibly splenectomy would help in cure of the portal hypertension. That's the only indication. But otherwise, I don't think. The second indication would be in patients with portal biliopathy, where you have a, obstructive jaundice secondary to portal biliopathy, and there probably I think creating shunt and reducing pressure is more important.
Thank you, Shrikant. Manav, you wanted to say something?
Yeah, so Dr. Shrikant has already highlighted that part. In an EHPVO patient who comes off from far off place to me, has some abnormality in liver function test, young guy, I would rather prefer a shunt than any other procedure in that patient, because that also helps in growth, preventing growth retardation. takes care of the varicose bleeding and does not lead to progression of portal biliopathy. So that is the only indication where I would advise surgery in addition to a splenic vein thrombosis. That's what we had thought of.
Thank you. Thank you. Brijesh, are you there? I don't think I can see Dr. B.C. Sharma on the panel, or is one of the...
No, probably he's not there. Dr. Gaurav and Dr.
Gaurav and
Ashok
yes,
Chaudhary is there.
yeah, sure. So since BC's name was there, okay. No, I think the other talk that we was very informative was the lecture given by Professor Angeli, and for on this, I think the specific question that I had for the panelists, maybe Dr. Ashok Chaudhary would like to take this. In real life situations, often you have in the same patient at the same time the problem of hypovolemia, the problem of acute tubular necrosis to some component, and as well as his advanced cirrhosis with the portal hypertension. So the hemodynamics of in HRS is present. So this is not an uncommon situation in real life. An elderly person with diabetes who has intrinsic kidney disease, a big prostate, who has had severe diarrhea, vomiting, and has decompensated cirrhosis. So multiple factors are present. So how do you see this? The definition that we have is trying to separate HRS into multiple different components. But in real life, when you get multiple of these happening together, how would you approach this problem, and how would you classify the acute kidney injury in these patients? Dr. Ashok? So could you unmute yourself? I think your mic needs to be unmuted. Yeah.
Thank you very much for this big question. It is probably the most difficult scenario to make a diagnosis and to start the right management. But let me be very practical and pragmatic. If I have a patient with decompensated cirrhosis, obese, with diabetes, of course, without arterial hypertension, and this patient suffer from a sudden impairment of renal function. So we are speaking about AKI on CKD. But AKI is clearly related, for example, to a bacterial infection or to dehydration, and does not solve at all with the plasma volume expansion. I will use terlipressin. Of course, I should be aware that the patient has not some cardiovascular disease according to atherosclerosis and so and so and so. But this is my approach.
Right. Thank you, sir. So I think that is important, because in real life, one does come across these so-called mixed situations where you have to expand the plasma volume, treat the infection, and then you might find that there's only a partial response to treatment with terlipressin. Right. Okay. Now, in terms of refractory ascites, I think Dr. Virender Singh did a very thorough job. We covered everything. We had an interesting question from one of the on the chat box from Dr. Sandeep Satsangi, and maybe Dr. Ashok Chaudhary, would you like to take this question? What is the role of SGLT2 inhibitors in refractory ascites? We all know about SGLT2 inhibitors for NASH, NAFLD, but in refractory ascites, are you aware of a place for this molecule?
Yeah, basically the site of action is renal tubules. It can cause diuresis, so that is one of the added advantages to do dehydration. So that side is coming up as a drug, but I have not detailed idea about this.
Yeah, I mean, this is an intriguing question. Maybe Professor Virender Singh might want to respond. I mean, is there anything that you know about SGLT2 inhibitors and for refractory ascites particularly?
Theoretically, it looks good, but nobody has done a trial on this.
There are probably few articles coming on SGLT2 with mobilization of ascites, but none of them have checked in refractory ascites. probably the liver dysfunction might be higher. And since most of these drugs are metabolized in liver, a thorough investigation, especially at the side effects, might be required. Especially the risk of fungal infection increases, and DCLD child's late child's B or C, that might be an issue that's coming up. The other issue is there can be an afferent vasoconstriction that might be happening because of SGLT2. So this may alter the hemodynamics per se in patients with the advanced decompensated cirrhosis with HRS physiology and refractory ascites. So these two might be a few concerns that might be there in advanced cirrhosis. But otherwise, for ascites mobilization and NASH, it has been used in few studies.
I mean, what I'm saying is that there seem to be promising pathophysiologic connotations, but no hard data as yet.
Yes.
So maybe Professor Sareen or Professor Angeli would like to comment on this particular issue.
Not really. Little data.
Okay, so it's just evolving. I think some of the most interesting things that we heard today were about ACLF, and on ACLF, maybe I can request Dr. Gaurav to tell us. You are very familiar with the ARC definition that we have all been using for a long time, but ARC does not include only refers to the first episode of decompensation. In subsequent episodes, one does not. Normally, it is not this part of standard definitions of ACLF. So what do you think about that? Because in subsequent episodes of decompensation, also the pathophysiology would be similar. And the second major issue that has always been of concern is that I think all of us have agreed that infections do play a major role in the outcome of ACLF. And hitherto, the three definitions and the consensus statements we've had from ARC do not consider this to be a precipitating or a factor only as a complication, and they are not part of the definition. So what are your comments on this? And then I definitely like inputs from others.
So for definition of ARC, if in front of Professor Sareen, there is nothing for me to mention. No, sir has already highlighted that ACLF is an acute portal hypertension syndrome. And that is so true. Once portal hypertension, there is sudden increase in portal hypertension and not a slow ongoing increase that happens with decompensated cirrhosis. So this sudden increase in portal hypertension does lead to altered gut permeability, increased intestinal permeability that we have shown in few of our studies, gut translocation, increased cytokines, PAMs and DAMs that add to inflammation. So definitely, because of sudden surge in portal hypertension, there is altered IP and increased bacteremia and increased risk of infection. Therefore, infection definitely plays a huge role, especially in our settings at SGPGI. It's almost the second most important cause of ACLF if we take alcohol with it, and plays a primary role. It not only plays a primary role, if we don't reduce IP, it definitely increases the risk of secondary infection that the patients develop in hospital. We have shown that patients who improve IP definitely do much better than patients who do not improve IP in our setting. So patients with improved IP have lesser amount of secondary infection developing in hospital than patients who do not improve in IP. So definitely infection plays a major cause, definitely in morbidity and mortality, maybe or may not be in definitions. That's up to stalwarts to decide.
Yes, we've had the bell telling us we are nearing the end of our time. So, sir, I'd request Professor Sareen for a last word on these issues, because they always generate controversy. So where do we look at repeated episodes of liver failure in a person who's once had ACLF according to ARC and the infections?
So in 2019 consensus to which you and many others were part, we had gave the term ACLF again. And ACLF again is a person who has recovered, and the natural history of 6,000 such patients was presented by Ashok. It was a plenary at EASL, but he is not able to write it down. So one of these days. Part 2 is about infections. In fact, now you can show in 24 hours of the hepatic insult, the monomac paralysis, monocytes, macrophage paralysis, HLA count. So infections will come in 5 to 7 days. Since we are secondary referral, tertiary referral, by the time patient comes, the patient will definitely have infection. So we cannot exclude. But if you start from beginning, and now we have 2 animal models of ACLF, classical. You can see hour-wise, 4 hour, 6 hour, 12 hour, how it works. So I think we leave it to another debate. I want to give one or two comments on Manav's and your thing, the difference between failure to control, because I was part to maybe no one to all these.
Right, sir.
Failure to control bleed, the term was given that if within 2 hours of primary intervention, whatever it is, whether it is a vasoactive drug, terlipressin given, or it is an endoscopic therapy, if within 2 hours you are unable to control bleed, means there is a decrease in hemoglobin by about 2 grams, requirement of blood is 3 units, and there is a systolic blood pressure fall, you need to change therapy. So that was the reason for giving failure to control bleed. So right on the top. And then what you have is another 24 to 48 hours. That is when failure of the primary therapy, which Mana very clearly said. So today everyone would agree that if you are unable to control bleed, you change therapy in 2 hours. These are my only comments.
Right, sir. I think we've run out of our time now. And I'd like to thank all the speakers for excellent presentations and all the panelists for their valuable inputs. So we're back to the hosts, to Ajay, for you to carry on further.
Thank you very much, sir. I think that was a wonderful session and you conducted it so well. So thanks to Professor Saraswat, all the speakers and the panelists for this session. And let's go on straight to the next session, and that is on hepatocellular carcinoma at CC, and which will be moderated by Professor Gaurdas Chaudhary, who is the director and the head of gastroenterology and hepatology at the Fortis Memorial Institute, Gurgaon. Over to you, sir, Professor Chaudhary.
Thank you very much, Ajay, and Virender, thanks a lot for calling me. It's a pleasure. I've been listening to this very high quality program. In this discussion on hepatocellular carcinoma, we have 3 very experienced speakers and 4 eminent hepatologists who are our panelists. Let me start the other way around. So the panelists are Dr. P.N. Rao, everybody knows, from Asian Institute of Gastroenterology, Hyderabad, Dr. Ashish Kumar, is at the Sir Gangaram Hospital, Sandeep Dhawan from CMC Chandigarh, and Saurav Mukhewar from Nagpur. Now we take a deep dive into the talks. The first talk is going to be by Professor N. Kalra. He is from PGI Chandigarh, and he shall be talking about one of the most common modalities that we use for treating hepatocellular carcinoma. So this is recent developments in the radiological interventions. Professor Kalra, are you there? Over to you, sir.
Yes, sir. Good evening, sir.
Good evening.
And thanks for the introduction. And thank you, Dr. Ajay and Dr. Virender, for having me here for this talk. And I'll be speaking on, are my slides okay?
Yeah, we can see that, yeah.
Okay, so I'll be talking about the recent developments in radiological interventions in HCC. And due to the paucity of time, I'm going to jump straight into the topic. So when we talk about radiological interventions in HCC,
make it full screen.
It is full screen, sir.
Okay.
Yeah, I think that's the format. Maybe it's that's why yours. Can you see the full screen now?
Yeah, it's okay.
Okay. So initially, when we think about the radiological interventions, we always go back to the BCLC staging system. And this was the old recommendation where RFA was not the first line therapy, was an alternate therapy, and TACE was indicated in the intermediate stage HCC. But now with these revised EASL guidelines, ablation has become the first line management for very early stage HCC, and it still remains an alternative therapy for early stage HCC, and for intermediate stage HCC, we do have chemoembolization as before. So this is the list of ablative techniques, and it's an exhaustive list, but I'm going to just delve into microwave ablation and cryoablation, which has now had a resurgence, and microwave ablation, which is now replacing radiofrequency ablation at most of the centers, and then irreversible electroporation. As far as catheter-based endovascular techniques are concerned, CTACE still the workhorse, but now the shift towards drug-eluting bead stays and transarterial radioembolization. So when we talk about microwave ablation, these are electromagnetic waves with a high frequency, and herein water molecules act as an electric dipole and align to the changing field lines. This results in the neighboring macromolecules, which are heated by convection, and this results in ablation of the tumor. So why we are switching from RFA to microwave ablation is because a higher temperature is achieved with microwave at the target tissue, the shorter duration of therapy, less pronounced heat sink effect. And this heat sink is if you have a vessel close to a tumor which you ablate, the flowing blood takes away the heat and there is less energy delivered to the tumor. With microwave ablation, this effect is less pronounced. A larger ablation area is achieved and there is no need of neutral electrodes. Microwave shares its applications with RFA with the advantage that you can do it in large nodules, which may be close to blood vessels as well. So just to show a patient where we opted for microwave ablation, the arrows show the lesion which is close to the hepatic veins, and that is the lesion, how it looks like on ultrasound. It is in proximity to the hepatic vein, and that's the microwave generator, the microwave applicator, and this was inserted under ultrasound guidance into the tumor, and you can see the generation of gases as the ablation evolves. And this is the follow-up CT at 1 month, and you can see the coronal section shows the large ablated area, and there is no residual tissue whatsoever of the tumor. And this is a 3 months follow-up, which shows the, again, there is no residual tumor, and there is shrinkage of the ablated area, which is as per the expected lines. So this is a meta-analysis which looked at compared radiofrequency ablation with microwave ablation. So there was no difference in the 3-year overall survival when we looked at microwave versus RFA, but microwave did outperform RFA in terms of local recurrence for larger tumors. So now about cryoablation. In this, this works on the concept of Joule-Thomson effect. And presently, argon is the gas which is used for creating the ice ball, the freeze part, and helium for the thaw part. So there has been a change in the machinery used for cryoablation. Earlier, nitrogen was primarily used, and now it has been switched to argon. So cooling via rapid expansion occurs. And what we get is an ice ball at the tip of the probe, and this is an oblong ice ball. So needless to remember that most of the tumors will not have this shape, so you need to sculpt your ablation zone to cover the entire tumor. And the procedure is carried under CT guidance, and you can adequately monitor the procedure. The frozen tissue shows a differential HU Hounsfield unit on CT, as we'll see on these images later. So it works on the mechanism of crystallization, and that causes the damage of the cells. Also works on the concept of vasoconstriction. Then there is immune modulation and apoptosis as a mechanism for the cryoablation for the tumors. So this is a patient where we did cryoablation, a central located lesion, as well as a lesion in the caudate lobe of liver, a hypervascular lesion you can see. And this is how it looked like on ultrasound. The arrows point to the 2 lesions, the right lobe and the caudate lobe, and that's the right lobe lesion, the needle placed right into the lesion, and then as you can see, these arrows show the evolving ice ball, and that's at the end of the procedure, the ablated lesion. And that's the lesion in the in the caudate lobe, showing the presence of the ice ball, and that's how it looks like on CT. You can see the ice ball well. That's what I was mentioning to how it looks like on a non-contrast CT. So we keep monitoring it under CT as well as ultrasound, our ablation and cryoablation, and that's the lesion being ablated in the caudate lobe. Another example of a patient with a hypervascular lesion in the GB, near to the GB gallbladder, and that's how it looks like on ultrasound. Has a slight exophytic component. So we placed 2 probes here in a crisscross fashion, got a large area of ablation, as that's the eyeball that you can see. And that is the follow-up at 3 months, and you can see that there is no. So the advantages of using cryoablation is there's well visualization of the ice ball. The size of the ice ball, though, is larger than that of the tissue injury. It's a relatively painless procedure compared to microwave and RFA, and there is lack of damage to large blood vessels and the gallbladder. There are adverse events, though they were more commonly reported when the earlier models of cryoablation machines were used, in the form of severe thrombocytopenia, liver failure, cryoshock, multi-organ failure, and DIC. This is a study which looked at the complete response, and they found that this was achieved in as high as 97.2% lesions, and the complications were less than 3% in their series. Moving now to electroporation, that's a non-thermal technique, and that uses pulse direct current to induce cell death, and it acts by creating holes in the cell membrane. The cells become leaky, and the body's own macrophages come up and gobble up these cells, inducing apoptosis induces cell death. It works with a high energy direct current generator, and we also have ECG synchronizer, which delivers energy only in the R wave trigger device. It is a R wave trigger device, and you have different electrodes with different lengths of ablation that you can do with them. 3000 volts of current is delivered in 90 pulses in 9 sets of 10 pulses each. You have a mathematical model before you start your procedure. The catch here is that you have to introduce your electrodes parallel to each other, and they cannot be closer than 1 centimeter. You cannot take them away more than 2.5 centimeters from each other. So you have to be very accurate and precise in the placement of your electrodes. It's a non-thermal technique, so there is no heat sink effect. And the vessels also don't get damaged. There is no injury to the collagenous structures, so the critical structures are preserved, that is vasculature, ducts, and the nerves. So this is a patient with a centrally located hypervascular hilar lesion, as you can see in this enclosed within these circles. And that is how there's a washout on the venous phase. It is just at the bifurcation of the portal vein and at the bifurcation of the hepatic arteries. And we chose to put in 3 probes parallel to each other into the lesion. And that is how it looks like at the end of the ablation. You can see the large ablated area, but you don't see any damage to the arteries and no damage to the portal vein whatsoever. And here again, you can see that there is the vessels escaped injury whatsoever. So there are adverse effects with IRE as well. You have cardiac arrhythmias, you have muscle contractions, you have transient hyperkalemia. And if you're not careful with your probe insertion, you can injure the pleura and have a pneumothorax or have venous thrombosis. So you have to be careful while you are placing your probes. It's an expensive technique. There's lack of track ablation. You have to have a learning curve for putting in multiple needles, and the data on this is evolving still. This is our study, which we published in CVIR of 21 patients of HCC, which we treated with IRE, and the range of tumors we treated was 14 to 40 millimeter. And we found that the maximum tumor diameter was significantly associated with the local tumor progression. This is another study in radiology, which looked at the safety of IRE in HCC for those patients who had lesions not amenable for thermal ablation, and they found that a pre-ablation serum alpha protein was the only factor which influenced the outcomes and the local tumor progression-free survival. Moving on now to endovascular therapy, we know about these 3 therapies: conventional TACE, DEP TACE, and radioembolization. So I'll move. So the rationale of this therapy being that the tumors are fed by the hepatic arteries, while the normal parenchyma has dual blood supply from the portal vein and hepatic arteries, as we are all aware of that. Moving straight to drug-eluting bead TACE, why use this when conventional TACE is there? The advantage is that there is simultaneous delivery of uniform embolic and chemotherapeutic agents, and it allows fixed dosing and ability to release the anti-cancer agents in a sustained and controlled manner. Once they are bound and they come in contact with the blood, the chemotherapeutic agent gets eluted into the tumor, resulting in a high concentration only in the tumor with less of the concentration in the rest of the body. So that's the advantage of using drug-eluting beads. So the CN5 trial looked at conventional TACE versus DEP TACE. They recruited 212 patients, and they found that DEP TACE did do better than TACE, tumor response rate being 52% versus 44%, and time to progression also was higher with the DEP TACE versus conventional TACE. However, all these figures were not statistically significant. So when we look at both conventional TACE and DEP TACE, we know the contraindications for doing treating HCC is when there is massive tumor involving both lobes, or there is main or branch portal vein thrombosis. So is there any therapy which we can do when we have this kind of multilobar disease or portal vein thrombosis? Yes, it is transarterial radioembolization, and here in microspheres get trapped in the capillary bed, and they have deliver radiation to the smaller volumes of the tumor, resulting in greater tumoricidal effect with minimal damage to the non-tumor tissue. And more important is that this is a non-embolic therapy. So there can be either glass or resin microspheres, and this is beta radiation. Typically, Y90, yttrium-90 is used. The size of the particles being only 25 microns, and radiation dose delivered to the tumor is anywhere between 150 to 200 grays. So there are, as we know, theta spheres and search spheres, which means either the glass spheres or the search spheres, and they have, depending upon what we use, they have different embolic power, and they have different activities loaded onto each of the spheres. So you can decide based on the size of the lesion which one to use. So as I said, you use radioembolization when there is massive tumor involving both lobes, or when there is portal vein embolization, portal vein embolus in the major branch of the portal vein. So when we looked at tear, whether we can do tear in the intermediate stage HCC, so the trials have compared the two and found no difference in terms of progression-free or overall survival. So the premier trial did show that a longer time to progression with tear versus TACE without significant difference in the overall survival. So this is another data for looking at retrospective studies of TACE versus TAR, showing the overall survival advantage with tear versus TACE in intermediate stage, except in one series only. The concluding few slides, I will show how different techniques are also have evolved over a period of time, which allow us to do this procedure in a better way or in a different way. So if you have fusion imaging and navigation tools, that is, we are aware that a lot of HCC nodules may be isoechoic and are not easily seen on ultrasound. So now we can actually fuse the CT or the MRI, which has been done for planning with the ultrasound during the procedure, and improve the visibility of the target HCC lesion. We can also superimpose the lesion on the cross-sectional imaging with the ablation-related gas formation seen on ultrasound to confirm our ablation coverage. So this is an example here, though the lesion was well seen on ultrasound, but I'll just demonstrate how we can fuse these images. So a CT and an ultrasound. So with the software, with external sensors, as well as using the anatomical landmarks within the patient, the CT and the ultrasound images are fused. A cursor comes over the target tissue, and you can actually subtend the probe with the needle in such a way that you hit the target with the needle, and you are actually fusing your CT and ultrasound images. I'll just just 2 or 3 slides, I'll be ending up. Sir, please, can I go ahead with that one? Just 2 or 3 slides. Yeah.
Okay, just go ahead quickly, please.
So this is an interesting study which looked at the local tumor progression subsequent to cryoablation, and herein they've kind of fused the images which were done pre-procedure and during the procedure, and they looked at the concordance between the site of local tumor progression and the minimal ablative margin. And they found that in all the lesions, the site of local tumor progression was congruent with the minimal ablative margin. So this could actually help to predict where you are going to get local tumor progression, or where you're going to get the failure of your ablative therapy. Cone beam CT, this is done as part of the endovascular therapy, where the C-arm rotates around the patient, and the acquisition creates actually a volumetric CT data set. So you can identify the lesion well, you can look at the feeding branches for embolization also very well, and this will reduce the total volume of the contrast agent, the fluoroscopy duration, and the radiation dose. So very well indicated to do it in the hypovascular tumor. You can see this HCC, which is hypovascular, though well seen on the MR. And this is the DSA during the procedure. You don't see the tumor blush, but when we do a CT, we can anatomically localize where we should deliver a chemotherapeutic drug. And then there is the angio CT, where actually on the same patient is on one couch, but you can, in the same suite, you have the C-arm where you can do the DSA and then just pull in the gantry and do a CT at the same time. So this is also very useful when you are doing procedures like TACE and TARE during for HCC, unresectable HCC. And there is a study, though limited data, which has shown that in patients who underwent TACE using this unified CT approach, they had showed a better survival, longer survival time versus those in whom this unified CT was not used. So to conclude, the present era, I would say, is of precision loco-regional therapy. The tumor ablative effect of microwave ablation is promising. Cryoablation you can choose for tumors which are close to the gallbladder or close to the liver surface. IRE, irreversible electroporation, is effective for small central peribiliary and perivascular tumors up to 3 centimeters. DEP TACE has lesser adverse events versus conventional TACE. TARE is primarily indicated in patients with HCC with main portal vein thrombosis or in bilobar disease, and features like fusion imaging, cone beam CT, and angio CT are developments and useful tools which are now available for local regional therapy in HCC. Thank you very much, sir. Thank you.
Thank you very much, Dr. Kalra. That was a very comprehensive, very detailed, tech-heavy talk, taking us through what has been the developments in this area over the last few decades. We move on to, there'll be certainly quite a few questions coming to you.
Sure.
Let's make time for that, and our panelists will lead the discussion. Our next talk, as you know, that one is the ablative therapy, or the next is actually liver transplant. Still continues to be one of the major options that one talks about in terms of a curative treatment. And we have Dr. Sanjeev Sehgal to talk to us about it. Dr. Sanjeev is the Senior Director of Hepatology and Liver Transplantation at Medanta, the Medicity. Is very well known to all of you. So Sanjeev, can you take us through this topic?
Right. Thank you, sir. Good evening, everybody.
There is a little catch to that topic. I think we have all been brought up on the so-called Milan criteria, and I think that we are now looking at the cutting edge of what you are going to tell us about the Milan criteria and where it ends. Go ahead.
Right, sir. Thank you, sir. My slides are visible, sir.
Yes, please.
Right. So this is a very interesting talk today, and I'm going to be really, speaking on basically the criteria which are now available Milan and beyond. What is an ideal criteria? How far one should go? Is there a difference between LDLT and DDLT when we consider liver transplantation for HCC? And then some controversies like impact of downstaging, impact of things like portal vein tuber thrombosis and so on. I'll just be brief in my presentation because in the next 12-13 minutes I'll try to cover whatever practical aspects we see in our day-to-day practice. Now we all are trained by this conventional Milan criteria: 1 lesion less than 5 centimeters and 3 lesions each less than 3 centimeters. And then we also have the UCSF, which is very used criteria world over: 1 lesion less than 6.5 centimeters or 2 to 3 lesions each less than 4.5 centimeters. Total diameter less than 8 centimeters. Now these are well established criteria, and if you look at the Milan criteria, for example, now it is known that the 4-year overall survival is 75%, the DFS is about 85%, and these results have been duplicated elsewhere, and this is now accepted by UNOS as the conventional criteria, and this has been there for decades. So the question is there a need to go beyond these criteria? Are we okay with them? Well, let us see. Clearly the Milan criteria is very restrictive. There are significant dropout rates because the tumor does progress while the patient is waiting for transplant, and this is based on pre-transplant imaging. Often what we see in the explant liver post surgery actually is different. Tumor has progressed, and it's not the size, but it is the biological factors which are also very important. So one should really consider that there is a scope of expansion of this criteria, and if we can do the expansion without impacting the survival, that is our aim. So how far one should go? Now if you look at the criteria from literature, there are actually much more than what I've written here. They are all evolving every day beyond the Milan criteria, and you have this up to 7 criteria, Hangzhou criteria, Tokyo, where they have 5 tumors, each less than 5 centimeters. Then a lot of them have come from Japan. Then the Asan Center, the Koreans have also given good criteria which they follow, the BCLC and so on. So they are essentially trying to go to a stage where they're trying to increase the numbers, trying to increase the size, and make sure that the patients don't have extrahepatic spread of the tumor. Some centers, some do follow a policy where they try to do a biopsy of the tumor to look at the actual pathophysiology, actual histology of the tumor before they take for transplant. Now, how far one should go? This is a question, I think, is a very relevant question which has been put to me today. Now, we start with the Milan and the UCF. These are two, like backbones, the broad criteria on which we are really working on today. And then you have, criteria which is increasing, how far you should go. And sometimes we have patients who have got some involvement of portal vein, the branch portal vein thrombosis, and these are also candidates where as Naveen would have spoken in his treatment part, these are the patients where you can actually offer some therapy, SBRT and all, and then the patient will be downstage. So should we really be doing that? So let us see how far we should go, and in my talk today I'll try to address these issues as we proceed. Now, this is a metro ticket concept which we all are aware of, that the more you go far, the more is the chance of the recurrence rate and the reduction in the 5-year survival. So as you proceed longer, you have got from a 75 to 80% 5-year survival, you drop down 50, and then 35 to 50% 5-year survival. So this is that the higher price you pay, further the distance you travel. So this is a thing which we all need to know. Now, when you compare these criteria, what are the 5-year survival rate, the Milan versus UCSF, Hangzhou, up to 7, Toronto. Now, like Toronto, for example, does not use any size. They're irrespective of size and irrespective of number, and they'd like to do a biopsy of the lesion. So that's a practice which centers follow. Bottom line is that they all have reasonable 5-year survival rate and a recurrence-free survival, which is also not that bad. And there is an argument for extending these criteria. Things go different when we consider LDLT, because in LDLT setting we are actually having a different ball game. Sometimes it's a very like double equipoise. Should we consider these patients for a transplant when the donor is from the patient's family, the patient has got advanced liver tumor, and they're not competing with the organ from the donor pool? So there is a pro and con for that. Some say okay, you can go ahead, some say no. If it's a survival 5-year which is less than 50%, you should not do. And all these criteria which we discussed today have actually initially evolved from the DLT centers. So when we take up an LDLT discussion, there would be some bias in our discussion, and we must make sure that the expanded criteria, when they're used in an LDLT system, they should be evidence-based, the results should be similar to that in DDLT, and the center should have adequate expertise in dealing with these complicated patients. So literature is full of these results of expanded criteria which are beyond the Milan for both DDLT and LDLT, and you will find these sort of tables which are easily represented in most of the discussions we do today. And in these you will see that the number of patients is actually still small. And although one study has 1556, which is a huge number of patients which is beyond Milan, and they actually try to do DDLT, and then the outcome which is anything from 50 to 70% or 80% 5-year survival. Similarly, we have LDLT centers where they have published experience of living donor liver transplant in patients who are beyond the criteria. And again, you will see that the number of patients here would be something like 75, 82, or 300 patients, 294 in this series, and the overall survival and the recurrence-free survival would vary from 55% to about 95% in various series. What they have emphasized, or what we have understood as practicing clinicians, is that the results are comparable with that of Milan criteria, even when we do these LDLT and expanded criteria patients. None of these patients have gross vascular invasion, and nobody will have extrahepatic disease, and the tumor biology is included as far as possible. Now, two things which are very important when we discuss these expansion of criteria. One is the role of downstaging, another is a lot of these patients have segmental portal vein thrombosis. How should we approach them? Now, is there anything more than the tumor micromorphology? Yes, we have tumor biology, which is defined by the AFP dynamics, the DES gamma carboxyprothrombin, the PIVCA. We have inflammatory markers, the neutrophil lymphocyte ratio, CRP, vascular invasion, FDG PET activity, the tumor genetics, and the molecular markers, microRNAs, and so on, some of which are still evolving, and newer data is emerging as we discuss this in every meeting. So, what is important to understand, if somebody is beyond criteria at this stage and we can downstage them to within the criteria, then are we okay to include these patients for transplant? Now, this is the protocol which is being followed by the UNOS, and you will see that the pre-treatment disease, that either one lesion more than 5 centimeter and less than 8 centimeters, or 2 to 3, each more than 3 less than 5, or 4 to 5 lesions, each less than 3 centimeters. Now, you do some loco-regional therapy, either TACE or TARE, and then post-treatment, you have a lesion where it is, like almost within the Milan or within the UCSF. So then these patients are considered for liver transplantation, mostly DDLT in the UNOS setting. Now, there are adequate studies which tell us that following downstaging, usually TACE, and based on RESIST criteria for demonstration of tumor response, these patients are subsequently taken for transplantation. Now, like in this compilation which I'm showing here, about patients which were included in these studies numbered from 15 to 76. Mostly TACE was used as the downstaging protocol, and the 5-year survival was anything from what 40-50% to about 90%. So there is a scope for telling that yes, you can downstage these patients by whatever you want to use, TACE most commonly, and then go ahead with the transplant. Now, this is a study which has recently been published by Annie Kardashian in hepatology, a multi-center study from USA, 20 centers, which is perhaps the best representation of outcome of transplantation in patients who are beyond the Milan criteria. So within Milan, there were about 3,500 patients, and beyond about 789 patients. There were downstage versus not downstage and untreated. There were 3 groups which were then compared. Huge number of patients in each groups. I think the largest study which we can say, which is available to date, on the impact of downstaging and transplant outcome. So what we see here. Now please look at these graphs carefully. The overall survival 5-year, in this blue line is Milan criteria, then this green one is beyond Milan, which we are downstage, which is 465 patients, and red line is beyond Milan, which are not downstage, which is 324 patients. Now these 3 are then compared. The ones which had downstage done or were within Milan were better than those who were beyond Milan and not downstage. So clearly, staying within Milan or beyond Milan but getting downstage is a better thing for overall survival. Similar is the recurrence-free survival. The blue line, the Milan criteria, followed by downstage and followed by not downstage. If you are within the criteria, or you downstage yourself and bring to the criteria, then you're better than the non-downstage patients as far as recurrence-free survival is concerned. And this was, endorsed very clearly that downstage patients had a superior recurrence-free survival, 60% versus 54%, and lower 5-year, recurrence rate compared to those who were not downstage. So again, you see here, the red one had a higher recurrence, which are not downstage, versus those within Milan, which is the blue line. So, in the multivariate predictors, AFP response to loco-regional therapy, pathological tumor number and size, and a longer wait time, they are actually effective in predicting the outcome of these patients. Now, it is controversial to see what portal tumor thrombus does, and with this publication which was published from our center recently in transplantation, it was a huge experience. About 2,348 patients were living to a liver transplant, 451 had HCC, 46 who were downstage, and 17 who were actually no PVTT, and they compared within Milan, beyond Milan, UCSF, beyond UCSF. So if you look into this part, I'll maybe discuss later on when the time permits. The outcome of these patients, those patients who were having no PVTT versus those who were downstaged and had PVTT, you see that the 1 year survival was 94% versus 82%, and 5 year was 65 and 57% respectively. And the recurrence-free survival was 88% 1 year in those who had no PVTT and LDLT was done versus 77% who were downstaged, PVTT and LDLT was done. And then over the 5 years survival also again was better in those who had no PVTT, but those as compared to those who were downstaged. Generally speaking, it is important that somebody has a branch portal in thrombosis VP1 or VP2, and then you do a downstaging therapy, and then you take them up. Then obviously they are better than patients who are not downstage and taken for transplantation. Now, what we concluded was that survival after LDLT for successfully downstage HCC with PVTT was superior with local regional, superior than that with local regional therapy or sorafenib. So liver transplantation is better. Just tumor thrombus in a branch does not necessarily mean that the patient would have had a systemic spread, so they can still be managed by on a case-based protocol. And the tumor biology, which is most important, which is low pre-treatment AFP level or a fall in AFP on treatment after downstaging and a low tumor grade, which favorably will influence the survival. So, in summary, in my short presentation today, what I observe is that conventional Milan criteria are too restrictive. Most centers would expand their selection for liver transplantation beyond the Milan criteria. Definitely in the LDLT centers, yes, they would go beyond that. UCSF criteria seems to be the most appropriate as of now in our practice today. Those beyond criteria should be downstaged to within UCSF prior to consideration for liver transplantation. And this is a practice which is being followed in LDLT centers also, as it is being followed in DDLT centers. Successful downstaging is predicted by the wait time, the AFP response to local regional therapy, the tumor burden, and then we can have excellent outcome following downstaging. Effectively, it means that we can go beyond the Milan, and you can really not restrict yourself to Milan anymore. In those with PVTT, a branch thrombosis like VP1, VP2, which is a branch thrombosis, segmental thrombosis, but not the VP4, which is the main portal vein thrombosis. In these patients, VP1, VP2, or maybe VP3 in selected patients, you can do successful downstaging using SBRT, local regional therapy, and then if they are downstage and you are sure that there is no extrahepatic spread, in a highly carefully selected patients after downstaging, you may consider for LT as a part of a protocol, but this is a very category, very statement in brackets. It's not that a general thing which I would like to say. So in general, those who are within criteria up to UCSF, pre-downstaging or after downstaging, I think that is something which we go beyond the present Milan which we practice up till now, and this is something which is adequately evidence-based. Thank you, and I'll be happy to have any questions on that. Thank you very much.
Thank you very much, Sanjeev. I think we'll take questions at the end. May I go to the third speaker? I think the last two talks have already demonstrated the huge strides made by medical science in managing HCC. And there are recent concepts on systemic therapy, which should be very exciting to all of us. We couldn't have had a better person than Dr. Paul Tuluvat to talk to us about it. Dr. Paul is a director at the Institute of Digestive Health and Liver Diseases, Mercy Medical Center, Baltimore. And he's also director of Advanced Hepatology Network, University of Maryland, Baltimore, USA. You would have all seen and heard him many times in most international conferences. He's been a teacher and a celebrated hepatologist. Dr. Paul, over to you. We look forward to listening.
Sanjeev, can you stop sharing your screen?
Yes.
Thank you. Thank you, Dr. Singh and Dr. Desija and the moderators for asking me to give this talk. My task is to discuss the systemic therapy in people with advanced liver cancer. Some of the previous speakers gave excellent presentation on local regional therapy as well as the role of liver transplants. So I'm going to focus mostly on systemic therapy and its role in the management of HCC. I
Can you
have
put
no
your slides
conflict.
on full slide mode, sir? Full screen mode.
Yes, thank you. I'm sorry about that. My only conflict with this talk is I participate in some of these clinical trials in HCC. In this brief 15 minutes, I will try to give you an overview of the systemic therapy. I cannot go into the details of each study because there won't be enough time for that. So when you look at the SEER database from 1975 to 2014, you can see the 5-year survival is very dismal if there are regional metastasis or distant metastasis. And when you look at the all-comers, approximately 16% will have distant metastasis at diagnosis. And if you look at the tumor pathology after resection or transplant, 85% may have lymphovascular invasion. So the estimated 1-year survival is only around 17%. Many prognostic factors, we heard it before, tumor size, vascular invasion, metastasis, and tumor biology, the surrogate marker being alpha-fetoprotein. And the other prognostic factors are liver reserve, which can be assessed by Child-Pugh score or MEL score, or host, the performance status of the host and the comorbidities. The previous speaker alluded to the UNOS criteria for organ allocation. In the pink is the expanded criteria. And once you can downsize them to Milan criteria, they can get tumor exception points in the United States, and they will be eligible for liver transplant. So there are patients who may be eligible for systemic therapy, but the role of systemic therapy in downstaging to Milan has not been well defined yet. I'm not going to dwell on this because the first speaker already explained the multiple modalities for local regional therapy. So I will focus mostly on the last part, the advanced HCC with child A and possibly child B. What is the role of systemic therapy and how well they do? So if you come to the right-hand side, the left-hand side is mostly how to choose. And I was asked to write a review article on this. It depends on the center, the size of the tumor, the location, multiple factors go into that. I will not discuss that any further as the first speaker has explained that in more detail. So once the tumor is beyond the Milan criteria, not a candidate for liver transplant or downsizing, that is when we consider systemic therapy. This is a patient I saw 2 months ago. He's a 60-year-old man with cirrhosis, and he was an intravenous drug user, and he was an alcoholic. He came with severe right upper quadrant pain. No decompensating event up to the time of admission. And his performance status was excellent. Liver function tests were normal. Child-Pugh score was 5. Ultrasound showed a large liver mass. Alpha-fetoprotein was 1,000. It should be 1,200. MRI showed a 13 centimeter mass with portal vein invasion and lymph node metastasis into the hilar lymph nodes. So the question is, what do we do for that person? He's not a transplant candidate. He's not a candidate for TACE or TAB because the tumor has already gone beyond the liver into the local lymph nodes. So we have to think about, should we do systemic therapy or should we have just supportive care? So these are the options we have. We have receptor tyrosine kinase inhibitor. There are multiple of them currently available, checkpoint inhibitors, or a combination. I'm not going to discuss in detail about the tyrosine kinase inhibitors, but just for the postgraduate students, kinases are a class of enzymes that catalyze the transfer of phosphate groups from ATP to amino acid residues or key proteins. That will result in signal transduction, which is associated with cell differentiation, proliferation, and death. So these receptors, there are many of them, they are overexpressed in tumors. And so because of the receptor tyrosine kinase subfamilies, there are many, you can be more specific, you can target for multiple kinases or be more specific to one kinase or other. And that is how tyrosine kinase inhibitors work. they bind with the ATP or ATP binding site, decrease the tyrosine kinase phosphorylation, and this causes inhibition of tumor growth. What about checkpoint inhibitors? The two important checkpoint inhibitors are PD-1, program death protein 1, and its ligand L1, or cytotoxic T lymphocyte associated protein CTLA4. Immune checkpoints are body's defense mechanism to reduce the tissue damage. So activation of the checkpoints will prevent the lymphocytes to be very active, so the tumor cells can escape the immune surveillance. And CTLA4 cells are inhibited in the tumor microenvironment. So there have been antibodies that target either CTLA4 or PDA or PDA-L1 pathways. Or you can use two antibodies, one against CTLA4 and one PD-1 pathway. And this will activate the pre-existing CTLA4 lymphocytes and may increase the tumor susceptibility to T-cell mediated immune response. This cartoon shows that there are a number of ways, there are a number of molecules available at PD-1 pathway, PD-L1 pathway, and anti-CTLA4 antibodies. So you can use either one of them, or you can use a dual therapy of CTLA4 antibody and PD-1, PDLA pathway inhibitors. Same as the immune checkpoint inhibitors, the tyrosine kinase inhibitors, there are differences, minor differences. And there are domains outside the cell, in the transmembrane, and inside the domains, inside the cell. And these work with the tyrosine kinase inhibitor in increasing the tumor death. So there are many drugs that are available. At least there are 5 drugs available in the USA. When you look at the survival, it is better with the tyrosine kinase inhibitor, but the delta is 2 to 3 months. And when you look at the objective response, all these studies show that less than 10%. A comparative study between lenvatinib and sorafenib showed that there was no difference, although lenvatinib theoretically was a better drug. So these drugs were effective, but the extent of the delta between placebo and the drug is limited. And there are significant side effects. 40% withdraw the treatment, and many of them discontinue early on. And it looks like some of these drugs may cause significant hypertension and the hand, foot, skin disease, and the quality of life of these patients are significantly impaired. So how do we select which kinase inhibitor we use? There are some evidence suggesting that lenvatinib may be more effective in non-HCV etiology, those with an increased alpha-fetoprotein, whereas sorafenib may be more effective in HCV-mediated HCC. This is all based on post-hoc analysis or meta-analysis. And if these drugs are not very effective, you can go to the second-line therapy, which is shown below. And if the patient is below 65, you may suggest regorafenib, or above 65, carbo. And this is a monoclonal antibody, again could be used in patients with high alpha-fetoprotein. What about immune therapy? The two studies, Checkmate 040, Keynote 224, both showed that it is better than tyrosine kinase inhibitor. Objective response rate is around 20%. And the side effect profile was much better. Permanent discontinuation was much lower. And a study that wanted to look at immune therapy as a first-line therapy, they compared nivolumab with sorafenib. Large study, the median survival was better, but did not reach statistical significance. One of the problems was the sorafenib arm had higher than expected survival, 14.7 months. One of the arguments was physicians have learned how to manage sorafenib better with time, and patients are taking the medicine longer than the previous registration trial. And the adverse events, as expected, was much lower with the immune therapy. A second a large trial published recently wanted to look at pembro as a second-line therapy. So patients previously with sorafenib were randomly assigned to 2-to-1 ratio, placebo versus active drug. It was statistically significant, as you can see in the blue line. The p-value was significant, and multivariate analysis showed that it is significant. But they had a predetermined threshold for approval. And unfortunately, this trial, in spite of the statistical significance, highly significant, did not reach that threshold, and that was not approved as a second-line therapy, as a monotherapy. So what about my patient? The patient has portal vein thrombosis. The patient had lymph node invasion and a large tumor, not a candidate for any other modalities. So instead of a monotherapy, I decided to try a dual therapy for him because he had an excellent performance status. We used a tyrosine kinase inhibitor, a second line, cabozantinib, and a monoclonal antibody against PD-1. You can see it's only about 2 months since I started. He had 4 cycles of the infusion of immune therapy and the carbo. Alpha-fetoprotein declined from 1330 to 142. Performance status remained good. Abdominal pain disappeared. And on the right-hand side, although the tumor size has not decreased, it looks like there may be more necrosis of the tumor. The patient is having a better time compared to the pre-treatment because of this reduced abdominal pain. What about combination therapy then? This was published in New England Journal recently. 2-drug combination, checkpoint inhibitors plus anti-VEGF infusion. This is a multi-center randomized controlled trial. When you look at that, the hazard ratio was reduced by 42%, and 12-month survival was 67% with dual therapy compared to sorafenib alone. And 1-year survival was 54.6. So dual therapy appears to be better. And there are many drugs trials in progress. As you see on the right-hand side of this table, you can see the objective response rate from around 15 to 20% has gone up to a little more than 30% with a combination therapy. So one of the problems with immunotherapy is that many patients get autoimmune diseases. It could involve multiple organs, and it could be very symptomatic. It could have cause colitis, hepatitis, thyroiditis, and it could involve any part of the body. So many of these patients will require steroids. This study looked at whether steroid at baseline or concurrently used, whether it will affect the outcome. As you can see in the top, it is the prednisone to different doses, less than 10 milligram versus 10 milligram on the first column, and then progression-free and overall survival. There was no difference. So concomitant use of prednisone did not have an impact on immunotherapy outcome. What is the other problem? It looks a very promising drug, and you are going from less than 10% objective response rate to almost 30 to 35%. One of the problems is primary resistance. We don't have a good explanation for that. I will stop with the 2 more slides. It could be low levels of immune infiltrate within the tumor tissue, or maybe activated other signaling pathway, or the tumor environment, microenvironment is too complex. What about the secondary, even less understood? And it is thought, we don't have a lot of evidence, but it could be ongoing and new mutations in the tumor cells. So there are many clinical trials, This field is very dynamic and constantly moving. There are almost 50 clinical trials using combination treatment. At least 10 of them are in phase 3. In the next 2-3 years, we are going to see the role of multiple treatments in HCC, which is not amenable to surgery or transplant. So in summary, systemic therapy is rapidly evolving and it's very dynamic. Current combination treatment appeared to have 30% objective response rate in very advanced HCC. Side effects are a major problem with TKI, but better with checkpoint inhibitors. Use of corticosteroids do not have an impact on outcome with immunotherapy. Primary and secondary resistance is a concern, but we are learning more each day. So patients with advanced HCC and good performance status, one should consider combination treatment as a first line, although it is currently not approved as a first line therapy. Thank you.
Thank you very much, Dr. Paul. That was a absolutely eye-opening lecture because many of us are not quite exposed to these areas. I think I would be failing if I didn't first give the privilege of asking questions or making comments to my fellow panelists. Are you there, Dr. P.N. Rao? I mean,
Yes,
could
yes,
we
yes,
start
I'm
with
here.
you? Yeah, could we start with you? So any questions or comments? Try and make them short. All there are 4 of us, and I think we are almost nearing time. Yeah.
So my question or comment is to Dr. Naveen Kalra. Dr. Naveen, of course, many of the centers, many of the places do not have the luxury of having all the things like an IRE and then where you can alternatives. What about PEI, which has shown about nearly 95 response in people who have got less than 2 centimeters, and 2 to 3 centimeters is shown about nearly 70 to 80%. What do you think about it? Even EASL also recommends that when it is not feasible, otherwise you can still use PEI. Over to Kalra, please.
Can I add a question to what you have asked, PN?
Yeah,
I think
please.
I can see that in the chat box, there has been a question to Dr. Naveen that if you have a smallish tumor where you can do both, that is one of the microwave ablation perhaps, and also TACE. What's your preference? You have actually given us a long list, but how do you choose?
Okay. So, yes,
Two
sir.
questions.
First, I'll take Dr. Rao's question. So he says whether ethanol injection can be used for. The answer to this is yes, it can be used. Only thing is that there is data to show that RFA performs better than PEI, especially when you look at beyond 1 year, like 2 years and 3 years follow-up. That is the time when we see the results of RFA being much better than PEI. But yes, if there are no options, definitely should be resorted to, and definitely still remains an option. And second, sir, that's Dr. Chaudhary's question with the coming up on the chat box regarding combining TACE and RFAI. Is that the question?
No. The question was when both are feasible, what's your preference? Which one would you like to take?
Well, there are clear-cut guidelines when we are looking at tumors being treated up to 3 centimeters. It should be by ablation, which should be either RFA or microwave ablation. On the other hand, if we are dealing with a tumor in the size of 3 to 5 centimeters, it should be ideally a combination of TACE along with ablation. Now, which one to do first? That is the question, and that's always been a point of debate. But usually, the issue is to do TACE first. That will reduce the vascularity of the tumor, and you follow it up with an ablation, which can either be an RFA or microwave ablation, and that will result in less heat sink effect and better effect of the ablation. So that if you have to do both in sequence, TACE first followed by RFA, but there are some studies which have done RFA first, and their take is that when you do RFA first or you do microwave ablation first, you have a surrounding area of hyperemia, and when you do follow it up with the transarterial chemoembolization, this hyperemia area takes up the chemotherapeutic agent. But all said and done, I would go with the sequence of TACE first, reducing the vascularity, making the tumor less vascular, and then doing an ablation so there is less heat sink effect and better effect of the ablation.
If I may ask a provocative question, so what are the equipments that you have in your department?
Sure. So luckily we have almost everything that I showed. So we have RFA.
So how do you choose? I mean, you get up in the morning and how do you decide that if somebody is a candidate for maybe say 2 or 3 options,
Yes,
what makes you decide? Or
well,
is it a part of a trial?
Well, I would again give a kind of provocative answer to that one, sir. So we are looking at doing precision LRT, I would say. So each case we decide as a part of the tumor board, so which in our case would be the hepatologist and the surgeon, and then we would decide which one would suit that patient best. Now, if you have a center which has suppose RFA alone, so I agree with you. They can actually do most of the stuff with that, even in the most difficult locations like the subcapsular, like the lesions close to the gallbladder I showed. This can be tackled with RFA if they kind of use kind of mayors to displace these, the gallbladder away, create artificial ascites. So they may not have the luxury of choosing the other modality. On the other hand, we have that luxury and we have a modality which will not damage these organs. So we use that modality. But yes, I think precision LRT would be the maybe the future for LRT.
Thank you so much. Ashish, are you there?
Yeah, I'm there.
Yeah,
So,
Ashish, over to you. Your questions or comments?
yeah, I would like to ask Dr. Paul Thuluvath a question. This sorafenib, which was approved in 2007, 2008, then over a period of 10 years, we hepatologists had a lot of experience using it. But now with 10 more drugs, cabozantinib, atezolizumab, nivolumab, so are you prescribing them as hepatologists, or are you referring these patients to oncologists nowadays? So because of lots of side effects and dose reductions and then various permutations and combinations. So what do you do?
Dr. Paul, can I pile up a few questions which have come into the chat box? So I think one person wants to know what is the safety of checkpoint inhibitors? I think in one of the slides you did mention it. I think this question was posted a while earlier. And how comfortable are you with the other drug, that is the one which starts with N?
Nivolumab.
Yeah, nivolumab. I find it absolutely tongue twisting. So over to you, Dr. Paul.
I'll take the first question first. This is a question I have been wondering what we should be doing, because with the drugs are increasing in numbers and we are becoming less of expert in this field. So currently what I do is, if it is just oral drug, if I'm just using receptor tyrosine kinase inhibitor only, I tend to prescribe that and I tend to follow the patient. But if I'm going to do a dual therapy, an infusion with anti-VEGF or immunotherapy, unless they are part of a clinical trial program, I send it to the oncologist and ask them to manage that. Because it's becoming more and more complex with our nurses who are not experts in oncological drugs to give this infusion. But if they are part of a study, I still use that medicine. I think what is going to happen, I think I can more and more, because oncologists were never interested in hepatocellular carcinoma until recently. Now they have a number of drugs and they are getting interested, they are keeping up the literature, and I think this will be taken over by the oncologists. I think that's what I think will happen, except some of the drugs like sorafenib and lenvatinib, or even the second-line drugs, we can use it safely. Regarding the second one, I think the checkpoint inhibitors are well tolerated by the patients. They don't have much of side effect unless they get an immune-mediated damage. And if you identify the immune-mediated damage earlier on and treat them with prednisone, they do very well. I think compared to the reverse tyrosine kinase inhibitor, this is a breeze for them. And they have to come for an infusion. That's the only disadvantage. But the side effects are minimal and the discontinuation is very low. So I think the immune checkpoint inhibitor, all these drugs, all these monoclonal antibodies are well tolerated, and we can treat the side effects very easily with corticosteroids.
Thank you very much. We have our third panelist, Dr. Sandeep Dhawan. Are you there? And Dr. Saurabh Mukhewar.
Sandeep, you need to unmute yourself, Sandeep, and Saurabh also.
I'm available. Yes.
Yes, one at a time. So who goes first?
Yeah.
Your comments. Yeah, please.
Yeah. Dr. Paul, does your decision is also based upon the etiology of HCC?
Dr. Paul, the question was that do you base your decision on the etiology of HCV? I think you mentioned once that one of them tends to do better if it is a hepatitis C related vis-a-vis the other one which doesn't do too well. Any comments on that?
We don't have a good data to answer your question, but people have looked at done a post hoc analysis of multiple trials, and during meta-analysis they found that hepatitis C patients with HCC tend to do better with sorafenib, and non-HCV tend to do better with lenvatinib. But lenvatinib was developed by a Japanese company, and if you look at their enrollment in their registration trials, there were more Asian patients. So the hepatitis B was the predominant cause for HCC. So if I were to recommend one drug over other, I would say if it is a hepatitis C etiology, try sorafenib. Hepatitis non-HCC, HCV, maybe try lenvatinib. If you look at the head-to-head study, lenvatinib was marginally superior, although it didn't reach the statistical endpoint as we expected. That was because some of us think sorafenib group did better than they had initially predicted. Our learning process, we know how to manage these patients better these days.
Okay, just 1 minute more. Saurabh, one comment from you.
Sure. Well, this one is a little different for Dr. Sanjeev Sehgal. Thank you for a wonderful talk. Just wanted to sort of ask you about biological criteria for transplant for HCC. And now with the alpha-fetoprotein levels, the level difference, the PIVCA2, the neutrophil lymphocytic ratio have all been sort of shown to have sort of an additional benefit beyond just the Milan criteria for liver transplant. At your center, do you consider all these criteria, or do you take some of these into equation, or what's your take on that?
Can I pile up one more question? This is from none other than Dr. Dharmesh Kapoor, so I better ask this question. So it says that Medanta data suggests that 40% patients having recurrent tumor within 5 years, even if they're not having PVTT. He was a little astonished that the data seems a little too high. So any comments? So one after another.
First, yeah, I mean, Saurabh, that's a very excellent question you put actually, and the biological behavior of the tumor is most important. Now we are using AFP right now. I think that in future we are going to be using more biological markers for this tumor behavior, and right now in our protocol it's alpha-fetoprotein mostly, but the things like NLR and some people are using PIVCA and all DCP, but they are not really used in centers routinely as you would have rightly asked. But I think that we will have these more coming up in future. And recurrence rate, I think that's very much in tune with the recurrence, which we see is about 23% recurrence rate we have seen in our patients on a follow-up. And if you see at these patients who are non-PVTT patients, about 405 patients, which we published in Transplantation Journal recently, we had an overall survival of 89% 1 year, and I think 55% 5 year, which and an RFS of 67% 5 year. So recurrence-free survival of 67% 5 year. I think this is in tune with these patients, outcome. And if you compare world literature, LDLT, I think that's something which is at par. This we published in Transplantation recently. So I mean, I wish we had an option of not having recurrence at all and getting away with transplantation, but I think that is too simplistic to think of. But as of now, I think yes, we are on our strategies to improve our outcome further, and I'm sure we'll have better these sort of questions answered much more in future. Thank you.
Thank you very much. I think it's my pleasant duty to thank three speakers for their excellent talks and the panelists. I think we have marginally overshot time, but it's also an indication to Ajay and Virender that there is so much happening in this area that you need actually a team conference on HPC, because there is too much to cover. But anyway, thanks a lot for giving me the opportunity, and I really enjoyed it. Over to you, Ajay.
Yeah, I think before maybe you all go, I think the response to your question, Professor Chaudhary, you said, and you asked this to Dr. Naveen, we keep saying this in all our meetings, that we are kind of full house at PGI, which means that you name anything and we have it, maybe better than some of the best centers in the world. And with the brilliant interventional radiologists like Dr. Kalra, I think our patients are very, very lucky, I would say that. And thank you very much for conducting it so well. And thanks to the moderator, all the three brilliant speakers and the panelists for that wonderful session. Now let's go on to the next session, and I'll request Professor Virender Singh to invite the moderator for the next session.
Thank you.
Yeah. So the next session is on the biliopancreatic diseases. And I invite Dr. Ajay Kumar, who is a gastroenterologist practicing in Delhi, and he'll be conducting the various the discussions on this topic. Dr. Ajay Kumar, are you there? Yeah.
Yes.
Welcome, sir.
Yes. Thanks, Dr. Virender and Dr. Ajay. I think we are already half an hour late, so I know that we need to stick to our time. So my request to all the panelists and the speakers to please stick to the time allotted to us. None of the speakers require introduction to this audience because they're well known not only in this audience but across the world. Now, first session, which has put as a debate that is a Heiler block, radiological versus endoscopic management. I thought we had already reached a consensus on these issues, but still there may be some areas of concern. But good thing is that we have got two of the best speakers, best known people who are doing work on this to address us today. And of course, the first speaker, a radiologist. Rarely the radiologist gets the first prerogative in the endoscopic meeting. But Sandeep, of course, is a part of the family of Indian gastroenterology. He has been with us, now is in Singapore. So hello, Sandeep. Nice to see you on the screen.
Hi.
And welcome. And we pass it on to you to speak on the radiologist's perspective on the Heiler block. And the time allotted is 10 minutes. We don't have any time for rebuttals or anything. At the end of all the three presentations, we'll take it for questions answered from the panelists. Over to you, Sandeep.
Yeah, thanks, Dr. Ajay. All right. Okay. I'm not sure what consensus we are talking about, but I'll just try to make my point very clear. Well, first of all, it's supposed to be a debate. Of course, this neither looks like me or Dr. Nagi Reddy, but we hope that the decorum is maintained for the rest of this debate. I have unfortunately no chance for rebuttal, but we'll try and get our points through as much as we can. So first of all, Heiler strictures, I think it's known that most patients with Heiler biliary obstruction undergo palliative drainage until the end of their life. And their main treatment strategy is in controlling the symptoms of jaundice, pruritus, pain, in preventing or in controlling the existing infection of cholangitis. And also these patients have chemotherapy, which is actually fairly effective to make sure that it's initiated and continued indefinitely throughout their treatment. Now, radiologically, what we can do is there are actually three things that we can do for drainage. One is what is traditionally being performed, the percutaneous transhepatic biliary drain, where we keep a drain above the level of stricture, allowing the bile to go out. Second is the percutaneous transhepatic external internal biliary drainage, where some amount of bile goes in and some amount of bile comes out. Now, both these methods are very effective and in decompressing the biliary system. Unfortunately, the presence of the tube has its problems. It can dislodge, can cause cholangitis, and create a lot of discomfort. So stents are, in fact, the method of choice for our treatment. And when we come to stents, we know that palliation is not just better with stents. And this happens even with endoscopic therapy. We know that stents are better than nasobiliary drainage. We also know that metal stents are better than plastic stents. So these are established facts. And with these facts, basically, it can be done either radiologically as well as endoscopically. So who should be treating hilar block? Should it be the endoscopist or the radiologist? Well, before we start that argument, I think it's important to recognize the anatomy of the biliary tree. Now, the biliary tree is essentially just a branch structure. From the bile duct goes up. You see the left duct and the right duct. And then further up, it goes into segment 2 and 3, and the right anterior and right posterior draining individual segments of the liver. Now, importantly is when these strictures occur at the hilum, they can occur either point where the two left and right ducts can unite, that is communicate. Sometimes they do not communicate, it becomes type 2 strictures. And when the communication is stopping at the level of the right sectorial branches, it's 3A. When it goes up to the left sectorial branches, it's 3B, and it's a combination of 3A and 3B, it becomes 3-4, segment bismuth 4. So why is that important? Well, traditionally, there's always been thought that 25 to 30% of normal functioning liver, if you can drain that, it's sufficient. So the right duct is about 60%. If you go only into the anterior posterior, you get about 30%. Similarly for the left duct. But for type 1 strictures, if the two ducts are communicating, obviously one stent would be enough because you'll get enough complete 100% drainage, and that can be done endoscopically as well as percutaneously. And in fact, now with low profile devices, we can even put it as a single step procedure. So that's a patient who had a type 1 stricture where a stent has been put, allowing complete drainage and decompression of the entire liver. But when the strictures go up, when they progress up the bile duct and go into type 2 to type 4, I think that's where the argument begins, whether we should have unilateral drainage or should have bilateral drainage, whether we should have a complete drainage or just an incomplete drainage. I think it was, again, traditionally thought that it doesn't matter whether you do one lobe or both lobes, do probably a few segments or not all of them, as long as you ensure that 25 to 30% of parenchyma is functioning, and as long as you ensure that the rest of the parenchymal ducts are not contaminated with the contrast or with the presence of a guide wire. And we always thought that, yeah, 25 to 30% is normal, but that theory has now been debunked. We know that it results in poor palliation of jaundice and high risk of infection, and this was proven in this paper in 2010, which actually looked at patients who had drainage less than 30% going up to more than 50%. Clearly, the risk of cholangitis started dropping as you started draining more and more segments of the liver. And also the median survival, not surprisingly, was much better when you drain more than 50%. So the bar has been raised, and we need to get more than 50% of the liver to be drained out. Now, these patients also undergo chemotherapy. There are some drugs which need normalization of bilirubin. And clearly, the earlier we get this bilirubin down, the better it is for the patient. And therefore, if you can achieve closer to 100% of the liver drainage, it is desirable. Now, if you have a stricture that extends all the way up into the segmental branches, obviously getting 100% drainage can be very, very challenging. So if you have type 2 to 4 strictures, again, you need to make sure that you drain as much as you can, but make sure you drain the correct lobe if you're not draining the whole lobe. And important to recognize which lobe is atrophic. Do not drain that because that does have no clinical benefit and produces, in fact, cholangitis. Look for variants, and what we use sometimes is just eyeballing on liver volumetry, tell us exactly how much volume of liver we are going to be draining out. And that can be done with the aid of 2 stents on the left and right as parallel stents. We can done with 3 stents, again placed parallel. What happens at the level of the hilum, all these stents actually become much narrower. So 10 millimeter duct actually stent becomes like a 5 millimeters stent on each side. So we can overcome that with the help of stent, a stent-in-stent approach where you can place stents to the left, right, anterior, right, posterior. In this case, we've actually gone even subsegmental into the duct. So we've got something like 4 stents, 4 areas that have been drained out. Also, patients can be drained out from one puncture, that's from the right side. We go on to the left and place a stent in a T approach. So another important thing is, if we are draining the bile, we have to make sure that we do not risk cholangitis. We do not contaminate the other lobes. As in this case, who had a hilar malignancy, a stent was placed in the right duct. You can see clearly now this patient actually has dilated system all around. It's only one segment that has been drained. This patient had fever, hyperbilirubinemia, jaundice, and therefore had to undergo a percutaneous drainage. As you can see here, there's the right posterior duct which you managed to cross and stent, and then later the left duct also was added on. So you could actually drain virtually the entire liver in piecemeal if you didn't want to do it one up. And that's what the stent looked like. So big question is, who should be treating hilar blocks? Well, it should be the endoscopists or radiologists. Well, there's been only one randomized trial which clearly benefited percutaneous drainage. You can see success was far more in the percutaneous arm. Complications were low and improved quality of life with percutaneous approach. If you look at the randomized studies, non-randomized studies, again, were showing benefit of percutaneous in the means of therapeutic success and the time to achieve drainage. And keep in mind that one of these studies, in fact, had 33% of endoscopic arm crossing over to the percutaneous group and none all going the other way. In fact, the Asia Pacific guidelines, which were published a few years ago, again said the same thing. Moment you have bismuth 3 and 4, percutaneous stenting is superior to endoscopic stenting. And in fact, at the same time, we had this meta-analysis, which actually said that in patients advanced unresectable hilar malignancies, palliation, percutaneous drainage seems to be superior to endoscopic drainage. And in fact, it is not again surprising because this was, of course, a few years ago, but they graded hilar cholangiocarcinomas for endoscopic intervention as one of the most difficult interventions, grade 5 interventions, when you needed multiple stents to be done with a much higher failure rate. So insertion of more than one stent can be very technically challenging for the endoscopist and not at all for the radiologist. We can easily put more than one stent. We can put drain more than one lobe. We can drain more than one segment with much better results in reducing the jaundice and preventing cholangitis. But of course, my dear colleague will obviously talk about using endoscopy. So to a man of the hammer, everything looks like a nail. So you can use a scope. You can certainly drain a lot of segments and a lot of things that I've shown you. Well, the major argument that he's obviously going to bring forward is going to be that percutaneous interventions have a lot of problems. You need multiple stages. You can't do a lot of things, but it has evolved over time. We are now able to stent in one single stage. We don't have to get them in 3 stages, which are traditionally done, as in this case where we manage to stent this hilar stricture and remove the drain. In patients with ascites as well, we can actually plug off the track. The ability to biopsy is there, ability to scope the bile duct is there, ability to form endobiliary RFA is also there. So you can do exactly what the endoscopist can do. Of course, there are complications with every procedure, and then it's no different with percutaneous drainage and stenting. But if you compare that with endoscopic stenting in cancer patients, realize that there is no much difference in the success and the mortality rates. Percutaneous procedures do have problems of bleeding, bile leak, dislocation, but pancreatitis is also has issues such as cholangitis, pancreatitis, and perforation. So what about endoscopic ultrasound guided biliary drainage? I think that's a new kid on the block. Will the interventional radiologist become again morph into a diagnostic radiologist? Good question. Well, I'm sure these pictures will be shown later, where they're doing all these kinds of drainages, bilobar drainage done from a single approach or from multiple approaches through the papilla, through the duodenum, through the stomach. Well, just to tell you that percutaneous drainage is something that's been done for many, many years, done in almost all centers with almost 100% success rate. With endoscopic drainage for hilar strictures, certainly does not enjoy the same rate of success. It is, of course, much safer because you're doing moderate sedation versus deep sedation, and again, economically far more viable. Again, the numbers with hilar strictures treated by endoscopic ultrasound guided drainage, very, very few. You're talking 4, 11, 12. This is what we do in a month. I mean, this is over many years now. So as I see it, endoscopic biliary drainage is an extension now of endoscopic interventions, is actually just a very complicated process. You really don't have to keep it that difficult and just keep it as simple and, as you can. Thank you very much.
Thanks, Sudeep. Can you stop the screen sharing there?
Sorry.
Okay, well, friends, first of all, thanks, Sandeep, to sticking to time. And of course, it's always good to be provocative for the debates. And even if there is a consensus, let's make it a debate. And with that, I will straightway go to Nagi. Of course, Nagi doesn't require any introduction to anybody across the world. And to put up the endoscopic perspective on radiological versus endoscopic management in a hilar block. Is it a teamwork or is it a you or me? Is it a Putin or Biden, or is it a teamwork? I mean, let's listen to him.
Thank you, Ajay. I'd like to thank Virender and Ajay for giving me this opportunity. I think before we actually start this debate, I'd like to put 3 facts in front of you so that we're on the same page. First of all, Hylar block is not a single entity. It's multiple, like type 1, type 2, type 3, and each of them have different modalities. Number 2 is that when you talk about endoscopy versus radiology, there are 2 aspects. It could be ERCP versus percutaneous drainage, or it could be endoscopic ultrasound versus percutaneous drainage. Now, level of evidence for EUS is not as good now. So I won't debate on that. What we're going to talk about is conventional ERCP versus PTBD and what's the difference and what we should do. The third important point I'd like to put forward is that Hylar block could be benign malignant. Now, for benign blocks, it's very clear that for indeterminate strictures, endoscopy is superior to percutaneous assessments. And therefore, I won't again go into that because of paucity of time. But when you talk about malignant block, palliation and preoperative are 2 separate aspects. There's a lot of evidence in the literature to show that for preoperative blocks, endoscopy is superior in terms of ENBD, which is being done frequently in these cases. So what we now are debating predominantly is malignant blocks with palliative intention in this patient. So when you debate in this, of course, each of us radiologists and endoscopists have their own perspectives, but I'll try and be as neutral as positive in this case. In fact, the literature sums it up very well in this JAMA Oncology article, which says that there is not enough data. The published literature to support either of these is very sparse, conflicting, and small studies, heterogeneous group. This actually sums up the whole thing. In fact, I don't have to go further in this debate. Just give this slide and say, we still have to decide further. But let's start with evidence. And evidence is, of course, randomized controlled trials or meta-analysis. Now, randomized controlled trials first started in 1987, the famous Lancet article by Peter Cotton and his colleagues, we showed that endoscopy is superior to percutaneous. But unfortunately, this was done mainly for lower tumors. You can see only 29 by Hylar. And look at the second study, which showed that percutaneous was superior in radiology long back, where they compared metal stents radiologically versus plastic stents endoscopically. So I think both these are now, of course, can't be taken. But the first RCT, good RCT, actually came from All India Institute of Medical Sciences, Piusani and Pramod's group, which took patients with gallbladder cancers and, of course, compared PTBD versus ES and showed very clearly that PTBD was superior in terms of successful drainage, early complications, early cholangitis. The problem with this study was that most of the cases were type 3B, and also they used plastic stents and not metal stents. So there's some doubts about this. The second study, it was not a randomized control study, but a large retrospective study of more than 100 cases, which looked at endoscopy versus percutaneous SEMS from Korea. And again, very clearly showed that successful palliation was better with percutaneous rather than with endoscopy. And again, the problem was most of these patients were type 4 strictures, few with type 3B strictures. So based on this, the Canadian Journal of Gastroenterology, the previous RCT, which Sandeep showed, concluded that PTBD was superior to ERCP and adverse effects were actually less and comparable. And therefore, that should be there. But the problem is, if you go through this meta-analysis very carefully, there are 7 of the 8 studies, 3 RCTs, and 5 of them are actually retrospective studies, very low JADAD score. And therefore, to take this as the gospel truth would not be right. So what is more important is actually to divide our patients into different bismuth types and see what is more effective. And this is where we don't have many RCTs. This is the major study which is published from Korea again, which took patients into 3 types, bismuth type 2, 3, and 4. And again, I don't want to go too much into the details, but they clearly showed that for bismuth type 1, endoscopic drainage was as good as percutaneous drainage, little more complications with percutaneous. For type 3, again, both were equal, but for type 4, percutaneous was surely superior. And of course, in the setting of surgery, preoperative, it is very clear now. This is again a major study which came from Japan, showing that percutaneous had much more adverse effects, especially in terms of long-term survival and metastasis in these patients because of percutaneous approach, showing that endoscopy was superior. So this is a special category. Again, I won't go too much into this, but sort of summarize, this was a very good recommendation which came from ESG, which clearly
sort of just, I'll read through this because it's very important. ESG suggests for palliative drainage of malignant hilar strictures by means of ERCP for bismuth type 1 and type 2, PTBD or a combination of ERCP for bismuth type 3 and type 4 to be modulated according to the local expertise. Of course, all of this was low quality evidence because we don't have good RCTs. But this, I think, very clearly summarizes our current thinking in these cases. Of course, there are clear, obvious indications for endoscopy or PTB if you have a patient with gastric gout obstruction, comorbid condition, and a papilla which can't be identified in endoscopy, then you go for PTBD. But the coagulation problem, ascites, or lack of expertise percutaneously, you go for endoscopy. So this is very clear. So just to summarize what I was trying to say, if you have type 1 obstruction, even with an average endoscopy skills, I would still suggest endoscopy. If you have a type 2, if you have good endoscopy, do endoscopy first. PTBD would be one option. For type 3, especially for type 3B, I would suggest PTBD. For type 3A, endoscopy. And type 4, there's no doubt about it. I think PTBD, radiological intervention, is much superior in these cases. And again, as Sandeep emphasized, what is more important to realize, not which method, but how much to drain. It is now very clear that you must drain more than 50% of the liver for adequate drainage, whatever method. So you plan your drainage before. If you have an expertise, a good expert like Sandeep in your unit, then you're going to go for endoscopic drainage. But if you have somebody who's going to produce a recurrent problem percutaneously in a unit, then of course you try and do more endoscopic drainages. So this is very clear. And just to again summarize what I was trying to say, if for hilar malignancy, if the diagnosis is in doubt, indeterminate strictures, first choice is endoscopy. For palliative biliary drainage, if you have type 1 and type 2, it's endoscopy, ERCP. For type 3, depending on the expertise, expert like Sandeep, you go for PTBD. Otherwise, you'll do endoscopy. For type 4, irrespective of whichever center you're practicing, I think it's percutaneous biliary drainage. For preoperative biliary drainage, endoscopy is clearly the choice, and that is many studies. But again, I'd like to emphasize here very, very strongly that this should not be a single approach as an endoscopist or radiologist, but it must be a multimodality approach. In many occasions, we've actually done a combined procedure. The percutaneous, I think actually I did one with Sandeep also, I remember, where the radiologist gives the guide wire to us endoscopically, and then we go in using this guide wire. So it's both working together. So multimodality approach is extremely important in these cases. And finally, I don't like debates. The reason I don't like debates is that this famous Italian saying says that even a clock which is not working is right twice a day. So whatever statement you make, you'll have something to support in the literature. So it's difficult to decide just based on a debate. So what in fact I would suggest for a hilar block is not whether we should do radiological endoscopic management, but we should decide when, which, and how. Thank you for your attention.
Thanks, Nagi, for a wonderful putting up your point, at the same time sticking to the time and making the whole thing lively. Actually, I am tempted to stop in between and start the discussion here itself, but I think the time does not permit me that. I think I'll come back to the discussion after the next presentation. Next presentation, another reputed speaker known to everybody across the country and abroad. Pramod from All India Institute. He will talk to us on IgG4 sclerosing cholangitis. Over to Pramod, and we all stick to our time so that we can have some useful, valuable discussion at the end of it.
Thank you, Dr. Ajay Kumar. I'd like to thank the organizers, Dr. Virendra Singh and Ajay, for inviting me for this meeting. For those of you who like tennis, let me update you on the score. Nadal leading 6-0, 5-2. So that's one of the advantages when you are at home and watching both tennis and listening to the wonderful talks being presented here. So IgG4 sclerosing cholangitis is something that is not discussed often, but with increasing imaging modalities available, this is being recognized more commonly. So let me present with a typical case. A 77-year-old male presented with jaundice for 3 months, anorexia, weight loss, mild abdominal discomfort, no fever, GI bleed, had diabetes for 5 years. So this is a typical setting where an elderly male comes in with jaundice and is diabetic for making the diagnosis of pancreatic cancer. That is what people thought. His bilirubin and SAP were raised. Ultrasound showed IHBR dilated, CVD dilated, and pancreatic head was enlarged. He underwent ERCP and a CVD stent was placed. diagnosis was made CA pancreas, referred to us for further evaluation and resection. When we saw this patient, we found on EUS, which was done for resectability to look at vascular involvement, diffusely enlarged hyperechoic pancreas, MPT was not dilated, and there was no discrete mass seen. And then we thought it could be autoimmune pancreatitis, did an MRCP, which showed enlarged pancreas and stricture of the intrahepatic and extrahepatic bile ducts. This is the typical pancreatic parenchyma here. And my friend, Dr. Madhusudan, is going to show many more pictures. This is just introducing the topic. And this is the picture of the MRCP showing diffuse biliary ductal involvement. His IgG4 was raised, and we diagnosed him having type 1 autoimmune pancreatitis with IgG4 related sclerosing cholangitis or cholangiopathy. So this is actually a disease which affects multiple organs in the body, and that's why it is said it is IgG4 related disease rather than just sclerosing cholangitis or pancreatitis. And you can see here multiple sites in the body can be affected. First described by Kawaguchi from Japan. Actually, most literature has come from Japan in 1991, where they called it lymphoplasmacytic sclerosing pancreatitis and realized that it does involve bile ducts. And it was 1995, Yoshida et al. Termed it as autoimmune pancreatitis, and 2001, high serum IgG4 levels were associated with the disease. So this is the background history about the disease itself. But important thing to realize is it's a systemic disease with predominant involvement of one particular organ system. In the pathogenesis, basically IgG4 producing B cells which proliferate, but other T cells also participate. It's not clear if it is a disorder of the B cells, something like a pre-neoplastic or a benign neoplastic disease where IgG4 related producing B cells proliferate, or it is an autoimmune disease. But majority of people would prefer it as an autoimmune disease. It is also unclear if IgG4 is pathogenic or it is just a bystander, but we are not discussing that today in terms of pathogenesis. But suffice would be to say that there is an expansion of the IgG4 switch B cells in these patients, which could be a result of effect of multiple T cell types. So it's an IgG4 related disease. 90% of patients have associated autoimmune pancreatitis in them. On the other hand, if you look at patients with autoimmune pancreatitis, 40% of them have biliary involvement. And this I'm talking about type 1 autoimmune pancreatitis. Overall, the incidence and prevalence, these are data from Japan, about 1.4 per 100,000 population incidence, and prevalence about 4.6 per 100,000 population. Just to remind the postgraduates that when we talk about IgG4 related disease, we are only discussing type 1 autoimmune pancreatitis associated with sclerosing cholangitis. Type 2 is not IgG4 related, and that is something which is out of the picture for this discussion. In the clinical features, the disease presents basically in the 7th or 8th decade of life, but can be seen earlier, and I'll show an example. More common in males, much more common in males. They usually present with chronic or recurrent cholestatic jaundice, which is often painless or maybe mild pain. Often are diabetic, they complain of weight loss, and there may be other system involvement in this, which is very important. Site of involvement in IgG4 cholangiopathy, Dr. Madhusudan is going to talk a little more about that. For 518 patients data, majority have lower end intrapancreatic block, 64%, but I'm not going to dwell on that now. If you talk about the diagnosis, most commonly we perform IgG4 levels, and the level should be more than 1.4 gram per liter, which is seen in about 80% of patients. The issue is that it is also raised to that level in about 10% of patients with PSC, 15% of patients with cholangiocarcinoma, and also 5% of healthy people. So it is not that specific. And particular problem comes in those who have got primary sclerosing cholangitis with raised IgG4. There you get confused what to do, what is the diagnosis. So if you raise the cutoff level to 2.8 gram per deciliter, your specificity increases to 90%, but of course, at the cost of sensitivity, which goes down to about 50%. Pathology is characteristic, but the problem with pathology is that unlike in autoimmune pancreatitis, where we have an opportunity to take biopsy from the pancreas, that is not the case with bile ducts. And when you talk about bile duct involvement, it is often on surgical specimen that a characteristic pathology may be seen, which comprise of dense lymphoplasmacytic infiltration, obliterative phlebitis, and storiform fibrosis. More important, and that I like the postgraduates to note here, that epithelium is normal in autoimmune cholangiopathy, unlike in primary sclerosing cholangitis, where the disease involves the epithelium. And one of the diagnostic features is more than 10 per high power field IgG4 positive plasma cells. A typical picture of a storiform fibrosis from a patient with autoimmune pancreatitis, not from bile duct. And you can see here the IgG4 related plasma cells being positive. So very important to understand the differential diagnosis. Lower end stricture, it is CA pancreas. Hilar obstruction, cholangiocarcinoma, diffuse involvement, primary sclerosing cholangitis. And I'm not talking about other uncommon diseases here. So uncommon presentation could be, for example, this lady, 34-year-old lady, came with cholestatic jaundice for about a month. She had anorexia and weight loss. Imaging showed hilar obstruction. And obviously, although her age was young, we thought it is cancer of the gallbladder or cholangiocarcinoma. We did an EUS to find out the mass. We found a mass in the gallbladder at the neck, which was obstructing the bile duct. She was operated as a case of CAGB, turned out to be IgG4 involving gallbladder and bile duct. So that's an unusual presentation. Now, with this, I will hand over the floor to Dr. Madhusudan, who is an additional professor in the Department of Radiology at AIIMS, to talk about the diagnosis of IgG4, which is primarily dependent on imaging. Over to Dr. Madhusudan.
Dr. Madhusudan, can you unmute yourself?
Yeah, so I hope I am audible. Hello?
Yes, you are. Yes, you are. Go ahead.
Yeah. Yeah, so the role of imaging in any patient with a suspected biliary disease, and in this case, in a patient of IgG4 sclerosing cholangitis, is in defining the morphology and the extent of the biliary strictures and the duct wall thickening. In addition, because it is a systemic disease, it also helps in identifying involvement of other organs. Further, imaging also helps in assessing the treatment response in these patients. These are the list of imaging modalities which are available, but most important is the MR, because there are some specific features which MR detects and helps in suggesting a diagnosis. So ultrasonography is the first investigation in most of these patients. It may show the HBR dilatation is usually mild because it's more of a benign disease. One important characteristic is the duct wall thickening. So you can see here the duct wall thickening is very sharp. You can see the inner margin as well as the outer margin, which is very well defined. And despite the presence of wall thickening, the lumen is seen. So this is one of the characteristic feature of IgG4 related sclerosing cholangitis. And then you may see associated autoimmune pancreatitis as well in the form of bulky pancreas. CT scan, again, when it is done as a case of pain abdomen with jaundice, so you can see here the duct wall thickening. This is the CBD, which is showing gross thickening with lumen still patent. And then there is this autoimmune pancreatitis with a rind of soft tissue around the pancreas. Or sometimes when it is hilar involvement, you can just see dilated ducts and the duct wall thickening may not be seen on the CT scan. MR is more sensitive in picking up these lesions. There are some specific features. So in this case, it's an extrahepatic duct involvement. You can see the entire extrahepatic duct is showing this wavy kind of an outline. And on axial sections, you can see the duct wall thickening. So this is characteristically dark on T2 weighted images because of the extensive fibrosis which is deposited within the thickening. And then the margins are very sharp, unlike a case of any other differentials like cholangiocarcinoma. And then this segment shows gross restriction of diffusion. So these are the diffusion weighted images where it is bright, and then there is a hypointense appearance on the ADC maps. Then there was associated autoimmune pancreatitis as well in this case. Then you may have both intra and extrahepatic duct involvement, which is less common than the extrahepatic duct involvement. Again, this shows extensive long segment strictures in this case, unlike a PSC where usually you see short segment strictures. And then this is the T2 hypointense wall thickening, and then the duct wall enhancement, which is again characteristic of IgG4 cholangitis. Then sometimes uncommonly you can see a mass kind of presentation. Here these are the T2 and T1 weighted images. You can see the hypointense mass which is seen right at the hilum, and then this characteristic feature is the progressive enhancement on injection of the contrast, because again it is the fibrous nature of the lesion which is responsible for this kind of contrast enhancement. Okazaki et al. In Japan has classified the IgG4 sclerosing cholangitis into 4 types, again based on the anatomical site of involvement. Although this does not have much clinical significance, but more important is to define a differential diagnosis and to define what is the next step of investigation whenever any whenever a lesion involves any location. The other organ involvement is another important feature which can be identified on imaging, the autoimmune pancreatitis being the most common one. And then you may see involvement of the kidneys as well, which is the second most common site in the form of hypointense lesions in the renal parenchyma, or they may be associated retroperitoneal fibrosis, as in this case, enhancing soft tissue around the aorta and encasing the celiac trunk as well. The diagnosis is mainly based on the HISORT criteria. HISORT stand for histology, imaging features, serology in the form of elevated IgG4 levels, and other organ involvement, and response to steroids, response to steroid treatment. And they have said that presence of imaging findings of the specific organ and other organ involvement. So when these two are present, then a definitive diagnosis can be made, and hence histology is usually not necessary. So this is where imaging plays an important role, and in the absence of other organ involvement, histology is required for making a definitive diagnosis. Differential diagnosis most common include the primary sclerosing cholangitis, which involves both the intrahepatic as well as the extrahepatic ducts, and the strictures are usually short segment, unlike in IgG4 disease where you see long segment strictures. The duct wall thickening is usually not seen, unlike in case of IgG4 sclerosing cholangitis. Then you can see the beaded appearance, which is relatively characteristic for primary sclerosing cholangitis. And again, the liver parenchymal changes are commonly seen in primary sclerosing cholangitis compared to IgG4 sclerosing disease. And the other important differential is cholangiocarcinoma, especially when the disease involves the hilum. Then it becomes difficult to differentiate from cholangiocarcinoma. But again, you can see that the enhancement pattern is very asymmetric and is very with ill-defined margins. So unlike in a case of IgG4 disease where you can see a very well-defined margin and well-defined thickening. So this is one point which may help in differentiation of IgG4 sclerosing cholangitis from cholangiocarcinoma. But again, in difficult situations, cholangioscopy, biopsy, and other parameters are needed to make this differentiation. So to conclude, I would like to say that it's IgG4 sclerosing cholangitis is a biliary manifestation of systemic IgG4 related disease. Imaging, especially MR, is very important in making the diagnosis, defining the extent, and also in follow-up of these patients. HISORT criteria is required for making a diagnosis. Differentials include PSC and cholangiocarcinoma. Thank you for your kind attention.
Thank you, Madhu. If you could stop sharing. So after we have heard about the imaging, which plays the key role in making the diagnosis, there are patients in whom one does find that there is a problem. And Madhu has already talked about the diagnostic criteria. Biliary tract imaging is the most important. Second is other organ involvement. And typically we are talking about pancreas when we talk about IgG4 sclerosing cholangitis. Then comes IgG4 concentration. And then you have histology and other things. So histology is last because often you don't get histology in patients with cholangiopathy. So definite diagnosis, again, to reiterate, 1 plus 3. 1 is biliary tract, 3 is other organ involvement. Or you have 1, 2, that is IgG4 plus histology, usually unavailable. And if you have steroid response, it is probable diagnosis, not a definite diagnosis. So what do we do if we are faced with this major differential diagnosis here? If we have lower end block, we do EUS-FNA from pancreatic head mass or pancreatic head. And often we should take ampullary biopsies because this can show you typical features. If there is hilar obstruction, if you are not able to differentiate, best to do surgery. And I would recommend that don't beat around the bush and do this and that. It might be better the patient undergoes surgery if you have a hilar block, because missing cholangiocarcinoma will be more dangerous. If you see a mass, and sometimes there is pseudo tumor in IgG4 cholangiopathy, then we can do EUS and FNA, and sometimes we resort to cholangioscopy and biopsy. But the problem with cholangioscopy, if you have a lower end stricture also and a hilar stricture, it becomes difficult. Another problem is the more you fiddle around in the bile duct, more infection you are going to introduce, and there will be problems with that. Sometimes in diffuse involvement, if you have you're confused, a patient is fitting more into this, you can give a trial of steroids, short trial. And that brings me to the treatment part. Steroids is the treatment of choice. Indications would be obstructive jaundice and symptomatic extrapancreatic lesions. The reason I'm saying symptomatic is in some patients who are absolutely asymptomatic, there is no treatment is required. They get better on their own. And many patients require biliary drainage. So this is the treatment approach. Start steroids. Some patients have biliary drainage done if the bilirubin is high, and then gradually taper off over a period of 3 to 6 months. Most Japanese experts recommend maintenance therapy for 3 years, and I'll tell you why. And we need to monitor the course throughout the disease. The second part of treatment is biliary drainage with the RCP and stenting. Unlike the debate we had, here there's no debate, it is endoscopy stenting for most patients. The question is, can we do away without biliary stenting? So there is some data, one is from Mayo Clinic, small numbers of patients, type 1 autoimmune pancreatitis with jaundice, mean bilirubin 5.9, and they showed without stenting, patients got better. Another series came from Japan, which also showed similar findings. So in some cases with mild jaundice, one can safely start steroid under supervision and see patient's response over a period of 1 week, and then decide whether or not ERCP is required. Because mind you, ERCP is not without complications. So do we need maintenance therapy? This was a randomized trial published by Masamune from Japan, 131 patients with type 1 autoimmune pancreatitis with biliary involvement. And they divided patients into those who received long-term maintenance therapy for 3 years versus those who received for 6 months. Because this is 6 months therapy is generally recommended, and they found the relapse rate was much higher. Those who received 6 months therapy, only 57%. So in bile duct involvement, better is to give low dose maintenance therapy of steroid 5 to 7.5 milligram per day. How do we treat for relapse? There is no gold standard, but steroids with the same dose are generally used, but you taper it more gradually and continue it for a much longer period of time, to 3 to 5 years. Sometimes we use azathioprine as a steroid sparing agent, but overlap with steroid for 6 to 8 weeks. There are not enough data about rituximab, which is used in patients who relapse frequently and are resistant. Otherwise, it is not generally used. Predictors of relapse are presence of proximal biliary stricture, extensive multi-organ involvement, very high levels of IgG4, and persistently high serum IgG4 even after treatment for steroids. So this would suggest that you need your maintenance therapy much longer for at least 3 years. Prognosis is excellent. Relapse may be high if you stop it early, and there could be a need for maintenance therapy. This is the algorithm. I took it from a Japanese guidelines published last year, that if you have IgG4 diffuse disease and you have other organ involvement, go straight to steroid therapy. If it is not there, other organ involvement, then you need to find out whether it is type 1, type 2, type 3. Type 3 and 4, they would recommend surgery. And this is important. Type 1, lower end block, you can give a steroid trial. Type 2, you have to go for further imaging before you treat the patient. This is our small experience at AIMS. We have seen about 12 patients in last, I think, 4 or 5 years. Mean age varied from 34 to 77. 3 patients were operated, 1 for tail mass, suspected of cancer, 1 for suspected cancer head, and 1 for suspected carcinoma gallbladder, which I showed you. 1 was asymptomatic, did nothing, he's doing well. 2 were asymptomatic and spontaneously improved, didn't require steroids, and 2 patients required maintenance as a thiopurine. So, like to summarize, ladies and gentlemen, that autoimmune IgG4 sclerosing cholangitis is being recognized more commonly now. It's a benign disease. Correct diagnosis avoids major surgery. Steroids have an excellent response, and must rule out PSC, cholangiocarcinoma, and CA pancreas. Thank you very much for your kind attention. Happy to take questions.
Thanks, Pramod, for covering so much of area in such a restricted time and then still sticking to your time. That's the wonderful thing. Well, friends, we have about 10 minutes for the discussion and we have 5 panelists. I don't see Dr. Kocher there. I think he was stuck up somewhere a short while ago. We did talk on phone. Maybe he will join in between. But I think the first I straightway come to the panelists, and Mahesh is there. Mahesh, what is your take? Any questions to the any of the 3 panelists? You can take up subject by.
I think hilar block issue, I think Ajay, as you started, is more or less well settled. For the early hilar blocks 1 and 2, we go for endoscopy, and for 3 and 4, we look at the radiologist colleagues all the time. I think US is coming up, but then I have a little issue about most of the studies which have been done on the US, that you have to have a good radiologist in that study, and then only you can do a good comparison between US and PTBD as the 2 comparative modality. I have only one question for Pramod. We also see IgG4 disease, but not too many, maybe 1 case every 3 months or 4 months. But we see more tubercular strictures than IgG4 strictures. So what is your viewpoint about that as a differential diagnosis for us? And we will still take a biopsy, if not to confirm the diagnosis of IgG4 disease, but to rule out some of the diseases, including tuberculosis and carcinomas.
So thank you, Dr. Goenka, for this question. I'll take it up. But before that, can I just make a small point about hilar blocks? Although I wasn't part of that, but because our study was quoted, that's why I think I must make that point. So in patients with type 2 block, let's understand the hilum is involved. Often the postgraduate think hilum is not involved. And the moment hilum is involved, it is important that you go and drain the system that you contaminate. The moment you do endoscopic therapy drainage, it is often that you have to drain both the lobes. Draining both the lobes endoscopically in the first place is difficult and often not possible. So when we published a study, the comment that we got from the reviewers was that you probably don't know how to do endoscopic stenting, because in endoscopic stenting, we place one side stent, cholangitis rate was 40%. So we had to give them our data of the lower end malignant block in peri-amperi and CA pancreas to show that we do know something about endoscopic stenting. Now, the problem here is that moment you drain one system endoscopically, within a 30-day, you will have 40% cholangitis, not next day or a week, in a month's time. And if you place a metal stent, you are now bound to do PTBD rather than endoscopically. You can't put endoscopically the stent on the other side. That's it. Okay, so before getting into the debate, let me answer Dr. Goenka's question. So this is very important. Tuberculosis is something that we see now and then. The major difference there is that in tuberculosis patients are mostly young patients. And we definitely try and rule out tuberculosis in our patients. We have had patients with hilar strictures presenting with tuberculosis. In fact, one young boy was operated also, although because we failed to make the diagnosis. Other young girl, we made the diagnosis. So if there is a confusion, I think cholangioscopy and biopsy should be done. But other system involvement, RAGE IgG4, CT chest, these are many modalities would help you diagnose tuberculosis compared with others. And I think, as you said, tuberculosis might be more common in Indian setting than IgG4 related disease.
Okay, let me just butt in here before I go to the next panelist. I'm not sure if Nagi is there because I see his mic is still silent. See, if you come back to the debate which Mahesh, the point raised and the point mentioned by Pramod, Sandeep, if I see the debate restricts to the 2 and 3A. Rather than 3B and 4, the endoscopists concede that the percutaneous approach is better. Type 1, you concede that the endoscopic approach is okay. So the whole debate actually comes to not only, let's not talk about either block, let's talk about type 2 and type 3A. I mean, Pramod has already talked about this. Obviously, the persons advocating more of endoscopy will talk about bilateral metal stenting, which technically is definitely a challenging issue, but is doable in expert hands, and we are doing routinely. Any comments on that, brief comments, and then we can go to the next panelist, and I'm coming on to Manish Chhabra after that. Yes, Sandeep.
Dr. Ajay, I would like to make a comment on this hilar blocks. Yes. Let Dr. Chhabra speak.
No, first let's Dr. Sandeep comment on this.
Okay. Yeah, I think I sort of agree with you that for type 1, it could be either endoscopic or percutaneous. In fact, at our centers, endoscopy is given the first shot. If they fail, they come to us. It's type 2, which I think it's a bit of a mixed bag, and that's largely because the level of stricture, first of all, deciding exactly whether it is really indeed type 2 or moving to type 3, I think that onus lies on the diagnostic radiologists, and often it has been underreported, and they just call it as a biliary stricture at the hilum without any kind of stratification as to what kind of stricture it is. And invariably, these patients are actually what is thought to be type 2 on the naked eye actually turns out to be a type 3. And these patients land with cholangitis quite often. So I think it's important, very important to interpret the scan and differentiating a type 2 from type 3. Now, if it is type 2, I think if the endoscopist is able to drain the correct lobe, when I mean correct lobe, it's no point draining an atrophic lobe, no point draining a lobe that has a portal vein thrombosis or a segment that's a lobe that's just, very tiny parchment left lobe. It's no point draining that. It's important to select the right lobe and get the wire in. And the point is well taken about contaminating the other side. Yes, indeed, that you do get contamination, especially if you inject contrast at very high injection rates, high pressures. So you have to be really careful when you do that. Yeah.
Okay. Before I go on to Manish, Professor Virender Singh, you wanted to say something on hilar block?
Yeah. The management of hilar blocks, especially malignant, is very tricky. See, there are few things which are important. One is that in that study which was published from All India Institute, as Dr. Nagi also pointed out, they had put up plastic stents only. And that was the flaw in that study. And the other study which was published in GI endoscopy in 2010, those were patients with the cholangiocarcinoma. In that too, they had put in a multiple stents, but they were also the plastic stents. Nobody puts a plastic stents now, especially if it is type 2 or type 3. So the next one is, if we ask for the guidelines are very clear. If it is type 1 block, there is no point in asking for a PTBD. If it is type 2 block, if it is carcinoma gallbladder, these patients don't survive for more than 6 months. Even if you put a single stent on the right side, that will be sufficient because you will drain more than 30%. The problem comes if there is a type 3 or type 4 block. In that, we may need help of the radiologists. So the most important is the contamination. You should fiddle with the system less and less. So even if you are putting a single stent on the right side, that is sufficient. But the problem with the radiologist is that you ask for the PTBD, and most of the time they will do a PTBD of the left side. If they do a PTBD of the left side, and this is the isolated stricture, in that case, this is not going to drain more than 30%. So if, on the other hand, if you put a endoscopic stent, that is a metal stent, and if you put it on the right side, which happens most of the time, our guide wire goes to the right side, and you don't contaminate, use the air cholangiogram. In that case, if you put a metal stent, that is going to suffice, and even a single stent is sufficient in such a patient.
Okay. I think enough has been talked about the hilar block debate. And okay, Manish, over to you. Any questions to any other panelists on any issue of the two?
Just a comment small that it's not important what you can do. The patient's perspective is also very important in hilar blocks. It's an intentional benefit versus an unintentional harm, especially in these cases which you can do. And these days, this unintentional harm of doing a cholangitis is perceived as an intentional harm. So it is very important before we embark upon of palliation is to define our intention and also think of the consequences of doing that. So
basically, select the patient right. Both the approaches work as a team, and consensus is that to select your right patient for each procedure, and quite often you work together to achieve the adequate result for the patient. Well, Dr. Surinder Rana, I can see you now. You were hidden till now. Yes, please. You have a huge experience in both the diseases discussed, any of your comments and questions to any of the panelists.
Thank you, sir.
Well, your choice is restricted to Pramod and Dr. Madhusudan and Dr. Sandeep, because Nagi I don't see here. No, I think must be some technical issue or something. I don't know. Okay.
Thank you, sir. At the outset, I would like to congratulate all the speakers for an excellent talk. My question was regarding isolated IgG4 sclerosing cholangitis, because that would be a little difficult diagnosis. There is no extra bile duct involvement and there is no pancreatic involvement. In this situation, what would be the role of cholangioscopy and intraductal ultrasound?
Thank you, Surendra, for this very important question. First of all, I think let's make sure that this happens in only less than 10% of cases. So first of all, IgG4 sclerosing cholangitis is very uncommon. Then only 10% of those will fit into what you're saying, that there is only hilar or intrahepatic involvement, as Dr. Madhusudan has shown. Now, in this situation, you have to depend on other things. If there is no other organ involvement, other than pancreas also, look at IgG4 levels. This would be important, and age of the patient. Now, if you say, no, still I'm not sure, you can give it a trial of steroids if you strongly believe clinically that could be IgG4. Then I would suggest that you go in and do cholangioscopy and take a biopsy. So Japanese have shown that if you do cholangioscopy, you find some dilated vessels in that area, which is suggestive of IgG4 disease. The mucosa looks normal, as opposed to in PSC, or if it is a cholangiocarcinoma, then of course you will see a lesion there and you can take a biopsy. My only hesitation in doing these interventional things is if you have a diffuse involvement and you do cholangioscopy, you are certainly bound to induce cholangitis. Now that cholangitis, to my mind, may be very detrimental if your patient is elderly, is a diabetic, and then you end up putting one stent or two stents or sometimes PTBD. And the problem, the ducts are not dilated, they're strictured, and they don't drain well. So that's the issue. But if you have isolated hilar stricture, you're not sure, you think it could be benign, it could be IgG4, you can go ahead and do cholangioscopy and place a stent.
So, Pramod, while we are on this particular issue, may I just butt in that is there any evolving role of a PET scan in differentiating the two? And secondly, we all know the uncertainty about the levels of IgG4. And will you elaborate on that? Or do we have a higher normal population? How much levels we have in India? And secondly, the status of IgG4, IG1 ratio. Do you believe in that?
First of all, PET-CT hasn't really been shown to differentiate between the two. So PET-CT is positive in any inflammatory disease. So it is very difficult to differentiate on that. And in fact, when you look at the Japanese guidelines published last year, they don't even mention about PET-CT. IgG4, I agree with you that it could be, as I showed you, that 5% of healthy people may have rabies more than 1.5 gram per liter. And when we study our patients, we found the usual levels is up to 500 milligram per liter. So that's the usual. 400, 500, 600 is the usual level that we see. Thirdly, you mentioned about
IgG4, IG1 ratio.
IgG4 ratio and IgG. So on biopsy, if you have the ratio which is higher, then it is helpful. Even on serum levels, if you have IgG4 levels are higher than IgG levels, more than 10 times, I'm forgetting the numbers, I think it's 10 times, it is suggestive of IgG4 disease. So that can be helpful.
Okay. Well, we are running short of time, but we have a very important panelist, Vikram, there. I can see him anxiously waiting. Sorry, Vikram, keep you waiting for that long. Any questions, any comments, please?
Thank you, sir. The lectures are very excellent, and it was my pleasure to wait and listen. My actually single query to Dr. Sandeep, Dr. Reddy, if there, and Dr. Garg also has obviously extensive experience. When is it that you decide that the obstructive jaundice because of a hilar block in this patient cannot be palliated? We all discuss when to do PTBD, when to do ERCP. But in your practice, is there a time when you see that either because of the general condition of the patient or the anatomical attributes of the stricture, you have to tell to the patient that either of the interventions would be to his detriment? So when is that in your experience? What should we do? or because we are doing it with palliative intention, so we don't want to harm the patient. Your take on
I think
that?
let's put to the clinician only. Pramod, you can handle that.
So I think this is a question that is very close to my heart, because what I find is patients with carcinoma gallbladder come with jaundice. They are told to have a ERCP stent placed, and often they have a stenting done. They develop cholangitis and they have a miserable life. So my take on that is very simple. If the performance status of the patient is such that a patient can undergo palliative chemotherapy, both the patient and the oncologist are willing for palliative chemotherapy, I would go ahead and drain the system. The second indication is pruritus. If a patient has significant pruritus, that's the only indication where it has been shown to be beneficial. Most patients do not have cholangitis. Even if they have some fever, in hilar block, fortunately, they don't have cholangitis. So I'm not worried about that too much. Of course, if someone has cholangitis, I will drain. So significant pruritus, and both patient and oncologist willing for palliative chemotherapy, that's the indication for drainage. Thank you, Vikram, for asking.
Okay, Pramod, last question, which I'm putting to all the panelists, just to raise.
I think Dr. Sandeep also wants to have a word on that. Dr. Sandeep.
Okay, let me just put this, because we are running short of time. Okay. You see, in a IgG4 disease, Pramod showed a slide in which he said that a diffuse disease, go for a therapeutic trial. I go in a hilar block, go for surgery. Or of course, he qualified later that if you need a tissue diagnosis, you can go for cholangioscopy and so on. My question to you all is, in today's time, with all the available modalities in place, we have a significant suspicion that you cannot rule out IgG4 disease. It may not, I mean, if you have a clear-cut evidence of a mass lesion and all, it's different. What will you go for a therapeutic trial of steroids for how long and or not? Let me start from Pramod. Just yes or no, will you go advocate a therapeutic trial there or not?
So in a hilar block, if nothing is working, you're still not sure, you still suspect IgG4 disease, there's no harm in giving a trial. For a 2-week trial, you will have the answer.
I would agree. If there's a reasonable doubt that this is IgG4 disease only, we should give steroid rather than going for surgery.
Manish, your comment? Will you give a therapeutic trial for 2 weeks, he says? Are you comfortable with that? I mean, if this message can go back home to everybody, the panelists?
Yeah, if there is no evidence of cholangitis, no evidence of infection, and we are at a point unable to decide, then definitely under close supervision, one can give a trial of.
What about you, Surinder?
Sir, I'm a big fan of EUS. I would probably do an EUS if I find an isolated involvement of bile duct, because in IgG4 cholangitis, you have thickening of the dilated ducts also. Right. So if there is no thickening of dilated ducts, surgery, there is thickening of dilated ducts, then trial of steroids.
Vikram?
I will use EUS to influence my decision.
Okay. So stay on the same lines as what Surinder said?
Yes, so I'm more confident for lower end. For HILA, if I remain confused, cholangiocarcinoma.
Okay. Can you just say specifically 1 or 2 features on which
Sorry?
On a US, what features you will have which you will say no therapeutic trial, go for straight.
लकड़ी वाला बंद करो दरवाजा, ये बार-बार बाहर जाएगा.
Yes, Vikram, sorry for the interruption. You can't hear you. You are muted. You are muted.
So, presence of autoimmune pancreatitis on EOS, which we can reasonably well distinguish.
We're talking about hilar blocks.
Yes, so presence of autoimmune pancreatitis even in a hilar block, diffuse thickening of the bile duct wall, intense contrast enhancement, maintenance of the bile duct wall structure, maintenance of the echo and hypo and echo structure. These are reasonably characteristic of autoimmune cholangitis, and particularly non-structured area of the bile duct wall is thickened. These are autoimmune cholangitis to me. In all the others, the patient goes for surgery.
So, well, I'm sorry to have taken 2 minutes extra, but I think we'll have to, everybody wants to sum it up. I think that we have a clear messages that in hilar block, type 1 is an endoscopy, type 3B, type 4 is a clear-cut percutaneous, type 2 is a debate, but you need to take a call as a teamwork, both radiologist and endoscopic sitting, that which approach to go first. Correct me if I'm wrong. Pramod, you have the veto power there. And second part is AIG. I think though the cases we are seeing now are increasing in number, but though it's less common, I think we should be more conscious and observant about this disease and pick it up early. And in a difficult case, do not hesitate to give a therapeutic trial of 2 weeks before subjecting to a major surgery. Pramod, any last second?
No, just simple that in type 2, our preference still remains PTBD.
That's a initial thing. That's
which is fine. But for IgG4, again, I would say if you have hilar hilar obstruction, beware that it is likely to be malignant. That is much, much more common than IgG4.
Okay. Okay. Well, thank you very much, Doctor, to all the speakers, panelists, and everybody. And of course, thanks to Virender and Ajay. The good thing about sharing the name with him is that everybody says thanks, and I take it that it is true to me. Thank you very much.
Thank you.
So, Ajay Kumar, without further ado, we will move straight, and thanks to all the panelists, we will move straight to the next session, which is intensive care in liver diseases. I have the proud privilege to welcome Professor Dharmesh Kapoor from Yashoda Hospital, Hyderabad, and the panelists are Professor J.N. Yattu from SKIMS, Dr. Shweta Singh from Max Hospital, New Delhi, Dr. Rakhi Mehwal from ILBS, New Delhi, and Dr. Nikhil Nankarni from Max Mohali. Welcome all, and we move straight away to the next session. Professor Dharmesh.
Thanks, Madhumita. Just Dharmesh is good enough. I think the last couple of days we've been treated to some wonderful, very informative, very educative talks, and congratulations are in order for Dr. Virendra Singh, Dr. Anup Sarai, and Dr. Ajay Duseja for putting such a wonderful syllabus together. So we are towards the fag end of this meeting, and probably this is the penultimate session. And without much ado, I invite my dear friend, Dr. Neeraj Saraf, who's the Director of Hepatology, to talk to us about acute liver failure. Has intensive care improved outcomes? Over to you, Neeraj.
Thank you, Dr. Dharmesh. I hope my slides are visible and I'm audible.
Yeah, please go on.
Okay. So again, at the outset, I would like to thank the organizers for giving me this opportunity to speak on this prestigious forum. So the talk for today is acute liver failure. Has intensive care improved outcomes? Well, I think the answer is simple. It's yes. So intensive care has improved outcomes in acute liver failure. And let's look at evidence that it has improved outcomes. So this is a review article published in Journal of Hepatology from King's College by William Bernal. And they talked of ALF becoming a curable disease by 2024. That means 10 years from when it was published. And if you can see that in the last 40 odd years, the hospital survival of patients with acute liver failure has significantly improved over the years because of intensive care. And this is, although the last bar is a little old, it's probably about 10 years before, but I think the overall trend is very clear that intensive care has improved outcomes in acute liver failure. And that's data from the King's College. This is another study from Australia, which compares two eras, 88 to 2001 versus 2002 to 2017. And again, if you see, there is improvement in transplant-free survival between the two eras, 37% versus 52%, which is significant. Overall hospital survival is also better in the recent years because of improved intensive care. This is data from the acute liver failure study group. This is not comparative between any eras, but again, if you look at transplant-free survival in viral hepatitis, which is probably the most common cause in our country, the transplant-free survival is about 51%, and paracetamol is much higher at about 65%. I couldn't get any data comparing different eras from India. I tried to look at our data, but since we're not a very old unit, we're about a 10-year-old unit. The overall survival at our unit was about 55% as well, but I couldn't really see a difference in the last 5-7 years. It's probably there because it's just all very recent. Now, what else impacts the outcome in acute liver failure? It's the etiology specific management. So this is a concept which I think has been there for the last 10-15 years, that we must try and identify the etiology in acute liver failure and try and treat the acute liver failure. So I think identifying and treating the etiology has definitely made a impact on improving survival in acute liver failure, and specifically in acetaminophen, hepatitis B, autoimmune hepatitis, probably Wilson's disease. So these are some of the diseases where identifying and treating the etiology can make a difference in outcome. Now, this is an overview of intensive care management in acute liver failure. So these are the systems which we have to tackle: cardiovascular system, invasive monitoring for all conditions, echocardiography for low cardiac output, and intravascular volume depletion must be treated with volume depletion or vasopressors. Hepatic, we know that intravenous acetylcysteine can help. Respiratory system, uh, early intubation has shown to improve outcomes in patients with acute liver failure. Management of hypoglycemia, hyponatremia, renal dysfunction, all of these are important. I think the key is, which I'll be talking of in more detail, is the central nervous system. So cerebral edema is probably one of the major determinants of outcome in acute liver failure. And I think that's where intensive care has really improved outcomes. Management of infections, coagulopathy, again, are important parts of management in the intensive care. So, because of lack of time, I cannot discuss all of management of acute liver failure. So I'll try and focus on what I think has improved outcomes in the intensive care management of acute liver failure. So it's simple hemodynamics, which has improved outcomes. So restoration of mean arterial pressure with vasopressors restores systemic circulation hemodynamics. Keeping a map of more than 65 has shown to improve cerebral blood flow and improve the cerebral perfusion pressure. And you can see this study that as the map increases, the cerebral perfusion pressure gets better. So hemodynamics, maintaining a good map in the intensive unit, helps in improving outcomes in acute liver failure. Again, a very simple concept of ventilation. So patients should be intubated. Endotracheal intubation and mechanical ventilation should be planned as a controlled procedure when patients develop grade 3 encephalopathy. So, this sounds very simple, but I think this is a concept which has improved outcomes. I think even 15 years ago, there were a lot of intensive care units where intubation would not be done electively, and patients were in encephalopathy and they were hand strained, and so the concept has changed and elective ventilation does help. Hyperventilation, decreasing the PCO2 to 25 to 30 millimeters via hyperventilation restores cerebral autoregulation, resulting in a reduction in intracranial pressure. So maintaining hemodynamics, electively ventilating a patient has probably improved outcomes in acute liver failure. Now, as I said, I think cerebral edema is probably the biggest determinant of outcome in acute liver failure. And this is again a study from Japan, which compares two eras, 98 to 2003 versus 2004 to 2009. And the prevalence of cerebral edema in acute liver failure, which is the white bar, has decreased significantly over the years. Again, 1,600 patients from the King's College data, again showing that ICH has, over the years, the patients developing ICH has improved, probably due to better management of cerebral edema. So the concept of ammonia is central to the pathophysiology, and I think understanding the pathophysiology in terms of the role of ammonia has helped improve outcomes in acute liver failure. So hyperammonemia is the main, central to the pathogenesis, which leads to increased glutamine synthesis, astrocyte swelling, and cerebral edema. And various treatments are targeted at various levels, like osmotic agents like mannitol, hypertonic saline, hypothermia, and continuous renal replacement therapy, which I'll talk of a little more in detail. So ammonia, I think, is a very central to the development of cerebral edema. And this is a study from Bernal et al. Published in Hepatology, which showed that a high ammonia is an independent risk factor for the development of hepatic encephalopathy and intracranial hypertension. So if you look at this graph, patients who had a low ammonia had the maximum, patients were free of intracranial hypertension. Patients who had a very high ammonia, more than 200, had less were free of intracranial hypertension. So ammonia is clearly directly related to cerebral edema. Again, a paper from AIMS by Vikram showing that arterial ammonia of 124 was found to predict mortality with a high sensitivity and specificity and diagnostic accuracy. So patients with ammonia more than 124 had a higher frequency of cerebral edema and deeper encephalopathy grades. So ammonia was lower in survivors as compared to non-survivors. So the reason I'm talking of this is that ammonia lowering therapies have improved outcomes in acute liver failure in the recent years. Another thing which I think has changed in the intensive care is monitoring of the neurological status or of cerebral edema. So till now, a lot of centers, especially in the West, were relying on intracranial pressure monitoring. And I think that has gone out of vogue now, or it's definitely declining. So this is abstract which we were supposed to present at the ILTS 2020, but which got cancelled. So is it the end of road for invasive neurological assessment in acute liver failure? So we looked at in patients, we looked at a cocktail of clinical examination, pupillary reflex, portable CTs, EEG, serial ammonia levels, and the optic nerve sheath diameter. And we saw that with a combination of these non-invasive modalities, patients were safely selected for liver transplantation, and we could achieve an excellent neurological outcome in 53 out of the 54 patients. So I think neurological monitoring has improved, and non-invasively, we can detect cerebral edema and decide which patients to transplant. And I think this has helped in improving outcomes in the intensive care. Some other modalities, which are transcranial Doppler, reverse jugular oxygen saturation, and bispectral index, are also being used now, and which probably help in improving outcomes in terms of neurological outcomes. So coming to management of cerebral edema, which I think is the most important determinant of outcome in acute liver failure. So I talked of monitoring of cerebral edema, which, to detect brain edema and intracranial hypertension. Basic steps are intubation, head elevation, propofol sedation, and I talked of keeping a mean arterial pressure of more than 65. Osmotic therapy with mannitol, hypertonic saline is important in decreasing cerebral edema. Therapeutic hypothermia, hyperventilation are again modalities for decreasing intracranial pressure. CRRT, therapeutic plasma exchange, are new kids on the block, and I'll talk of them in a little more detail when we talk of management of cerebral edema. So this is a paper published in Hepatology, which shows hypertonic saline improves or reduces the intracranial pressure. And if you look at, this is the test group and this is the control group, the incidence of intracranial pressure was significantly lower in patients in whom we could maintain sodium of 145 to 150. So hypertonic saline important along with mannitol in reducing ICP. Hypertonic saline, I think, is more used now as compared to mannitol in the recent years. Now, this is something which is very important in decreasing ammonia levels in renal replacement therapy. And we have seen that hemodialysis improves ammonia levels, and CRRT, which is a slower form of hemodialysis, is very effective in decreasing ammonia levels. This is a paper published which shows again that CRRT removes ammonia, water, and lipid-soluble toxins and glutamate. The advantage of CRRT is that it is, intermittent renal therapy has shown to be less intracranially stable. And if you look at this chart, intracranial IRRT, there's surges of increase in the intracranial pressure and thus causing more harm than improvement. This is a paper published in 2018 in Hepatology showing the improvement with renal replacement therapy and lowering of ammonia. And this paper showed that CRRT decreased ammonia, it increased transplant-free survival, and decreased all-cause mortality. So with recent use of CRRT, it is shown that it decreases all-cause mortality and decreases hyperammonemia in patients with acute liver failure. And this paper showed this as well, and that 21-day transplant-free and all-cause mortality was lower in patients with CRRT as compared to intermittent renal replacement therapy. Just lastly, a word on plasmapheresis and acute liver failure. I think this is again something recent, which ICUs are using now and probably helps in improving survival. This is a paper published in Journal of Hepatology in 2016, which showed that high volume plasmapheresis, randomized control trial versus SMT, and there was significant improvement, 58 versus 47% in patients who went high volume plasmapheresis. There was improvement in the INR, bilirubin, and less number of patients required renal replacement therapy. So if you look at the subgroups in this study, the best outcome was in patients who underwent liver transplant. Then it was in those who underwent plasmapheresis and liver transplant. And obviously the worst was in patients who did not undergo a liver transplant or high volume plasmapheresis. So this paper was the first paper which showed that high volume plasmapheresis improves survival in patients with acute liver failure. This is a more recent paper published last year, which looked at low volume plasmapheresis. Just one more minute. This is a study looked at low volume plasmapheresis, about 3 liters in one session. High volume used up to from 8 to 12 liters. And this study also showed that even low volume therapeutic plasma exchange improved multi-organ dysfunction. It improved mean arterial pressure, and it improved survival in patients with acute liver failure. I think another concept which has changed outcome is monitoring and managing coagulopathy. Tech-based monitoring of coagulopathy has decreased the amount of transfusions required. And if you look at this, this is a tag of an acute liver failure patient, and this is a tag of a normal a patient and person, and this is identically similar. So because of the increase in pro-hemostatic acute phase reactants, there is really no need to transfuse unnecessarily, and TEG has really told us that. Infections, there's really nothing different, and I think prophylactic antibiotics should be considered in patients awaiting transplant, and specifically if they're undergoing liver transplantation. I have not talked of liver transplantation because this was beyond the scope of my talk, but again, if you talk of intensive care, then liver transplant has improved survival, and this is data from our unit, which shows about 80% survival in patients with acute liver failure. So to summarize, what are the lessons learned? Survival in ALF has improved dramatically in the last 3 decades. Establishing the current etiological diagnosis remains vital to management of acute liver failure. Supportive medical care is most effective when commenced early, addressing all aspects of multi-organ dysfunction. Cardiac, coagulation, and neurological monitoring has advanced and it has improved outcomes. The incidence of cerebral edema has fallen over time and is related to earlier recognition and better initial treatment by improving plasma tonicity and early use of renal replacement therapy. Plasma exchange may play a role in improving survival in acute liver failure, and results of emergency transplant have improved and in the long term are almost close to those for elective procedure. I have not talked of paracetamol because we don't see it often, but there is significant improvement in paracetamol-induced liver failure, and which approaches liver transplant. And the thought is now whether transplant even should be done for paracetamol-induced liver failure. Thank you.
Dr. Dharmesh, can you unmute yourself?
Thanks, Neeraj, for that wonderful overview. I think the time constraints would not permit a detailed discussion on what we do in the liver intensive care, but I think you did a good job. I now invite Dr. Pramod Guru, and he's going to talk to us about role of ECMO in liver transplantation. ECMO is now again become a buzzword courtesy COVID, but let's hear from Dr. Pramod Guru, who happens to be working as a consultant in the Department of Critical Care Medicine at Mayo Clinic, Jacksonville, Florida. And he'll be talking to us about role of ECMO in liver transplantation.
So are you able to, thanks Dr. Dharmes, are you able to hear me or see my?
Yes, we can. Yeah, you need to share your slides, please.
So, 1 second, please. Are you able to hear, see my slides?
No, sir.
No, not yet.
Oh, that's strange. Share the screen.
Yes, we can now.
Oh, okay. Thank you.
You need to go full screen, please. Yeah.
Okay. Sorry for the confusion. First of all, thank you, Professor Singh and Professor Ajay D'Souza, my teachers from PGI, giving me this opportunity to speak to this esteemed group. And thank you, Dr. Kapoor, for your kind introductions. The topic which is assigned to me is that extracorporeal membrane oxygenations in liver transplant. And in next 10-15 minutes, what I'll give you the practical application of what are the challenges we are facing in this arena of critical care practice. Of course, I do not have any disclosure except for the fact that I am a strong believer of this mechanical circulatory device, which is called the extracorporeal membrane oxygenation. And some of the picture you will see that I have stolen from Internet, Harvard Business Review, and some of are my own. So that's my disclosure. And so before I jump into the details, I will give you a case summary, which we recently took care of in our ICU to think about. So this is a 64-year-old female with underlying history of diabetes, hypertension, hyperlipidemia, and a diagnosed case of end-stage liver disease, which was attributed to the NAS. And she came to our hospital for transplantations. What happened is that her intraoperative course was complicated by a cardiac arrest, mostly because of the VTAC. So we have to do the CPR. Fortunately, we get the return of spontaneous circulations back after 3 to 4 minutes of CPR. She did require, bunch of blood product transfusion, include 17 of PRBC, FFP, cryo, all that stuff. So post cardiac arrest, we saw that she has coagulopathy and edema. So the surgeons and then the team decided that it's better to defer the bile duct anastomosis and keep the abdomen open, and then they transfer the patients to the ICU. So next couple of hours, we have a nightmare in the ICU. As you can see that the chest X-ray is completely white out now, and we have difficulty in both oxygenating as well as ventilating, despite being on almost like 100% oxygen, nitric oxide of 40, and then PEEP, high PEEP, everything. Then she continued to have progressively worsening acidosis as well as increased inotropic requirement, requiring norepinephrine at highest dose and epinephrine as well as vasopressin. We did do the echocardiogram, which showed that her ejection fraction has significantly dropped from the preoperative, which was normal. So the question arises, what's the next and what should we do to these patients? While I was talking, or I'm going to talk about extracorporeal, I wanted you to think what are the options for you guys and what we did in our institution here in Mayo Clinic. So the concept is about the liver transplant and the extracorporeal membrane oxygenation. It's not new, we all knew that when your liver is full, it's better to give a new liver. And that is being really idealized back in 1960s and 70s, so started with Dr. Thomas Sturgill from University of Pittsburgh. And then similarly, the concept of bypassing the heart-lung is also not new. It started back in 1950s. And then the pioneer of this extracorporeal membrane oxygenation was credited to Dr. Bartlett, who is still a practicing physician or surgeon at University of Michigan. Somehow I'm lucky to get benefit from Dr. Bartlett, who helped me to get my green card, writing a letter. And I was trained also at Thomas Stargill Institute as a nephrology physician. So very nice story. The question is, like, all of this esteemed group here know that, you know, what is liver transplant, but I wanted to just give you a snapshot. What is extracorporeal membrane oxygenation? To be honest, it's a miniature version of the cardiopulmonary bypass. What we have done is that we stolen the cardiopulmonary bypass machine from the operative theater and brought it to the ICU. And then the basic concept of extracorporeal membrane oxygen is nothing but it has the capability to provide oxygenated blood in the scenario whether your heart or lungs are doing anything wrong or bad. So that means whenever you have a compromised heart and lung, we have the capability to provide you oxygenated blood. And depending upon which organ we wanted to support, they are divided into veno-venous or veno-arterial. In the veno-venous, the primary aim is to support the lungs. In that scenario, your heart has to be pretty good. In the other way, veno-arterial, what we do is we can support your heart and lungs, and then that's called veno-arterial. The difference is mainly lies where is the oxygenated blood goes. If the oxygenated blood goes to the venous side of your circulation, then it's veno-venous. If it is go to arterial side and bypass the heart, then it's called veno-arterial. So this is the basic difference. However, if you come back, like think about the liver transplant as well as the ECMO, they are conceptually completely different. How it is different? We know that, you know, the liver transplant is a curative form of therapy, and we have to be careful about not getting a rejections and then have to be on immunosuppressions as well as infections, all these things. In comparison, when you come to the ECMO, which is temporary, we do not have the capability to permanently put somebody on ECMO because it's a support system like mechanical ventilator. We need to have an exit strategy. Without having an exit strategy, that means what's the next step of your care in the patient? You are not supposed to think about ECMO. And then the other thing, which is very important, ECMO by definition asks for anticoagulation. The current generations of the so-called all the machine, we cannot run without anticoagulation. So these are the basics difference. But question arises, why we are talking right now, even if the concept and the therapy is available since 1960s and 70, what has changed recently that we are talking more and more? The changes is mainly there are a lot of innovations, not only the surgical technique, but also like many other care at the ICU at the bedside, from both liver transplant as well as ECMO. The innovation which has changed the ECMO practice at bedsides, and mainly the smaller size of the machine, which one of the prototype is CardioHelp, the various types of catheter, and then the oxygenator, which is really the membrane which helps to oxygenate the blood while you're passing through the membrane. Similarly to the liver transplant, we know that the transplant outcome has improved significantly. The donors are also, you know, we are being more innovative in the donor finding and to fill up the shortcut. There is immunosuppressions and then machine perfusion, all these things. So that's definitely one. But the most important thing in my way is that in 21st century medicine practice, what's really being done is the confidence in caring of these people. So we are getting more and more experience, and that experience is really like kind of extrapolating into care more sicker patients and more severe patients, and we are exploring the other alternative way in which we can help these people. That's what polymer is. That comes to the challenges, you know. Again, I'm not comparing the liver transplant to ECMO, but the challenges are unique. So the unique in the sense, in the ECMO world, our main challenge is to currently, again, for years together, how to fix the bleeding and the clotting and then infections, the renal replacement therapy. These are the major complications. Similarly, in liver transplant world, there are a lot of, you know, organ shortage, and that you know that probably all of us know that there are so many people, those who are in the waiting list, we cannot just get them to get the liver because they are too sick to go to the OR. And then the other problem is that the short-term and long-term outcome. So this is where the challenges. But the good news is that the bridges are building slowly. Like that means what? Previously, in the people, those who are a liver transplant or acute liver failure, ECMO was considered as a contraindication that you cannot give them. The reason being the risk of bleeding and everything. So the data says that we can be smart enough and really help these people, and then maybe improve the outpatient outcome. That brings to a point. Like, I'm talking about ECMO, but all of you probably know all these political stalwart in the India, those who are supported by ECMO, but none of these people are alive at this moment. That brings to the big question: does ECMO really works? So I don't know the answer. As I said, that I am a believer of ECMO, but I believe that it does work. But what is important is where in which setting you are utilizing, and what is the patient selection criteria. We do have some data, but not that robust data as Dr. Saraf showed in the acute liver failure in the ICU. There are a lot of data. Unfortunately, in the ECMO world, we don't have a lot of data. The things which really got the ECMO practice has got impetus just exactly 10 years back after the H1N1 pandemic, where people have shown that those who have acute respiratory distress syndrome because of the H1N1, and once we put them in ECMO, their survival is significantly better as compared to those who are not. And then recently, a Eulia trial has the similar. Again, the Eulia trial is a controversial trial. I wanted you to really learn about the trial and see how the practice of the statistical difference in the research makes a difference in the outcome and interpretation of a trial. But the important thing, as Dr. Dharmesh pointed out, is that now it is being really, this is the COVID-19 pandemic. And this is the latest data from the ELSO registry, where you can see that the application of ECMO in the ARDS populations, which is supported by the COVID-19, has significantly changed the dynamic. At least the mortality, 90 days mortality has improved. So I mean, without going to the detail of the COVID-19, how the ECMO is being practiced, I can point out from our own experience as well as the worldwide experience that it is a very important mechanical circulatory devices to think and apply in these people. This is the ELSO registry data. That is the data of all the ECMO people around the world, those who are supported. So far, almost more than 135 or 30,000 people has been supported by ECMO, which in comparison, if you start from the liver transplant, starting from 1960, probably 500,000 or less than 500,000 people have been supported or got the liver transplant. The survival to discharge is almost 70%, if I correct. So the 1-year survival in particular liver transplant is close to 90%, and the 5-year is probably 70%. So the difference is not too much. But the difference is the needs. For the liver transplant, we know that the need for liver transplant is completely different, because if the patient has acute liver failure and you cannot fix the liver and you cannot help them the organ dysfunction, then you need a new liver. And similarly, some metabolic disorders like Wilson's disease, other things, or end-stage renal disease end-stage liver disease because of the HCV or other things, you definitely need a liver to get the people. But in the ECMO, the difference is absolutely other way. The primary indications in ECMO is acute respiratory failure, shock, and cardiac arrest. So what's the role in a liver transplant area? Number one, particularly acute respiratory failure. We know that the liver transplant people have a unique pathophysiology, which is not seen in other people. That one is called portopulmonary hypertension and hepatopulmonary syndrome. They are prognostically important and you have to diagnose. The other way to think about that, these liver transplant people are increased risk of ARDS because of the infections and then the immunosuppression, and also they are also at risk for pulmonary embolism and the other kind of respiratory failure. When it comes to the management of acute respiratory failure or ARDS, we know that mechanical ventilators supposedly help tons of life. But when you are in the severe ARDS category, the mortality remains half. Like half of the people in the severe ARDS die in the ICU. So we need to do something. Cardiogenic shock, we know that the percutaneous interventions has changed the dynamic, but most of these people at the elderly age comes to the hospital with a cardiogenic shock. And if they comes to the hospital with a cardiogenic shock at the ED, their mortality is most of the 50%. We cannot fix them. And then the other area where it's shown to be really important is the cardiac arrest. All of us in this group are ACLS, BLS certified, and we have been trained to rescue the people. Unfortunately, the data is very, very poor. Despite the so-called all the effort, the in-hospital cardiac arrest, the survival to discharge is less than 20%. If it is out-hospital cardiac arrest, it's less than 10%. So in this area, it has been shown that ECMO is going to be really helpful. However, when I talk to the liver transplant area, this is an important slide. I wanted to focus on that because the liver transplant people are unique in the sense that they are predisposed to cardiac arrest intraoperatively or immediate post-operative period because of the fact that The right ventricle is all we know that's non-forgiving. If the right ventricular output increases, or they get increased so-called pulmonary hypertension because of the transfusion, fluid, or immediate reperfusion injury, or may they have intracardiac clots, then we are in trouble. Somehow this is a spiraling process, and patients really die. And we do not want to lose it liver, because you're not only losing the liver, also you're losing the patient. So that's why it's very important to be proactive to find out which people can be salvaged by this methods. And that is why there is a perception that ECMO can be helpful. Unfortunately, the data is very, very scarce, and it's only limited to case series and case report. Mostly are from the Southeast area, particularly Taiwan and Korea. If you think about United States, this is the largest series published last year. I can say that 8 patients, 5 on VV ECMO, 3 on VA ECMO, their survival is 50%. And then just 2 days back, there is a publication from the pediatric world where the survival is 68%. The number of people are 34. So we don't have a lot of data about the liver transplant and ECMO, but what we have is ECMO is certainly life-saving, and it has benefit. It is both labor and resource intensive. We have to be careful. It's not for indiscriminate use. You need exit strategy, like what's the next step, and the patient selection is key. So that brings to the point, like when you are in confused state, you don't have data, how do you take a decision? Then it depends. Like my take is that it's just the demand supply, whether you have the choices, what the patient require, what your community require, what is the pros and cons of supporting the patients on ECMO, and how you can get out of the so-called once you go to the ECMO. There is no guidelines, unfortunately, which is being considered the laws in the clinical medicine. We all need guidelines. There is no guidelines for these things. It's all practical and a case report. So for our practice of person in our center, we usually have this outline. Pre-operatively as a bridge to transplant, if we know that you can fix the people's ARDS, then we go for that. Peri-operatively, we are more proactive to find out some of the cases where there is hepatopulmonary syndrome or portopulmonary syndrome, and then if there are thromboembolism or acute coronary syndrome during the surgery, we have kind of go for that. Or they are multi-organ transplant like heart kidney or liver kidney, and then we know that it will be a prolonged case with increased cardiac insult, then we go for that. In post-operatively, mostly the pulmonary embolism or other things. And then the other area where it has been shown to the organ donations. The aim, as I told before, is mostly to restore the physiological milieu and then probably prevent the other further organ injury and stability of organ dysfunction. Back to the case, what we did. So immediately after that, we supported our patients with the VA ECMO, and then we removed the ECMO after 7 days. He was doing fine and transferred out to ICU 4 weeks. We have a good success. So this is what we did. So coming to the point, since essence of time, so the collaboration is essential for the care of these people. ECMO has a lot of promises, but the problems are a lot. We do not know what the best anticoagulation strategy, which model we wanted to do. There is a lot of other ICU care, but the practice is improving. Not only putting the patient in ECMO is helpful, but you have to also careful about the infection strategy, nutritional, other management. That's more important. As Dr. Sharaf rightly pointed out, what are the things which has improved the care in the process of acute liver failure in ICU. That all has to be applicable in ECMO patients. The journey certainly is scary, but it's worthy because we have certain success. We have lost a couple of people. So my take is that ECMO does provide an alternative option or maybe a viable options to improve the outcome in the liver transplant patients. The practice is certainly sophisticated and labor intensive. And the mortality and morbidity is still high, but it's improving gradually. The most important fact is we have to be a humanistic approach to the care process, because that's more important than anything else. With that, I'll close and take questions, and thanks for giving me the opportunity. Please, if you have any questions or concerns, you can email or tweet me. Thank you, sir.
Thank you so much, Dr. Guru, for introducing this audience to this new concept. We are all using some kind of extracorporeal device or the other in our day-to-day clinical practice, but ECMO is, I think, still out of bounds for most of us. Just to put it in perspective, in this country, a day's session of ECMO would cost something like $10,000. And obviously the patient selection has to be very astute, and probably because of time constraints, all of these things cannot be discussed. Now, can I have all the panelists on screen, please? Madhumita, could you assist me in that? And I think without much ado, we'll take the
Dr.
discussion
Guru?
forward.
Yeah, can you please stop sharing your screen?
So while Dr. Guru is doing that, let's start taking the questions which Madhumita has been very proactively putting in the chat box. So I'll break the convention. Neeraj, Madhumita wants to ask, why are we still using the King's College criteria for listing patients for acute liver failure for transplant?
Yeah, so
Can we
who's
have
using
all the
the King's
panelists on
College
the screen,
Guru,
please?
can you
now?
please stop sharing your screen?
Is it now? Is it happen?
No,
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 not
still
yet,
share.
sir.
Okay. How about now?
Now
Yes,
it's good.
that's fine.
Okay.
Yeah, so I totally agree with Madhumita. I don't think, I mean, I personally don't use the King's College criteria, and I think most centers are moving away, and they are not really valid in our etiology and in this time. And I think dynamic criteria is what we need to do. Maybe the Alfred criteria from AIMS. I think I really don't follow any criteria. I think it's just a dynamic change over a period of time, and you see the patient, maybe in 24 hours or 48 hours, you see which way he's heading. I think the key things to look at are ammonia, INR, hepatic encephalopathy, and bilirubin. And I think you have to see the trend. So I agree with you, King's College criteria doesn't hold today.
All right, so I might have a different opinion because the King's College criteria have been laid down for centers which are drawing from a common pool, Madhumita, and that is a very important thing to remember. So most transplant programs in our country are based on living donor transplant, so probably this would not hold. But just to put it in perspective, many centers in this country, many states actually still use the King's College criteria for organ allocation. So there is something called super urgent listing, which exists in the state that I practice as well as in Maharashtra. I'm quite sure of these two states which have generous organ donations compared to other states. So I think these criteria still hold their ground. Is Dr. Yatu there? Because I would like to start the discussion with someone who doesn't have transplant facility as a center. Is he there?
Yes, I can see Professor Yatu. Can you just switch on your video and unmute?
Okay.
Yes, he has unmuted himself. Yes, sir, you're audible.
Yeah. Dr. Yatu, good evening, sir.
Very good evening. How are you?
All good, sir. So the question that I wanted to pose to you is, what is your take on the medical management of a patient with acute liver failure who's in grade 3, grade 4 HE? So you work at a center which is an academic institution, but you don't have a transplant facility. So what would be your recommendations? Because I think many centers or many people who've logged in would probably be faced with a similar situation.
I think you're absolutely right. What Dr. Neeraj gave a very elaborate talk on, in a role of intensive care. See, this intensive care is definitely of great help in a center while you also have a liver transplant unit, and we don't have it. Not only that, being a government hospital, you have so much burden of patients. See, for intensive care, you need a support from a nephrologist, you need a support from an intensive care specialist, which very difficult, with a lot of difficulties we give it. To be very honest, how we are treating, managing our patients is the conventional treatment that, manage their cerebral edema usually we use, even now, mannitol we use, just manage their infections in the conventional way. We haven't really gone the way, what we normally in an intensive care center, what is being discussed theoretically. In a government setup, you will not find these things, particularly in a in a place where you don't have a liver transplant unit. But what we have seen is that if we go for etiologically based treatment, I'll tell you that in 2002, I think our institute was the first, when our DM student got a thesis, we treated severe acute hepatitis B with some of them presenting as acute liver failure with lamivudine. That was the only nuke available. And it was a placebo-controlled study which was presented in ISG as an award-winning poster that time. And we did find that if you give lamivudine in these patients, we could definitely at least, made a bridge between going to a liver transplant. And many of the patients did survive. And even, if I remember correctly, 3 patients in seroconverted. This was an etiological based treatment. So we yet go on the same thing. We don't have all these modern gadgets for like hemodynamic monitoring. It is not happening in our unit. We have a 4-bedded liver unit where we usually give just conventional treatment, what in any government institute is being given.
Thank you so much for your comments, sir. Dr. Shweta, would you like to leave the audience with some takeaway points, the medical management and the time to referral for transplant? So what would you recommend in every possible case that you see with acute liver failure on your unit?
Uh, I would like to reiterate what Neeraj said today, that management with emphasis on neurological monitoring, effective monitoring of coagulation, maybe with TEG, viscoelastic monitoring, this has gone a long way in improving medical management, because the rest of the things, that is antibiotics, anti-epileptics, all those things remain standard. And institution of things like high volume plasmapheresis or CRRT, whichever of the two, if at all, is offered to a patient who is not fulfilling the criteria early, helps in guiding these patients without transplant. But King's College criteria is the criteria to be followed. That is the criteria we would use, because the Alfred criteria we have not validated in our setup yet. So
Right.
I would like
I think, Neeraj, the most important thing, and just at the expense of repeating myself, I think what you mentioned and that needs to be emphasized more is sedation, ventilation, and this is something that still is not done in most centers. They are averse to ventilating or sedating their patients. So the moment you transit from grade 2 to grade 3, we should be very happy to do that. Monitoring sugars, not using hypotonic fluids, because you still see patients even in big centers being prescribed 5-10% DW using hypertonic saline and maybe N-acetylcysteine even in non-paracetamol overdosage. And then of course the management of ammonia, which you alluded to very nicely in your talk. Rakhi, you are a Plex avid unit. So what is your take on Plex in acute liver failure? And I want a critical answer, please.
Yeah, sir, thank you. And yeah, we are very often using Plex, because whatever patients we get in our unit, most of the times they are not for liver transplant. But I would just like to tell how we go about, because we have a live donor liver transplant program here. So we go by KCH criteria to find out patients who are more likely to fail with these supportive therapies. So our success is 1 in 4 if a patient meets KCH criteria. And even in the KCH criteria, to the success, the failure is very high. It's almost 90% in patients who meet single KCH criteria of high INR and cerebral edema. So a composite of two things can tell us that these patients are more likely to fail. So that's how we go about identifying which patients we will be able to salvage. The other two, very important, which we had conducted a trial, we do standard volume plasma exchange. So we're not doing high volume plasma exchange like what UK is doing. And we had good results with the standard volume plasma exchange. And in that particular study, we also analyzed our data to find out which patients are non-responders and which patients can actually survive. So what we found out was very interesting. We found that patients who had already landed up with renal failure, metabolic acidosis, and patients who had high SOFA scores above 10 or 12, they were the ones who were more likely to fail and were more likely to go on to CRRT. So we're not using CRRT as the first line therapy. We go with plasma exchange, and most of the patients who respond, they require less than 2 sessions of plasma exchange. So patients who require more prolonged sessions have a rebound increase in parameters, and they are more likely to require a liver transplant. And there is where also we start discussing futility by day 3 or 4 of therapy, because we also need to identify that group of patients where we should stop and where they are less likely to survive in the absence of a liver transplant.
Right. So I think the take on Plex in acute liver failure is that the study which Neeraj quoted, that study happened over a period of more than a decade. So I have serious concerns about consecutive enrollment into that trial. And that trial has been published as multiple papers. The second you alluded to was using high volume plasma exchange, and these authors have already published that the low volume plasma exchange does not work. The third is the homogeneity of the etiology of acute liver failure. So most of the patients in this study had hyperacute liver failure. And many a times what we see in our country is not hyperacute liver failure, because paracetamol is not a common cause. And I think those who've logged in, it's very important to know that the etiology-based management of acute liver failure still holds the key. So someone who's got hepatitis A induced acute liver failure, even if he comes to me decerebrating, I will have a very high threshold for putting him on transplant. So I think the etiology remains the key. And I have serious concerns about using plasma exchange in people who present late acute or in subacute acute liver failure. Dr. Guru, I would like to have your comments on plasma exchange. And then I think we would just conclude by asking you something on ECMO, which has come up in the chat box. So what is your take on plasma exchange as a modality of treatment, sir?
Thank you, Dr. Dharmesh, for asking the question. To be honest, we do not do plasma access. We are more kind of, I would say that we are more lean towards Mars, yearly Mars. And again, you can ask whether there is any data or not, but our center's overall practice is more towards Mars rather than plasma exchange. That's the shortest answer. As you nicely pointed out, the data about the benefit of plasma exchange on these people is questionable. Whether it's high volume or low volume, it's also, it needs prospective studies to find out what exactly it does to the patients in short run as well as long run. But again, in the anecdotal studies and the personal experiences, it's bit different, similar to our ECMO practice, but that's what we do.
So just to mention here, sir, that there was a study which was done from All India Institute on use of Mars versus standard medical therapy, and that was a negative trial, and the ethics committee had stopped that study. Last question to you, sir. Where do you see the role of ECMO? Do you see it more in the setting of acute liver failure or in the kind of patient that you described while talking about this procedure? So where do you see a greater role for this therapy?
Thank you for again asking for that. I think it's both. The fear that ECMO induces or ECMO can cause more bleeding, and then the fear of bleeding being a contraindication in the acute liver failure should not be the case, because the methods, the technique, and then the experience has changed. So we can certainly run the ECMO without having any anticoagulations for weeks. So that should be the take-home message, that it can be utilized in acute liver failure patients, and then it can be a bridge to transplant. And the other one is about the perioperative. I believe that in the next couple of years there will be explosion of the studies across the US center that this is being part and parcel of the transplant. What I'm more envisioning that probably most of the liver transplant people are going to be preemptively supported by the ECMO during the surgery, and then in the next 24 to 48 hour post surgery, so that the hemodynamic can be stabilized by the ECMO, and then you have a good outcome. So that's what the take home message is.
Okay.
Right.
I think we have to end the session here, sir. Thank you, Dr. Kapoor, Dr. Saraf, Dr. Guru, for your excellent talks, and also for all our panelists, Dr. Yatu, Dr. Singh, Dr. Mehwal, and Dr. Nadkarni. Thank you so much and this is a good segue since we've been talking about transplantation, and I hand over to Dr. Taneja.
Thank you.
Thank you, Aditya. We move on to the last session of this meeting, and for this I invite Professor P.N. Rao, who is the Director of Hepatology at AIG Hyderabad, to call upon the panelists and the speakers. Thank you.
Thank you very much, and thanks and congratulations to both the teams, PGI and then AIMS. And then let me tell you that the faculty, we are going to have one talk and one debate, and the panelists are distinguished, accomplished, and then experienced people. And for the talk in ACLF in liver transplantation, we have got an overseas faculty, Dr. Sanjay Satpathy, who is, of course, we've been seeing him in our liver meetings. He's from Northwell Health, New York, and then he's going to talk about the role of LT in ACLF, followed by a debate. The panelists, Dr. Samir Shah from Glengale Global, Mumbai, Dr. Narendra Chaudhary from Medanta, and Dr. Vivek Vij from Fortis, and two transplant surgeons, and then two hepatologists are there on the panel. Over to Dr. Satpathy, please. Share your slides and then go ahead with your talk, please. Yes.
Hello, good evening.
my colleagues from India. Am I
Sanjay,
audible?
can you make it on full screen?
Is my slide visible?
Yes, you are visible. Audible and visible. Please go ahead.
So at the outset, first, I would like to thank the organizers of PGI and AIMS for setting up such a brilliant, really enjoyed and also learned from this meeting as well. I would like to thank Professor Singh and Professor Diseja for the kind invitation. I've been assigned to talk liver transplant strategies in acute on chronic liver failure. I have nothing to disclose. Acute on chronic liver failure is a syndrome that is broadly characterized as a rapid deterioration in liver function coupled with extrahepatic organ failures in patients with occult or non-underlying chronic liver disease with or without cirrhosis. This is associated with a high 28-day and 3-month mortality compared to decompensated cirrhosis. Now, the European and the North American definitions require cirrhosis to qualify, but the Asia-Pacific region, where hepatitis B is endemic, the definition includes patients with chronic liver disease without cirrhosis. Now, it's very important at the outset, I want to make sure that we're not comparing apple to orange. So acute on chronic liver failure, there is a high risk of short-term death. That is death less than 28 days after hospital admission in patients with an acutely decompensated cirrhosis. Whereas acute decompensated cirrhosis, you are talking about development of ascites and encephalopathy, GI hemorrhage, or any combination of these disorders in patients with cirrhosis. Now, this is very more clear in this particular slide where you can see the traditional acute decompensation, the survival at 90 days is up to the tune of almost 90%, but whereas in a patient with acute on chronic liver failure, close to 50%. In comparing 1,047 patients with 302 patients. So now we know that the traditional acute decompensation and ACLF are completely different entity. Now, this is important in terms of the implication of choosing a patient for liver transplantation, to strategize our patients for liver transplantations. But the timing is important. Two important points that we need to find out: when it is too early and when it is too late. And within that crossroads, 40 to 50% will recover. I think this is important to know that timing, and this different scoring system, including the APASL, the EASL clip, and the NAXL, they are all in a way, they help in different ways to find out this particular timing. And it is important to find out when it is too late. Now, there are subtle differences between these three different criteria for ACLF. I'm not going to go through more detail for the interest of time, but I would like to point out one thing, that APASL, first of all these definitions, they include a hepatic component, that is the bilirubin, kidney, brain, and coagulation. Circulatory failure and pulmonary failure is not included in the APASL, but they included lactate, which is factored into their final ARC scoring. Whereas in CLIP organ failure score, the components are also, along with the components which I just talked about, age, WBC count are factored for the final CLIP-C ACLF scoring. Whereas in NAXL, they're considering ACLF as more than 2 extrahepatic organ failures, and they combine that with age, WBC count, albumin, MAL score, and presence of bacterial infection at admission, factoring to the final scoring system. Now, how are we going to use these different criteria? So first of all, let us make it clear that APASL CLIP, APASL ACLF, there is no cirrhosis. Is a chronic liver disease the underlying condition you can have with or without cirrhosis. Whereas in the setting of EASL, CLIP, and NAXL, cirrhosis is a defining criteria. Now, APASL ACLF, liver, the primary injury is liver related, whereas in EASL and NAXL, you have non-liver related injuries are considered as the primary injury. Now, clinical goal is to assess response to therapy, identify the window for the transplant based on APASL and EASL, and identify patients for regenerative therapy and liver support therapy and transplantation window. Now, in NAXL, predicts more of a futility of care, help discussion about the futility. Now, I'll tell you why is that. This is a very elegant study that was published in American Journal of Gastroenterology very recently. If I point to the table on the right side, they're basically summarizing and comparing EASL, CLIP, and the NAXL, and talking about 7-day mortality, 28-day mortality and 90-day mortality. Now you see that in there is 29.3% were identified as EASL clip with applying EASL clip criteria, and then 7.4% by the Naxal ACLF criteria, that are ICLF. Now the 28-day transplant-free survival of ACLF was 58.4% using EASL clip versus 37.1% using Naxal criteria. But more importantly, when you were talking about 28-day mortality, Naxal criteria demonstrated significantly higher overall accuracy, specificity, and positive predictive value, but lower sensitivity and negative predictive value than those of the EASL clip. But when we talked about overall accuracy become similar actually in the Naxal and the EASL clip criteria at 90 days mortality because of the decrease in the sensitivity and negative predictive value. Now, this is also they applied in the hepatitis B related ACLF, and they found they performed almost similarly. So the more importantly, the take-home point from this is that Naxal pretty much more likely would predict futility of care than the EASL one. Now, while it is clear that the incidence of acute and chronic liver failure is increasing in hospitalized patients with cirrhosis, the numbers vary dramatically from study to study. Now, we know that ACLF causes high short-term mortality, but that varies from 25 to 40% at 30 days. The grade 3 particularly is associated with a very high 3-month mortality, but reaching mortality reaching up to 79% without a transplantation. Now, let us, this is a study where we was a co-author with Professor Singhal, where we have shown that, let's look at the epidemiology of acute and chronic liver failure and alcohol-associated liver disease. What we have found, the young patients, less than 35 years, there is an increasing number of patients being admitted in hospitals with alcohol-associated liver disease, ACLF, and as compared to the older ones. Similarly, there is a study that came out from very recently, Sundaram is online right now. What they have shown, NAFLD, actually the fastest rising etiology of cirrhosis associated with ACLF among patients listed in the United States. So as the NAFL population continues to grow in age, patients with NAFL ACLF are likely to have the highest risk of waitlist mortality. This we need to keep in mind because NAFL patients are presenting at much older age, and having ACLF, many patients will actually have a more likely to have waitlist mortality, and this needs to be kept in mind. Now, a little bit of the pathophysiology I would like to discuss before discussing further. Now, combining these different definitions, let us see in a patient with a cirrhosis, there is a leaky gut, there is portal hypertension, intestinal dysbiosis, and this inflammation is causing impaired intestinal barrier function, bacterial translocation, release of PAMPs. Similarly, hepatic inflammation due to viral hepatitis, etc., causing hepatocyte necrosis, release of extracellular vesicles, activation of the liver, the sinusoidal endothelial cells, and resident immune cells, leading to DAMs, cytokines. All these things leads to a cascade of events related to cytokine release and cytokine storm that leads to further liver dysfunction in addition to multiple organ dysfunction. So then what is happening is this set is all ready now for a prolonged immune paralysis at this point because there is counter-regulatory cytokines like IL-10, prostaglandin E2, regulatory T cells. They are now leading to immune paralysis and predisposing these patients to secondary fatal infections. So while bacterial infection is the most common cause for ACLF in the Western world, the second most common cause is idiopathic. Clinical features is defined by the criteria already by the ACLF, but the sepsis is the inciting event in almost 60 to 80% of these patients, and we know what's the etiology by the pathophysiology as we just described. One thing I want to point out that the inciting event appears to influence the prognosis, and bacterial sepsis portends to a very poor prognosis, whereas direct liver injury generally has a better 30-day survival. ACLF organ failures grade by itself predicts mortality. ACLF is a dynamic process. Changes in scores from 48 hours to day 5 to 7 are highly predictive of improving or worsening prognosis. So this is important. That window period is very, very important. And a second bacterial or fungal infection in ACLF grade 3 patients portend to a very, very poor prognosis. So suspected ACLF, once we diagnose, should be transferred to ICU and the preventative strategy, particularly for infections, would be instituted right away. Empiric antibiotic therapy, I always would favor that, both covering gram-positive and negative, and those which already have pictures of hypotension, hypovolemia, renal insufficiency, 25% albumin, midodrine, norepinephrine should be considered to keep the MAP between 70 to 80 millimeter mercury range. Terlipressin may be marginally better in patients with acute renal dysfunction, particularly in the type 1 hepatorenal syndrome, the HRS-AKI variant, in the setting of ACLF and norepinephrine. Now, those with the mental status changes, we have to take the airway precautions. Those with ACLF grade 2 to 3 should be considered for urgent listing for liver transplantations. If after about 3 to 7 days from the initial presentation, they improve or they stabilize, but maintain a high MEL score, then you may consider proceeding with the liver thinking about futility of care. Patients with the grade 3 who worsen, do not show significant improvement, or patients with the lesser grade of ACLF who progress to ACLF grade 3 despite 5 to 7 days of ICU care, that's where we have to talk about withdrawal. And grade 2 to 3 who kind of stabilize at the MEL score around 25 above, they should be considered for transplant. Now, the role of albumin dialysis, particularly MARS and extracorporeal liver assist device in stabilizing patients with ACLF and bridging them to successful liver transplantation is unclear and currently recommended only as an experimental therapy as a part of approved research protocol. We talked a lot about in the talks from Dr. Sarap, and we had a nice discussion about this. And I think the utility still needs to be seen, although many centers use this as a modality to bridge for liver transplantation. And the question of GCSF, with or without erythropoietin in the setting of ACLF needs further study, but I would like to point out some of the encouraging results. The first study that was published by Dr. Garg from Surrey, Professor Surrey, showed percentage of patients who developed hepatorenal syndrome and hepatic encephalopathy or sepsis were lower with GCSF therapy. And this is a meta-analysis showing some improvement. And I would like to point out one thing, that the mortality of the ACLF grade by day 3 to 7 is very important. If you see, the ACLF grade 3 has 3.8% survival at 180 days, but no ACLF is 62%. But if you transplant them, 81% will have a survival at 180 days. So it is important to the window and get this patient transplanted. Now, one thing I want to point out, multiple studies suggest the MEL sodium score underestimate the true risk of mortality in ACLF patient, and it accounts only for hepatic and renal failure. Short and intermediate term mortality in patients with grade 2 and grade 3 ACLF is very high, irrespective of the MEL score. Now, but despite this, no special status for patients with their MEL alone is used currently for prioritization for the transplant. Now, let's look at this study from Sundaram. Now look at the point that I'm trying to highlight. ACLF grade 3 and the MEL, the orange actually connotes their MEL score is less than 25. They have a much higher mortality, and we also replicated this. I'll say this is a study where we look in a single center study. We definitely, we thought that as the ACLF grades increases, the mortality increases. But when I combine this with the MEL score with the ACLF, high ACLF, low MEL also has the highest risk of mortality. So this is actually helpful to determine who may be at high risk of dying, who may need to be listed much earlier and may proceed with the liver transplantations. This is important to understand that ACLF is driving in these patients and their mortality. Now, long-term outcomes are pretty good. Graft survival at probability at 5 years was above 90% for all groups, but however, there is a little inferior survival in patients with that higher grades of ACLF. Now, I want to also point out the renal dysfunction at the pre-liver transplantations. Now, this is a study which we just published in Clinical Translational Gastroenterology, and I want to point out that at patients who had ACLF, as compared to the non-ACLF, now they have a lower EGFR before their transplantations. Now that persists even after their transplantation. They recover pretty quick. By 3 months, the reset, they improve, as you can see in the ACLF with a low EGFR in the right side. But they improve, but they remain. Their GFR continues to remain low even at 12 months. So there appears to be a window period between 5 to 14 days after initial presentations of ACLF, and patients who stabilize and are transplanted during that period do well following that transplantation. We need to identify the care when it is futile. Now, studies have suggested mechanical ventilation at the time of transplantation has about a 10% drop. I'll take only a couple of minutes. 10% drop in 1 year post-transplant survival in ACLF3 patients. And this is very clear in this study. 1 year post-transplant patient survival among patients with ACLF3 mechanical ventilated at the transplantation, stratified by transplantation within 30 days. If you wait longer than 30 days, these patients don't do well. There is a futility score that was developed by Asrani, and they have found 5 factors: ventilator support, a recipient has more than 60, preoperative dialysis and preoperative diabetes, creatinine, and they graded with a different severity index, and they have found as the score increases, they have a much higher risk of mortality, and the futility can be inferred from this scoring system. I would, for the interest now, we had talked a lot about the ACLF from Professor Serin, and this is also very useful in terms of as they score more than 11 at baseline, they are persisting in the first week, often seen among the non-survivors, and they could help in deciding who could be a futile in the transplantation. Obesity has been found to be an increasing risk factor in ACLF patient. Frailty, important, and the higher the frailty, these patients with ACLF are more likely to be hospitalized with higher ACLF, and their survival is also long-term survival, particularly, has been found to be poor. So finally, the current criteria is actually general principle that is followed in most centers to determine the patient with ACLF is transplantable include a combination of absence of sepsis or control, absence of hypoxic respiratory or failure of control to the level where a patient could be potentially extubated, absence of pressure support, absence of features of congestive heart failure, ability of patients to follow verbal command, and assessment of frailty. These are the criteria that would help a patient who could be transplantable or not. This is my final slide, just to summarize the management of patient with ACLF. If a patient with chronic liver disease, you have to define whether the patient has underlying cirrhosis, no cirrhosis, or decompensated. You identify the injury, whether it's a direct or indirect. What if the patient has ACLF, then you grade by ACLF score. Now, if transplantable, if the grade 2 or more, transfer the patient to ICU, remove offending agent, treat the cause if possible, aggressive care with 25% albumin, antibiotic, pressure, ventilator support as needed, and minimum 3 days and maximum 7 days reassess. The patient is stable, improved, but ACLF grade 2 to 3, list and activate for transplantation. If the patient continues to worsen at the day 3 to at the day 7 maximum, despite ICU care, palliation and withdrawal care would be the ideal thing to go. If they improve, of course, they wait for their MEL score. Based on the MEL score, await an offer for the patients. And that would all I would like to point out. And thank you so much.
Dr. Satpathy, and then for your elegant lecture, especially in combining all the 3 things, NACSEL, EASL, and ACLF. It's a very difficult, in fact, you made it very understandable to us. We'll come back during the panel discussion again. With this, we'll go on to the debate on the liver transplantation in severe acute, severe alcoholic hepatitis. We have 2 distinguished speakers. One is Dr. Arvinder Swain. I mean, both the people do not require any introduction. Without having any introductions or anything, Dr. Swain is going to talk about that we should do the LT, early LT in severe alcoholic hepatitis, whereas Dr. Pamecha from ILBS is going to say that we should not do it. Let's hear from them. Over to you, Dr. Swain, please. Share your slides and then you can kick off, please.
Yeah, thank you, Dr. Rao. Good evening, all. I will just share my slides. Just give me a second. Can you see my screen?
Yeah, we can see that.
Yeah, we can see.
Right, so I will try and explain to you why early liver transplantation is indicated for selected patients with severe acute alcoholic hepatitis. Now, the three questions to ask and answer are: one, why can't we do it? Or why should we not do it? The second question is, whom is it indicated in? And the third question is, are the outcomes similar to non-alcoholic hepatitis patients? Now, majority of the people will deny alcoholic hepatitis patients liver transplantation because they're worried that with short abstinence, there will be an increased risk of alcoholic relapse. They're also worried that the outcomes might be poor. Minor reasons are, of course, there is a likelihood of recovery on medical therapy, and there is a potential negative effect of transplant of alcoholic hepatitis on donation of deceased liver grafts. And there is this notion of personal responsibility for alcoholism, and therefore justice and equity might suffer if you give them cadaver grafts. But of course, if you think of live donor liver transplantation, the last point is not so valid. Now, we all have lived by the 6-month rule of alcohol abstinence, and between mid-80s, when this rule came into being, about 35 years ago, and until the late 90s, this was really stuck onto by everyone all across the world. But then, as long back as 15 years ago, people started questioning it. People said that, especially in this French consensus conference that was held in 2005, they said that 6-month period is not sufficiently evidence-based. There are other factors involved in alcohol relapse. And as recently as last year, there was a consensus conference on liver transplantation for alcoholic hepatitis in the US, where the recommendation was that a fixed period of alcohol abstinence is not required. And there have been scores of papers which say that 6-month period on its own does not prognosticate alcohol relapse sufficiently for us to all stick by it. Now, what does then tell us the story of the future? People have tried to look at factors that might predict alcohol relapse and tried to do scoring systems. At Hopkins, they've done a score which relates to some protective characteristics like self-admission to hospital, low level of drinks per day before abstinence, having insight into diagnosis, having a stable marital status, and abstinence prior to liver transplant. And then at-risk characteristics like psychiatric comorbidity, history of substance abuse, failed rehabilitation attempt, family history of alcohol, unemployment, and so on. And there's another score called the SALT score, which is a sustained use of alcohol after liver transplantation. Again, that depends on history of non-THC illicit substance abuse, prior alcohol-related legal issues, and the number of drinks per day and failed alcohol rehabilitation. So both these scores and a couple of other scores are actually pretty good with negative prediction, in the sense that if all these characteristics, the bad ones, are absent, then you can say that relapse is less likely. But if they are present and if the scores are high, that does not predict relapse reliably. So the positive predictive value is low. Who are the candidates for liver transplantation in this scenario? Well, this whole story started in 2011 when there was this seminal paper by Philippe Mathurin from France, where they thought that people who had this first episode of liver decompensation because of alcohol without any known chronic liver disease, if they had not responded to medical therapy and if they had high Lilly scores, then they had a survival of less than 30% at 6 months. So they took up 26 of these patients across 7 centers, 6 in France and 1 in Belgium. And these people with first episode of alcoholic hepatitis, if they didn't respond to medical therapy, which was given at a MADRI score of 32 or more, and especially if they had then a Lilly score of more than 0.45, they were put through an emergency or a semi-urgent transplant without sticking to the 6-month or the 3-month rule. In fact, without paying any attention to the abstinence part. And basically, they showed that there was 77% 2-year survival among 26 patients who had transplants for acute alcoholic hepatitis, and just 23% among another 26 matched controls who did not have liver transplantation, who were managed with medical treatment. So, and the recidivism among patients who were transplanted was about 11.5%. Just 3 patients had alcohol relapse. So this was the paper that had all the heads turning back to looking at whether these patients should have transplantation. Now, what do we do at Medanta? Let's show you some data from our hospital. Among 3,000 odd adult liver transplantation done so far, about just over a fourth of our patients have alcoholic liver disease. And we have this abstinence protocol right from the beginning of our program. If we have patients with end-stage liver disease due to alcohol, whether it is progressive or stable with history of decompensation, we do insist on an abstinence of 3 months or more. But if we have patients with severe acute alcoholic hepatitis with a high MELD and a Maddrey score of more than 32, we do consider them for either medical treatment with steroids, if suitable, or liver transplantation in selected patients, independent of the abstinence period. So our protocol for liver transplantation for SAH is first episode of liver decompensation due to alcohol, jaundice with high SGOT, no known chronic liver disease, and failure of medical therapy. Commitment to abstain permanently. Positive psychosocial assessment by the psychiatrists and the medical teams, that's hepatologists and the surgeons, and good family support. Absence of major comorbidity, and absence of ascites, absence of sepsis. I mean, treated sepsis is okay, but florid sepsis, which is untreated, is not. So we have actually published our experience with 39 patients who had liver transplantation for alcoholic hepatitis. And we had 39 among a total of 500, among a total of 1,706 liver transplants, living donor liver transplants done in the 7-year period from 2010 to 17. All these patients had right lobe grafts with good GRWR, and there was no definite abstinence period considered. So this is another representation of the patient cohort, a total of 1,700, 500 ALDs, out of which 101 we thought preoperatively had clinical alcoholic hepatitis, but only 39 of them proved to be so on histology of the explant. So on the explant histology, we considered all these features to actually diagnose them as having alcoholic hepatitis, steatosis, focal ballooning, neutrophil infiltration, hyaline bodies, and pericellular fibrosis. Now, looking at the preoperative characteristics of patients with SAH, obviously they were a younger lot. They had high MELD and child scores, and they had a Maddrey score of more than 53, 38 to 73. Comparing this cohort of 39 patients with alcoholic cirrhosis in 461 patients, again, the alcoholic hepatitis patients were younger, the child and MELD scores were higher, and post-transplant, they had a higher incidence of infections compared to alcoholic cirrhosis. Now let's look at abstinence and relapse. 3/4 of our patients had less than 6 months abstinence. About a third of them had less than 3 months abstinence. And we had 5 relapses. That's just under 13%. There was just occasional slip or relapse in 1 and significant relapse in 4 out of these 5 patients. And the relapse was not actually related to the abstinence in any way. This incidence of relapse was very similar to our other publications where we found an incidence of around 10% relapse in these patients. And in this group of 39, we had a survival of 85% at 24 months. We lost 6 patients, 3 early and 3 late. And again, the mortality had nothing to do with the abstinence. There was no correlation. And compared to alcoholic cirrhosis, the alcoholic hepatitis patients had very similar survival. The others have actually found the same thing, that they have excellent survivals between 70 and 90%. and relapse rates of around 3 to 23%. And a recent series, I mean, these are all single center series. This is, of course, not, but these two are single center series. And this is 12 center US series, which had 147 patients, where they found 1 in 3 year survival of 94 and 84%. Relapse was 34%, that means any alcohol, and harmful amounts of alcohol, and 11%. And in this LDLT series, living donor liver transplant series, again, in about 100 odd patients from Korea, they found that less than 3 months and more than 3 months had similar relapse rate. And there was no relation to the abstinence period. So how many centers actually do this? I actually posted this question on the Liver Transplant Society of India members group, and nobody said no. I've had like about 25 yeses that yes, we would do it in selected patients. A couple of years ago in France, there was a survey and nearly everyone would do it. And in the US, there was a similar survey where 28% centers had actually done it, 50% were open to doing it, and 81% were neutral. So there is a huge conversion happening across the globe, and these patients are being accepted for transplantation. So to conclude, those with SAH that do not respond to or are unfit for medical treatment, especially with high Lilly scores, have a less than 30% chance of making it to 6 months. So these patients must be considered for early liver transplantation. Of course, there have to be strict selection criteria. And relapse rates are 10 to 34% with around 8 to 15% harmful drinking, which is the same as with the 6-month rule. An improvement of candidate selection to predict alcohol relapse after transplant is definitely needed because we don't know which patients will actually relapse. And so quite clearly, living donor liver transplantation for alcoholic hepatitis can be performed in selected patients with good outcomes and acceptable relapse rates. Majority would do it even with deceased donors, but obviously in terms of competition among different types of recipients, these recipients may not receive priority. Thank you very much.
Thank you, Dr. Ravinder, for an excellent talk and then convincing us that early liver transplantation. Now let's hear from Dr. Virendra Pamecha from Institute of Liver and Biliary Sciences about why early transplant may not be helpful or not to be done. Dr. Pamecha, please, over to you. Share your slide. Dr. Swain, unshare your slides, please.
Yeah, sure.
Yeah.
Just give me.
Yeah, please.
Okay, thank you very much. Thanks a lot, Dr. Rao, and thanks a lot, Professor Singh, Professor D'Souza, Sumi Mudirima, and Dr. Swain has actually put forward a very good case for doing transplant for alcoholic hepatitis. So, can you see my slide?
Oh, no, not as yet. Please, I have to share the slides. Your voice is working.
Okay.
So you need to share your slides.
Yeah. I'm getting on.
Yeah.
Can you see now?
Yeah.
Oh, yes.
See my slides now?
Yes. Please go ahead.
Okay. So Dr. Swain has put a very good case for doing transplant for alcoholic hepatitis. Just about the title, he's moved on to the selection. Actually, title didn't say about selection, and a title actually also didn't say about severity of alcoholic hepatitis. So not every patient with alcoholic hepatitis actually require transplant. That's a very important baseline to start with. It has been shown very well that the only ones with hepatitis with a Lilly score of more than 0.45 will actually require liver transplantation. And there are good number of patients who will respond with alcoholic hepatitis. That was again seen in that paper, the landmark paper from French and Belgium study, that there will be a good proportion who will respond to medical therapy and they may not need transplant. So we need to select out those group of patients who will need transplant. And medical therapy over time has improved. A few things which have been happening, like CSF, fecal microbiota, and liver assist device, which can help a lot of patients in actually overcome the acute period, and they may not need transplant immediately. Now, coming to selection part, which is the most important thing, and what has happened in the literature is there has been a lot of cocktail happening in terms about alcoholic hepatitis, decompensated alcoholic cirrhosis, and acute on chronic liver failure. That's where actually we get a very poor picture about exactly what is happening in terms of selection. And when we see this landmark paper again, this was based on a selection, and this was based on a very stringent selection. And if you apply very stringent selection, only 7.7% of this patient were eligible for liver transplantation, and actually only 2% of them got transplanted. So there has to be a very stringent selection, and if you apply that criteria, there are not many actually who will fall into that group. And when we look at this paper more closely, they have shown only very short-term result, about 1 year. Long-term results are not there actually, and this paper has been there now 10 years in the literature, and the group has still not shown us what was the long-term outcome in terms of relapse and recidivism. So we don't know that. Then we well know that previous studies on alcoholic liver disease and liver transplantation has shown a relapse rate of 25 to 30%. And this does have a great impact on what is going to happen, which is what I'm going to show you later on. Finally, reproducibility of the same result. Again, when people applied the stringent criteria, not many centers were successful. Actually, in UK, when they applied this, there were none of the patients they could recruit for alcoholic hepatitis study they wanted to do for liver transplantation. And this is where the crux of the things are, that it's very difficult to select this patient. When you look at this US experience, where the criteria were expanded, and clearly when they expanded the criteria, the relapse rate were much more. That went up to 30%, and the harmful drinking was around 15% as well. So when you relax, there are more patients going to drink, and they do go on to have harmful drinking as well. So US criteria did show that there was much better survival, but the incidence of relapse was much higher, and the first drink after a transplantation was much earlier as well in compared to the French-Belgian study. And when we look at the meta-analysis which was published in 2018, and this is very interesting actually when we look, and these are 11 studies, and if you look at the number of patients which are there, a very small number of patients. And can you make a conclusion, hardcore conclusion based on this small number of conclusion that we should just transplant right, center, and left on alcoholic hepatitis? I'm not sure about that. And then when you look at the way the alcoholic hepatitis is diagnosed here, again, there are lots of those, almost 3 or 4 of the studies are based on explant histology rather than actually preoperative criteria set it down. And then when you look at the duration of abstinence, it varies from 15 months to 10 months to less than 3 months. So there is no consensus. There is nothing you can draw from this meta-analysis that whom should be transplanting and whom we should leaving out. So there is a very variable in terms of in terms of patients being recruited into various studies. So that is shown in the results of meta-analysis as well. So if you see, the overall relapse rate is 22%. And when we take clinically severe alcoholic hepatitis, the relapse rate is 20%. And even when we take it up to stringent criteria, then it is 40%. And the recurrent harmful drinking is 13%. One in five will actually, 1 in 5 will go on to drinking, heavy drinking, and then loss as well. And this is all based on follow-up of 1 to 3 years. There is no long-term follow-up of this patient who has been transplanted for alcoholic hepatitis. So we are drawing conclusion on a very limited follow-up, and we all know as the period increases, more and more patients are going to go on to drink. So what is the problem with alcoholism? Alcoholism and alcoholic hepatitis are two entities. You can treat liver failure by liver transplantation, but you cannot treat alcoholism by transplantation. And alcoholism has an impact on an individual, family, other patients who need liver transplantation on waiting list, and it also has an impact on the society as well. So when you make a decision, you need to be very careful in terms of what we're doing with this patient. In terms of coming to recidivism impact of individual, it is very clear that relapse is associated with accelerated graft injury and early mortality. It is also associated with other comorbidities like cancers and cardiovascular disorders. So it does have a direct impact on an individual. And this is a very interesting data from France, transplanted for alcoholic liver disease. and there was severe alcohol relapse in about 18% of the patient. And the ones who relapsed and went down to develop cirrhosis, nearly 65% of them died. The ones who didn't have cirrhosis, nearly 40% of the patient actually died. And this is long-term results. These are results about 15 years. So we're talking about, this is the actual scenario of patient who is being transplanted for alcoholic liver disease. Then one main criteria Dr. Sain emphasized on abstinence and recidivism. Whatever we take, a period of abstinence is associated with what is going to happen in terms of relapse as well. And this has been shown that when you have sobriety before transplant, it does reflect in terms of happening after transplant. The longer the period of sobriety, the lesser the chances of having alcohol relapse after transplantation. This has been very well documented in the literature as well. Now, why abstinence? Why you need an abstinence? This is basically to allow liver to regenerate, and then you may not need a transplant. It also allows patient to show a commitment that they are going to remain abstinent after transplant, and it gives an opportunity to apply for preventive strategies in terms of psychosocial support as well. And 6-month rule, I agree, it is outdated, it should not be. But then what are the criteria we need to transplant? And these are extensive criteria which Dr. Sayan also emphasized on. But currently, we don't have that robust system to evaluate all this criteria. He also emphasized on the study, SALT study. Again, this is not validated. This is applied to DDLT patient. This is for West, and it has not been applied to the LDLT or ethnicity. May actually have a different impact in terms of outcome and also in terms of psychosocial behavior. So we can't take on from that particular study. Then in terms of impact of recidivism on other patient waiting, we all know that we've got a limited resource and it has to be distributed properly. So we can't do injustice to the other patient in terms of transplanting patient with alcoholic liver disease who will have a high rate of relapse as well. And this is the best example which has been there. George Best, football player who was transplanted for alcoholic hepatitis, had recidivism and died. And the organ donation rate actually decreased dramatically in UK after that. And then it took a time to recover from for the organ donation again to come to normalize. And this is an interesting paper which was published in order to take a public opinion. And it again showed that the people are very clear in terms of concerns of recidivism and leading to graft damage. That was 85% had concerns about graft damage after if we give liver to patients with alcoholic hepatitis. Live liver donor, we can say that it is a gift, but again, it comes with lots of things. In terms of voluntary, we all know that Indian families and also otherwise as well, there is always a pre-pressure about donation. Then again, proportion of patient who would be suitable for donation is always a question. And then there is always a definite risk of morbidity and mortality for live donors. And now we have nuclear families, so we now try to extend the criteria for donation, and that may actually increase the risk for live liver donor as well. Our own experience, we're now 700 transplant, out of which about 225 we have done for alcoholic liver disease, mainly for CLD. We also don't follow 6 months rule. We go with 3 months for a CLD, but ACLF and alcoholic hepatitis we are not looking at. Just two last slides. That's it. And we've seen that with ACLF and alcoholic hepatitis, there is more chances of recurrence. So these are the issues which I have discussed in terms of transplanting patient with alcoholic hepatitis. Early, I'm not sure. Medical treatment still has some value. We don't know how to select them. Abstinence and recidivism go hand in hand, and we need to be careful. There is a social justice issue with DDLT. Public perception is important because organ donation can only happen when public is happy to donate organs. And there is an associated live donor risk with live donor liver transplantation. So early, I'm not sure, but in a highly selected patient with severe alcoholic hepatitis, with failure of medical therapy, maybe there is a reason to transplant them. That's where I will land it. Thank you very much. Thanks a lot. Sorry, I ran a bit over. Thanks a lot.
Oh, no, thank you very much. I think all of you will agree with me that both of them have put up very, very convincing in their own way. Whatever the personal views are there, but this is how a debate should be there. And we will not go into the, pardon me, if we will not go into the traditional additional rebuts, and we'll have it during the panel discussion. Can we have the panel, please? Dr. Samir Shah, Dr. Naren Chaudhary, Dr. Vivek Vij, and Dr. Anunanshu Behra. First, I will start with Dr. Naren Chaudhary. Dr. Vinendra said that about the commented about the medical treatment. Suppose if your medical treatment is effective, you will send less and less people for the transplant. So, are we shying away from steroids? Are we not giving enough of consideration for the steroids? Over to you, Dr. Naren.
Sir, this is true that we shy away from using steroids. So generally, when we say that Indian patients are poor candidates for steroids, it is more of an opinion than a data-based statement. So in a study from ILBS published in Hepatology 2019, out of 430 patients, they could use steroids in 30% of patients. That is a significant number. And they noted improvement in 75%. It is more than what is reported in literature, but definitely we shy away from using steroids in patients with alcoholic hepatitis.
Dr. Pamecha, can you stop sharing your screen?
Okay. Sorry. I will. Yes. Yeah. Is it okay now?
Thank you.
Good.
You're trying to indoctrinate the audience.
No, Dr. Sai. Dr. Sai, just about the thing you said about, on the WhatsApp, you tried to get the opinion. And I thought I lost the debate. But then Dr. Mathur did put one important thing, and nobody shared on that nobody showed the results of what was the outcome of patient being transplanted with alcoholic hepatitis. So that gave me a bit of this one that, yeah, I got a chance.
Well, I am not guilty of that. I shared my outcome. So.
Anyhow, inadvertently, rebuttal has also happened. Right? Okay. Yeah. Now we'll go to rest of the discussion will be on the transplant, both in ACLF and this one. Dr. Samir, can you tell us about the ACLF in Indian scenario?
So we have looked at we have looked at our data at the Global Hospital in Mumbai. So in 2018 and 19, in our liver ICU, we had around 520 admissions, out of which around 202 were ACLF by Western criteria, the CLIF criteria. If you see the APASL criteria, in 2018, 20 patients have fitted with the APASL versus 100 who fitted in with the CLIF consortium criteria. So the APASL one is definitely much smaller number, which we see compared to the Western, the CLIF consortium definition of ACLF. As far as transplant is concerned, most of our ACLF patients were ACLF3, almost 70% were ACLF3, and yet we could transplant only a very small number. So only 20 patients were transplanted. We usually do around 50 to 75 transplants a year. So over a period of 2 years, only 20 of these ACLFs were transplanted. And the survival also is lower compared to the quoted figure of 80% in the West. Our survival was 63%, whether multi-drug resistant infection or sarcopenia or frailty, whether all that plays a role, we are prospectively looking at in our group of patients.
Thank you. As I've seen that timing is very important here. The window period, you have to do it within the window period. Yet the patient should not have developed the infections. That's the most difficult part. Dr. Vivek, please, what are your ideas on both ACLF and also alcoholic hepatitis? Both of you can give your opinion, please.
Thank you, Dr. Rao. I really enjoyed the talk by Dr. Swain and Pamecha. Regarding ACLF and alcoholic hepatitis, the talk was early transplant in alcoholic hepatitis. Basically, almost the same scenarios. So I want to just point out one thing that I personally in my unit would like to do transplant for patients, even for alcoholic hepatitis who need transplantation. There are many reasons for that. I think the most important, I think Pamecha and Dr. Swain also mentioned that once we rule out that these patients don't need transplant or rule out the futility, rest of the patients, you look at a situation, practical situation, a patient is lying in your ward with severe acute alcoholic hepatitis without any contraindications. Now, what do you do for that patient? the whole family wants transplant. We are not on a moral ground here discussing that what would happen. And there is a lot of data for and against recidivism as far as the time period is concerned. So our first priority should be to save life of that patient. That is my concern about saving the lives for a transplant patient. And same goes, consider the other diseases like NAFLD. Well, NAFLD is also a self-induced disease. Why do we offer transplant in and out for NAFLD? Now, there are many diseases in which we offer transplant, but when the situation like acute thing happens, we have no choices. The situation is different in DDLT scenario, I agree, because one organ is shared by many, but my view is we should go ahead with the transplantation if the patient requires and there are no contraindications.
Thank you very much. Dr. Sanjay, what's your opinion about severe alcoholic hepatitis? What do you follow there?
When we talk about alcoholic hepatitis, I think we've been moving from not transplanting them, like we're waiting with a strict criteria of 6 months to a no criteria, like a no waiting period. I'm saying no waiting period over this last couple of years, especially as Dr. Soin pointed out, that particular the Mathurin study, kind of eye opener for everyone. Now, with the accelerated study further showing that the survival is good, I think more and more centers are now willing to transplant patients early with alcoholic hepatitis. In our center, we follow very vigilant criteria, a little bit stricter, at particularly in our center where I am working. We like to see this patient to have a first decompensation event. If they have a multiple decompensation events, we would like to have we'd like to see a good social support system, a strong family support, and a commitment. I think an insight that we need to assess is it's very important to understand the patient is committed, and we have to find out that inside the patient understands this is a problem, and then he is trying to reform himself. I think this only comes with the conversation. It's always a complex situation, but we're more and more open and started doing considering patients for early liver transplantations in our center.
Thank you, Dr. Vinendra. Dr. Pamecha, let's forget about the debate. Let us forget about Dr. Swain for a moment, right? What is your personal view in the sense that you just know we had, so many alcoholic hepatitis series have been there, in ILBS center. Surely there must have been cases, which required transplant.
Yeah, I partly agree with things that there will be a patient who need an emergency transplant or an emerging transplant for alcoholic hepatitis, and we all. But every time we do an assessment, this psychosocial assessment, and then we find that there are lots of issues with the patient, and this a typical binge drinker who has come first time to the hospital with alcoholic hepatitis, that is a very rare thing to happen. Most of this patient actually have been defaulters. They've been drinking after knowing that they have got a liver disease, and these are the ones who actually go on to drink after transplantation. And you need to be very careful, because the one who knows that I've got a liver disease and still drinking, these are the ones who actually who default. And to find a patient who actually hadn't stopped drinking after knowing, and especially coming for an acute transplant, this are actually difficult to decide whether we should do or not. We've done few, and as I showed typical alcoholic hepatitis, out of 3, 1 got recidivism and he died as well. We've done quite a few ACLF in terms of, then they had a period of observation. They had a certain period of abstinence. We don't go by 6 months. We never actually applied 6 months rule. We go with 3 months, and we had quite a good proportion within CLD as well, where we have actually bridged the 3 months line as well. That looking at the patient profile and his commitment to remain off alcohol. But to, in an acute situation, to find somebody with, an ideal alcoholic hepatitis to go for transplant, if you apply proper criteria, there are very few who will actually be eligible for that.
Thank you very much. I think we should conclude now by summarizing, because it's already we are beyond time. Concluding that both ACLF, the timing is very important in that sense that the as I told already, that it has to be done within the period and also identify who are likely to be benefited without the infections. And alcoholic hepatitis, I think, is more and more gaining ground as we gain more experience, and then more people. I think that people will go in for the early transplant, provided all the strict and selection criteria are taking place. Over to you, Dr. D'Souza. Thank you very much. I thank all the speakers for an excellent job and the participation by the panelists. Over, Dr. Ajay.
Yeah. So, really want to say something, or should we go ahead?
I want to thank everyone for this wonderful session.
Okay. Thank you.
It's time to close. Thank you.
Okay, I think all good things do come to an end, and I think we've had a real academic feast, as well as I say, because I think these 2 days I was just listening and learning rather than speaking or doing other things. So it was really an academic feast. But to formally say thank you to all, first I will invite Dr. Virender Singh, organizing chairperson, and the professor and head of hepatology, and then I will say few words to thank you all.
Ajay, will these be available for the future for the references in the YouTube?
Yes, yes, all the recordings would be available. Yes.
Good. Thank you.
Yeah. See, this was a power-packed meeting, like 2020 match, and still it is around 11 p.m. and the speakers and the panelists are still busy. This is all happening because the speakers, the faculty, the international faculty, the very important international faculty, Scott Friedman, Saggio, Paolo Angeli, then Yonasi, Dr. Tulubat, then we have Dr. Sanjeev Arora, Robert Gage, Aswini Shingal, then Chan, then Dr. Sandeep, Dr. Pramod Guru, and Dr. Satpati. So, and the Indian experts, Dr. Nageshwar Reddy, then Dr. Sareen. It will be difficult to name all, but all the Indian faculty and the Indian panelists and the international faculty, they did a marvelous job. And we enjoyed sitting in the lecture theater 1 here all through without any tea or coffee, although Ajay is having tea or coffee at home.
Yeah.
But I chose it and then made it a hybrid meeting. See, it was really enjoyable here. Hybrid meeting we conducted. I think this is an example. I never felt that this is a virtual meeting. I felt it is like a physical meeting here. So it was a great meeting, and the whole credit goes to the Department of Hepatology, especially Dr. Ajay, Dr. Sunil, then Dr. Nipun, Madhumita, Arka, and all our residents, and the help given by pharma companies. With that, we come to an end. Thank you all. Thanks a lot.
So thank you, sir. I think I'll just take maybe 2 minutes to again thank some of the people. I must confess, in the beginning here, I thought that the virtual meeting would actually be an easy task and would be easier to manage, but I was wrong. I think it really takes your time and really, takes your, efforts to really organize even a virtual meeting. And this is all message to all of those who are planning to maybe organize a virtual meeting in next, few months or weeks or whatever. And it really required a lot of efforts, I must say. And for this, I need to thank that this was not possible alone or even 1 or 2 people. This was a team effort. And the team was nothing but our departmental faculty, led by Professor Virender Singh and helped by Dr. Taneja, Dr. Madhumita Prem Kumar, Dr. Nipun Verma, and Dr. Arka Dey. I think all did their bit, and I think finally we could manage, and finally we could do, and what you could see was a combined effort. And this has been ongoing for, I would say, more than a month now. But I think finally, I think the end product I thought was acceptable. Other than, I think, the organizing committee, I also need to thank my residents. I think they have been throughout, and I'm sure if they're sitting in the hall, the residents are also there. But for the hypoglycemia, I think probably they had a better academic fees, but I'm pretty sure they were obviously, I think, the lack of, what I said, the refreshments in between and the other breaks. Other than that, I think has already been said. I think we are thankful to the international faculty. I think not only that they agreed on a very short notice, but then for some of them, even the timings were very, very odd. I think some of them, it was 4:30 in the morning or 5 o'clock in the morning. And in spite of that, they were as fresh and as good. And I think, I don't know what is the time for you, Sanjay, there, Satpati, but I think some of them, Ashwini Singhal, yesterday it was 4:30 for him in the morning. And he said, and it was bright as ever. So I think, and to all the national faculty, I think, but I again must confess here for the national faculty that since most of the talks, we had a lot of international people, went to the international speakers, and we could adjust the national faculty as moderators or panelists. But in spite of that, I think everybody gave a real active participation. There was hardly any miss, or maybe one or two misses here and there. I think real thanks to the faculty for your, the active participation. I think obviously delegates are the key for any meeting. And let me now tell you the figures here. We aimed at 3,000 registrations, and we could achieve 2,758 delegate registration. And plus, if you add 125 faculty, so we are close to 2,900. So we could reach their 2,900 registrations, I think, which is, I think, is a good figure. And we have had logins also, which were, very, very high. So I think thanks to all the delegates again for joining us for this virtual meeting and for their active participation. But my, I think I would like to acknowledge here that we could not involve the delegates, so much because of the paucity of time. We could not take out their questions. I think that was one drawback, which we have to accept that, because the chat box questions were there, but because of the lack of the time, I think we couldn't really, respond to their questions. But if you have any questions, I think you can certainly email it to us, and I think we will try to answer those. Finally, I think pharmaceuticals again have been said. I think whatever little contribution they did, I think they could actually give us the real, I would say, even though it's a virtual format, I think, but people could enjoy that feel of that physical meeting, getting into the conference hall, exhibition hall, and other things, I think, and for that. Finally, I think this would not have been possible by our conference managers, which are the Maisha, and I will request all of them to switch on their videos if Shifali is there, Garima, Rahul, all of them if they are here, and Amitabh and Prateek and Shobhankar. I think they did an excellent job, and I must tell you, the backbone of any virtual meeting is nothing but a good audio visual. And good audio visual, I think, which they provided the platform. I think thumbs up to them and hats off to them. And I think we have to have 3 cheers for them. I think they did a wonderful job. And here in PGI, Tarun managed, the connection between the virtual team in Delhi versus the Tarun managing here the lecture theater. So thanks you, Tarun, again for making this a good hybrid meeting, and thank you very much. I think again 3 cheers to all of you. Finally, I think my thanks to my family also. I think because I had some other issues also in last week, 10 days, little tied up with some of the academic things, but then ultimately I had to take out time out from my family time. So my thanks to them. So thank you all, and we look forward to having you all and seeing you next year, hopefully in a physical meeting of CPLD 2021, which would be held in Ames next year. And thank you all, and good night. And thanks for being with us till 11 p.m. in the evening. Good night. Thank you.
For that, we will have another meeting of International Club of Ascites,
Sure.
and it will be somewhere in February. And we'll have a lot of time, and we'll give the chance to delegates also. So wait for that.
Yeah, sure.
We'll call all the experts on ascites. Thank you very much.
Thank you. Thank you all. Please, you can log off now.
Thank you, sir.
Thank you.
Good night.
Good night. Good night. Good night.
Thank you very much.